Okay, the WhatsApp's gone through, but I'll just see when he replies.
Hello, everyone. We are live now.
Good evening, colleagues and friends. I welcome you all to this webinar on cutting edge in uveitis. It's a very interesting program which has been designed, I guess, by Dr. Partho to touch upon some of the most exciting frontiers shaping contemporary uveitis practice and touching upon some of the research issues. One of the major challenges in uveitis has been the management, where either you fail to detect uveitis very early, especially during the recrudescence or recurrences, but also people have a tendency to prematurely taper immunosuppressive therapy before actually the inflammation has fully resolved or died down. So I hope Professor Alejandro Marchis will be discussing some of the challenges in detecting the subclinical inflammations in uveitis which escape us all in practice. This is to be followed by Professor Derek Smith. Now, he is coming from a very interesting place in Cape Town, South Africa, which is a global epicenter of three biologically and socially intersecting what we call syndemic infectious diseases that includes HIV, syphilis, and tuberculosis. So he'll be providing us insights on immunology of ocular and neuro syphilis, and it involves a complex, I believe, interaction between the ocular infection, immunity, and a systemic disease. Our third lecture by Daniel from Brazil, where I guess every fifth patient in the uveitis clinic they see is suffering from toxoplasma. And I think their group is one of the global leaders, especially they have done some trials in prevention of congenital toxoplasmosis, as well as in syphilis research. So I think he is going to be talking on how they manage and prevent occurrence or recurrences of toxoplasmosis in Brazil, because they are no doubt the global leaders in this particular disorder. And Dr. Ilaria would be discussing one of the most practical and rapidly evolving question in daily practice in modern day management of uveitis. What drug to choose, what is the right time, and how do we move, from corticosteroids to biologicals and what biologicals. I will be touching upon, I very, very briefly touch upon, it's a huge subject of what are the emerging frontiers in uveitis research and therapy, and looking at maybe we may not see these in the next few years, but certainly over the next 10, 20 years, they would become part of the routine clinical practice. So on behalf of the organizers, I once again welcome you all to this webinar, and thank you for joining us, all the attendees as well as the faculty. And I hope this session stimulates some ideas, discussions, and maybe it will lead to some development of some collaborations across the globe in the uveitis community. Thank you very much, and Partho, back to you.
Thank you, sir. So now I'll be introducing the guest we have with us today. So is my slides visible?
Yeah.
So welcome everyone once again to this cutting edge management in uveitis. So I'll be just introducing the faculties for today. Our first panelist of faculty is Professor Amod Gupta, who needs no introduction. He is a teacher of the teachers, and we call him Dronacharya of Indian ophthalmology. So his main area of interest is retinal and uveal eye diseases. He contributed significantly to the discovery of new diseases, their clinical manifestations, and new management strategies, bringing a paradigm shift in the management of several blinding diseases. He described a new disease, tubercular serpiginous like choroiditis, now recognized worldwide and successfully treated by all of us. He discovered that the contaminated glucose infusion as previously unknown risk factor for developing fungal endophthalmitis in otherwise healthy young individuals. His work on the use of atorvastatin in managing the diabetic maculopathy is extensively cited in the contemporary literature. He is the founder president of Uveitis Society of India and an ex-president of VRSI. He has published 425 original articles in peer-reviewed journal, which are extensively cited, which he has a H index of 56 and 12,307 citations. So with several awards and named oration to his credits, he was awarded Padma Shri by President of India in 2014. Our next guest is Alessandro Marchesi. He is a consultant ophthalmologist and head of the UVA services at Ferrero Hospital, Italy. So he graduated in medicine from University of Turin in 2014 and completed ophthalmic residency at University of Vital Salute San Raffaele, Milan. He received short-term training in uveitis and retina at PGI Chandigarh. He completed his retina and uveitis fellowship at Northwestern University, Chicago. He is a fellow of European Board of Ophthalmology, author of 100 peer-reviewed international publication. His research interest includes uveitis and retinal disease. He has served as editorial assistant for the European Journal of Ophthalmology. And interestingly, and we are very proud that he is life member of Uveitis Society of India. Welcome, Alexander. So our next guest is Daniel Vasconcelos Santos, who is head of the ophthalmology at University's Federal de Minas General. He is an elected member of International Uveitis Study Group and American Uveitis Society. He is president of Brazilian Uveitis Society and executive board member of GOIWS and International Ocular Inflammation Society. He is international consultant for American Academy of Ophthalmology Basic and Clinical Science course. He is author of 120 plus peer-reviewed manuscripts, 80 plus book chapters, and 120 abstracts. He has delivered nearly 200 invited presentations at national and international scientific meetings. He is in editorial board of several leading ophthalmology journals. His research interests includes tropical ophthalmology, infectious, non-infectious uveitis, muscular syndrome, retinal vascular disease, ocular inflammation models, ophthalmic pathology, and telehealth. Welcome, Daniel. So our next guest is the Derek Smith, who is Associate Professor, Division of Ophthalmology, Stellenbosch University, Cape Town. He is a South African ophthalmologist with nearly 30 years of academic and clinical experience. His expertise includes intraocular inflammation, ocular tuberculosis, ocular syphilis, and viral ocular infections. He has special interest in novel diagnostic technique, particularly the HIV positive patients. He is author and co-author of 80 plus peer-reviewed publication and multiple book chapters. He is co-editor-in-chief of Ocular Immunology and Inflammation. He is a supervisor of more than 20 postgraduate students and invited speaker at various national and international conferences. He is active in community outreach initiatives in South Africa. Our next guest is Ilaria Testi, who is a consultant ophthalmologist specializing in uveitis and ocular inflammatory diseases. She is member of uveitis service at Moorfield Eye Hospital, London. She works in pediatric uveitis service at Great Ormond Street Hospital for Children in London. Over 10 years of clinical and academic experience in ocular inflammation. She has also received international training experience in India and Singapore. She has completed fellowships in uveitis and pediatric uveitis from London, and she is author of 70 peer-reviewed publications and 10 plus book chapters, and her research interest includes uveitis and ocular inflammatory diseases. So I welcome all of you, the panelists and the guest here. First, we'll start with the presentation on the Seeing the Invisible, Detecting Subclinical Inflammation in Uveitis by Alexandro Marchesi. I'll request the backend team to share the presentation of Alessandro. Can you share the presentation? Backend team?
Symposium. I'm sharing, sir. Sharing, sir. Sharing.
It's named 2026 AIOS Imaging Symposium.
Yes, sir. Sharing in seconds. Yeah, it's here.
You can mute. Yes.
Wait, sir. Give me a second.
Open Microsoft PPT.
Why is my hand in a PPT?
Please mute at your end, Sunilji.
Sure, ma'am. Sure. Office slides.
But Professor, can I help in any way?
Below that fat pad, you can always say relationship from a
I can share if there is any problem.
Can you share?
I think it's the slides are visible.
Yeah, it's slides are visible, but it's in slides, so I'm not able to sharing now. It's not a PPT. That's why
I see, Partha, so we can have
Yeah,
it.
I'll share. I'll share just a
Sure,
minute. Just unshare. Can you stop sharing?
Good afternoon, everyone, and thank you for the great invitation. It's a pleasure for me being here with you. The title of my talk is Seeing the Invisible, Detecting Subclinical Inflammation in Uveitis. Let's start with the cases. The first patient is a 12-year-old healthy Italian girl who presented to us because of left eye visual loss. As you can see, the fundus really looks normal. However, when we obtain an OCT, you can see there is significant macular edema in the left eye, while in the right eye, there are no significant macular abnormalities on OCT. At this point, we had to go back to the anterior segment examination to notice that there were actually some cells, but no KP. And we look again at the vitreous, and in the inferior periphery, we saw some snowballs. At this point, our workup was that for intermediate uveitis with labs and fluorescein angiography. Fluorescein angiography is very important in this patient because it may reveal vasculitis that is not seen clinically. And in this case, as you compare the fundus photos with the small vessel vasculitis that is seen on FA. And if you are lucky enough to have wide field fluorescein angiography, you can see the amount of inflammation that is present in this patient. And this is the correlation with the OCT. ICG, in this case, was normal, a rule out choroidal involvement. And the results of the labs led to the diagnosis of idiopathic pars planitis. And after treatment, you can see that there is not only a significant improvement in macular edema, but even the subclinical retinal vasculitis is much better. The conclusions of this case is that macular edema as a complication is not the disease, but is actually a very helpful sign that can lead to the detection of subclinical inflammation because it indicates active uveitis. Let's jump to the case number 2. This is the 22-year-old male from India who presented for visual loss in his left eye for a week. And his vision in the left eye was 2200, and you can see vascular tortuosity and edema of the optic disc. On OCT, you can see also intraretinal hyperreflective foci and subretinal foveal detachment as well as interretinal fluid. Is this a retinal vein occlusion or something else? If you carefully look at the OCT, you see something very interesting. There is an area with a featureless choroid and underlying choroidal hypertransmission. And this, even if it's very subtle, is a possible sign of choroidal inflammation. Indeed, when you obtain the angiography, you can see that non-FA, there are no significant abnormalities, and you can even have the impression that it is a simple retinal vein occlusion, but it is not, because on ICG, you can see these hypofluorescent spots that are indicative of active choroiditis. And the patient was testing for TB, and it resulted quantiferon TB positive. And he was treated because of this tubercular choroiditis. And you can see that after ATT and corticosteroids, he beautifully responded without any need of intravitreal injections of anti-VEGF. Let's move to case number 3. This is a female, 32-year-old with metamorphopsia and right eye visual loss for 3 days. She is high myopes, and you can see there is a CMV there. The question is this a myopic CMV? If you look at the fundus, you really don't see anything suspicious. But in these cases, you want to always dig deeper. And if you do autofluorescence, what you see, there are some area of hypoautofluorescence. They are scattered throughout the posterior pole of both eyes. And at this point, you want to have an OCT through this lesion. And if you look carefully, there is an RPE opening with hyperreflective material going into the outer retina and backscattering underlying it. And this is associated with the leakage from the CMV and mild leakage from these foci at the face and hypofluorescent spots on ICGA. And this is very consistent with the presence of inflammation and is a multifocal choroiditis. There are different signs that you can see in multifocal choroiditis, and one are inflammatory lesions, and another one are CMV. And you can not always be able to perform angiography or have OCTA. So if you just have OCT, is there any way to tell them apart? Yes. If you carefully look at the inflammatory lesions, there is underlying significantly backscattering. While if you look at the CMV, there is underlying hyperreflectivity. Let's start with the last case. This is a 78-year-old female who was on treatment for wet age-related macular degeneration, AMD. And you have seen plenty probably of this OCT. And you will probably describe as the presence of SHRM, and you advise injections. But you want to always look at OCT in perspective. Compare them with what was before there. And if you do that, in this case, the appearance is striking because this was before and this is now. And you can see some signs of inflammation. And the first one is this vertical opening of the RPE with the underlying backscattering. And the second one is a significant swelling of the choroid. And at this point, you look at the periphery because sometimes your clinic is very busy and you just look at the macula and you see all these scars and this depigmentation of the choroid. And these are all signs of previous choroiditis. And FA and ICG, they confirm the presence of inflammation in this eye. And we saw the signs of inflammation, but that eye was undergoing treatment with anti-VEGF because there was a CMV. And is there anything that suggests an inflammatory origin of the CMV? Yes, there are some signs, and one is present in this case, which is the pitch 4 sign, where you have this vertical hyperreflective lesion going into the outer retina. Another one is the sponge sign, where you have exudation not only under the retina and inside, but also in the choroid below the CMV. And the last is the shark teeth sign, where you have the classic RP opening of multifocal choroiditis inside the SHRM of the CNV. So to conclude, it's very important to recognize signs of subclinical inflammation that are visible on retinal imaging, because these signs can help you to narrow down your differentiation, execute appropriate labs, and get the right diagnosis. Thank you very much for having me here.
Thanks, Alexandro. That was a beautiful presentation and so interesting cases. So we'll come back to you with our queries and all. So next, I invite Dr. Derek Smith, who will be talking on the immune signals in ocular and neurosyphilis. Multimedia team, can you just play the video?
Good afternoon, ladies and gentlemen. I would like to start my talk by thanking the local organizing committee for inviting me to join you online from Cape Town today. My talk is entitled Immune Signals in Ocular and Neurosyphilis. In the background, we know that syphilis cases have been rising since the turn of the century, and in the USA, the CDC reported a 74% increase in cases between 2015 and 2019. As we know, the most frequent risk factors are male sex, men having sex with men, and intravenous drug use. We have identified two problems in the diagnosis of ocular syphilis that we would like to consider. Firstly is the fact that the diagnosis of ocular syphilis is based on a compatible clinic picture with positive serology, whereas neurosyphilis is diagnosed on CSF testing. The other is that people commonly say that ocular syphilis is neurosyphilis, and we're hoping to provide evidence to show that this might not necessarily be true. If we look at biomarkers in neurosyphilis, specifically the VDRL, the test was first developed in 1906, 120 years ago, and the current version dates from 1946. Yet it is still the gold standard for the diagnosis of neurosyphilis. It is said to have a high specificity but low sensitivity, with the sensitivity on CSF ranging from 49 to 87%, and the specificity between 74 and 100%, although they do say that you might have a higher percentage positive results if the patient is HIV positive. Looking at the FDA absorption, it was first developed in 1964. The sensitivity is given as between 91% and 100%, with 100% specificity. If we look at some examples of biomarkers in ocular syphilis, this is a study that we did a decade ago looking at cytokines and chemokines to diagnose syphilitic and herpetic uveitis. In syphilitic uveitis, we found that ApoA1, ApoC3, and CRP differed from other biomarkers in syphilitic uveitis, and that a 3-marker biosignature of CCL4, ApoC3, and CRP separated syphilis from other diagnoses with an area under the curve of 83%. We know that we are unable to obtain adequate aqueous sample volumes to do VDRL and FDA absorption, whereas we are able to obtain plenty of CSF, so the question arose as to whether there were any other options. Along with colleagues from the Netherlands, we used immunoblot and PCR on both aqueous humor and CSF. Interestingly, all cases tested PCR negative, which led us to question the quality of the in-house PCR. But what we did find was that 5 CSF and 3 aqueous humor samples tested positive by immunoblot. The detection of antibodies to Treponema pallidum antigens could therefore be complementary to traditional tests. If you have someone with a compatible clinical picture and their serum RPR and/or TP absorption is positive, we suggested that one might consider performing PCR and immunoblot for syphilis on aqueous humor. If either of these were positive, we would then consider that ocular syphilis was confirmed. However, if the tests were negative and no other cause of uveitis was found, one could then probably say that the patient had ocular syphilis. Looking at ocular and neurosyphilis, which we started becoming more interested in, the paper on the left is one from the BJO, which is still to date the largest case series of ocular syphilis in the world, and the one on the right was a collaboration between ourselves and colleagues from Brazil, of which Daniel Vasconcelos Santos will be speaking after me today. Just a word on the diagnosis of neurosyphilis in patients with and without HIV. The areas in the colored blocks point out that in patients with HIV infection, because they already have CSF pleocytosis as well as raised protein levels, one cannot consider those for the diagnosis alone, but I refer you to these up-to-date algorithms if you're interested in more details. When one digs deeper into the diagnosis of neurosyphilis, you'll see that colleagues in the USA and in China started looking at the cytokine CXCL13 as a CSF marker for neurosyphilis. Others added CXCL10 and CXCL8. Colleagues from China also looked more specifically at CXCL13 in neurosyphilis, and they found that if the concentration was greater than 13.36 picograms per milliliter, it would then have an 85% sensitivity and 79% specificity for the diagnosis of neurosyphilis, and it seemed to be more suitable to diagnose neurosyphilis in HIV-positive patients. It can also be used to evaluate the effectiveness of treatment of neurosyphilis as these levels come down after the patient has been successfully treated. So at this point we said, wait a minute. If you think about it, aqueous humor and CSF are biochemically very similar. And we already knew at this stage that CSF and serum chemokine concentrations differ significantly. And given the fact that we have the Luminex platform available at the new Biomedical Research Institute at our university, which is shown in the picture, we said, why don't we start looking at these different chemokines in ocular and neurosyphilis? So in a prospective study between 2018 and 2021, we had 23 participants, of which 14 were male and 15 were HIV positive, and serum, aqueous humor, and CSF were collected prospectively from all newly diagnosed patients. Of these, 14 had evidence of neurosyphilis according to the up-to-date algorithms. What we found was that the mean concentrations of all three chemokines in the aqueous humor and CSF were higher than in the serum. In neurosyphilis, concentrations of CXCL13 were similar between the aqueous humor and CSF, but CXCL13 and 10 in the aqueous humor were higher than CXCL13 in the serum. Also, if you looked at the aqueous over serum ratio of CXCL13 and CXCL10, these were much higher compared to patients with no neurosyphilis, which is what you can see in the graphic at the bottom. Furthermore, we found that CXCL13 levels were significantly higher in the aqueous humor of participants with HIV infection. So in the graphic, these patients are HIV negative, these are HIV positive, and the blue is the aqueous humor concentration. Furthermore, patients with ocular syphilis who tested negative for neurosyphilis by conventional testing showed evidence of neurosyphilis when analyzing their CSF chemokines. In a different study published last year, looking at the same cohort of patients, we now considered the concentrations of CRP, IL-2, 6, 10, 12, MIP-1 beta, and interferon gamma in, again, aqueous humor, serum, and CSF. And what we found was that all those concentrations in the aqueous humor were consistently higher than in the serum and the CSF. So if you look in this graphic here, these patients did not have neurosyphilis and these did, and yet the aqueous concentrations were much higher than the CSF and the serum. And again, looking at the HIV status, these patients were non-reactive, these were reactive, and again, the aqueous humor concentrations were much higher than of the other two compartments. So what conclusions could we make from this? First of all, we once again demonstrated a notable variation in specific cytokine levels in the aqueous humor, CSF, and serum. Here we found that the levels were raised in the aqueous humor compared to the CSF and serum, and this might suggest that syphilis induces a distinct immune response in the eye. So what comes next? We are currently analyzing normal control samples of serum, aqueous humor, and CSF to determine the normal range of the levels of these chemokines. We believe they have the potential to become dual biomarkers, in other words, diagnosing and monitoring response to treatment. We are also subjecting more than 10 other biomarkers to similar scrutiny, and we hope to ultimately determine which chemokines have the greatest diagnostic accuracy, and this will hopefully allow us somewhere in the future to develop a simple point-of-care test to distinguish between ocular syphilis and neurosyphilis, as this has implications for their treatment. I thank you for your attention.
I think that was very interesting. So I hope we will have a lot of queries, and we need to learn more from you, Dr. Smith. So next, yes. So next we have Dr. Daniel from Brazil, and we'll be speaking on the infectious uveitis unmasked, the current strategies in therapy. Over to you, Daniel.
Okay. Okay. Hi. Well, it's a pleasure to speak on a subject which is very close to our heart. That is treatment of infectious uveitis. Thank you so much, Parto, for this opportunity. As you all know, infections comprise a significant bulk of cases of intraocular inflammation worldwide, particularly in developing countries. It does affect all age groups with specificities in immunosuppressed patients. When we're dealing with a patient with intraocular infection, we have to take into consideration whether this is a primary infection or reactivation, whether we're dealing with a typical clinical phenotypes or in the context of opportunism, we may have atypical presentations. Particularly in some instances, we may deal with combined infections, especially in immunosuppressed individuals. What is very important is that even though we are dealing with the eye, all the time we have to consider systemic changes before, during, or even after the development of eye disease. Luckily, the diagnosis has significantly improved with molecular testing, multimodal imaging, but eventually the etiologic diagnosis is mostly presumed, as we are usually not able to get intraocular samples for many of these patients. So it's this presumption is based on a clinical picture, on active systemic infection concomitant to ocular disease, on results on serological tests, as well as a response to therapy. That is the subject of this talk. There's a few principles we'll have to take into consideration. First, antimicrobials are the mainstay of treatment of infectious uveitis. These are those who contain pathogen proliferation. They may be administered through various routes, systemic, oral, or intravenous, topical, or even intravitreal. However, in many or most situations, we use corticosteroids to modulate the immune response, which may be even more deleterious to ocular tissues than the pathogen proliferation itself, usually with the hint of starting steroids 24 to 48 hours after starting the antimicrobials. So we have actually the treatment. For many cases, this follows a cycle. We have the induction phase where we hit hard to kill the bug. We have the maintenance phase where we keep stable levels of the antimicrobial to finish the control of the infection. And last but not least, particularly in cases in which we have high risks of reactivation of intraocular infection, we enter the so-called prophylactic phase. There are situations where we just have the induction and the prophylactic phase. And for cases that are mostly monophasic, we don't usually cure the patient, we just kill the bug and treat the patients. So the bottom line is, if we use sufficiently antimicrobials, we contain microbial spread. However, if we don't modulate the immune response, the immune damage may lead the patient to blindness. In contrast, if we mostly use corticosteroids, if we impair the immune response, which in many cases may be very important to help contain the process, we may also have problems. So ideally, what we try to do is to balance the antimicrobial effect of the drugs that we employ, and also to use steroids to balance and not to exaggerate, to exacerbate intraocular infections. So I'll just go over a few entities. Toxo, as you all know, it's the most common etiology of intraocular infection worldwide. The treatment is based on a combination of antiparasitic drugs and corticosteroids, which are used from 5 to 6 weeks. The treatment decision is based on several factors. And also we have several different therapeutic schemes. We have the so-called classic therapy, but globally, maybe the most used scheme is the combination of sulfamethoxazole and trimethoprim, also considering the use of corticosteroids. Intravitreal therapy has been used to help treat ocular toxoplasmosis. We usually combine clindamycin with dexamethasone, usually for patients who are intolerant or have contraindications to systemic therapy. We may use it combined to systemic therapy for patients who are not responding. So this is an example. It's a 22-year-old pregnant woman in the very beginning of gestation. She was complaining of decreased vision floaters in the left eye. You see here in the right side, in the right picture, an active focus of retinal choroiditis adjacent to pigmented retinal choroidal scars. We see the vitreous quite clear, not much retinal vasculitis, but in this setting, we were quite concerned. This is a patient with just IgG for tox, so it's a reactivation. We were quite concerned that any medication in the very beginning of pregnancy may pose a risk to the fetus. So what we proposed was utilization of intravitreal therapy. And as you see, after a single intravitreal injection of Clinda and dexamethasone, the patient does respond. Even though the response, if you just use isolated intravitreal therapy, it's less efficacious, it's slower than the effect of systemic therapy. This is in contrast, for example, for intravitreal treatment for viral retinitis that I'll address in the next few minutes. Usually, toxo does resolve centripetally. The margins become flat, then the lesion flattens down and becomes eventually completely hypoautofluorescent. This is an OCT sequence that you see the active lesion here, then the patient was treated, and you see the centripetal resolution of the inflammatory focus. We use quite frequently autofluorescence to monitor response to therapy, and you see usually as we start to treat these patients, they develop a hypo and a hyper autofluorescence halo, which progressively increase in area until we finally have a completely hypoautofluorescent lesion. Prophylactic therapy is quite useful in toxo, as this very recurrent disease. Up to 2/3 of patients do develop recurrences anytime in life, and the mainstay of therapy is a combination of sodium methoxyl, trimethoprim, a double strength one, which we may use either 3 times a week or every other day. And we use this more primarily in patients who are immunosuppressed, in patients who have very frequently recurrent lesions, bilateral involvement, unilateral multifocal involvement, or lesions that threaten the macula or the optic disc. Usually we use prophylaxis once we decide to use it for the first year at least. That is the period where we have a 15 to 20% risk of reactivation, but we may extend it for the second year after the last crisis of retinal choroiditis. Very briefly, herpes virus retinitis, I will just quickly address acute retinal necrosis. As you all know, is a very severe fulminant viral retinitis. We have this induction phase in which we use high-dose systemic, either intravenous or oral, if you decide to use high-dose valacyclovir as well. For these patients, we may associate intravitreal therapy to increase the antiviral effect. Usually we wait for 48 to 72 hours to start the corticosteroids, and we treat the anterior segment as accordingly. After this induction phase, we discharge the patient, use a lower dose of the oral antiviral, and then move to the prophylactic phase. These are the medications and the doses that we use: IV acyclovir, IV ganciclovir, particularly in patients who are HIV positive, and we cannot tell if that is HSV, VZV, or CMV. And high-dose Valtrex, 2 grams 3 times a day, may also be very helpful. We have to be very careful with renal dysfunction in these patients using high-dose acyclovir. As I said, intravitreal therapy may be used as a supplement to systemic antivirals. Then we move to the maintenance phase and later to the prophylactic phase, usually using antivirals for up to 12 months after the last crisis. Syphilis, as Derek nicely addressed, is an emergent disease. Luckily, the patients with syphilitic uveitis, that is a form of neurosyphilis, they do cure with antibiotic therapy. So the first choice is aqueous intravenous crystalline penicillin G, a very high dose. Alternatives, according to the CDC, procaine penicillin, and even ceftriaxone, which we have been using quite frequently here. It's controversial whether it is necessary to supplement this treatment with benzathine, penicillin, intramuscular one, a few doses afterwards. We consider this for a few patients. And also the use of corticosteroids. Patients with mild disease, we may defer corticosteroids, but usually if they're threatened to the macula, to the optic disc, we do use corticosteroids. Cat scratch disease is a disease that is also re-emerging. You see a patient with neuroretinitis, also a superior focus of retinitis, as you can see here as well. The picture is quite typical. You see the angiogram showing this hyperfluorescence. And these patients, they very nicely respond to oral doxycycline, as you see in this case. You see the response here. We did not start steroids right away until we had the results of the serological tests, and then the patients, they do quite well. This is an infection which can be cured. We don't need to do prophylaxis afterward. Last but not least, this is a condition in which we may not even need to use antimicrobials. As a patient with migrating retinal infiltrates, as you can see here, and then we can locate this S-shaped larva in the superior retina, and you see the OCT section of the worm, and we may just cure the patient by lasering it if we detect the worm. Otherwise, we may use a high-dose albendazole as well. So in conclusion, we have this protagonist of antimicrobials in infectious uveitis. We also consider the judicious use of systemic corticosteroids and care follow these patients to assess the therapeutic response. Thank you very much for your attention.
Thanks, Daniel. So we'll come back with our queries to you after end of all talks. So now the very interesting questions we have, because we have corticosteroid, we have immunosuppressives, and we have biologicals. So now which one we should use? So we have Dr. Ilaria Testi with us, who will be sharing her views on from steroid to biologics, the right drug at the right time. Over to you, Ilaria.
Thank you. Good afternoon, everyone, and many thanks for the kind invitation. So many non-infectious uveitis are chronic inflammatory diseases requiring chronic suppressive treatment. Systemic corticosteroids are the first line in treatment, but we are all aware of the long-term side effects that are potentially associated with the long-term use of systemic corticosteroid. So that's why patients are starting on immunosuppressive treatment. I would like to start my presentation by sharing with you a few clinical scenarios and make you think about how you would treat this patient. So in scenario number 1, our multimodal imaging is telling us that we are dealing with the VKH. So how you would treat this patient? Would you start systemic steroid taper to stop, or would you also start a second line agent? And what about scenario number 2? Scenario number 2 represents a birdshot retinochoroiditis. So would you treat your patient the same way as scenario 1? Scenario number 3 represents an active PIC. We have 2 active inflammatory lesions and also an active CMV. Apart from the active CMV, your management would be the same comparing to the first 2 scenarios, or you would do something different. And finally, we have our last scenario that represents ocular Bechet with a recurrence of inflammation after stopping steroid. So how you would treat this patient at baseline and in the long term. So which are the factors that dictate when immunosuppressive treatment should be introduced in the management of these cases, and more in general in the management of non-infectious uveitis? So, of course, we have just seen that ocular Bechet is managed in a different way compared to VKH or compared to PIC. So what is this telling us? This is telling us that therapeutic approach is basically dictated also by the disease type, the entity, the phenotype, the natural history of the disease, and by the disease severity. So the way you treat a PIC is different compared to the way you treat Bechet at baseline. But of course, there are also other factors that need to be considered. For example, you might want to start immunosuppressive treatment if you lack of controlling your diseases with corticosteroids since the beginning. So your patient is on a good dose of steroid, for example, more than 0.5 milligram, still active inflammation. You might want to start your immunosuppressive agent. Of course, also, if you are tapering down your steroid and you have a rebound of inflammation, or you have a rebound of inflammation after stopping corticosteroid. But also if you're not able to control your inflammation on a low dose of steroid, and for low dose, we usually mean 7.5 or less. But of course, we also need to keep into consideration that we are not dealing only with the disease, the phenotype, but also we have our patient. So the patient can have also some contraindication on steroid intolerance, and therefore the need for steroid sparing effect. So back to our first scenario, VKH. So VKH is an acute disease, severe, sight-threatening. So of course, we need prompt anti-inflammatory control, and this can be achieved with systemic steroid. But we also know that the disease can enter a chronic phase, and there is evidence that a combined steroidal and non-steroidal immunosuppressive treatment as a first line can prevent this, meaning can prevent the chronic phase of the disease, can prevent the persistence of clinical inflammation and all the structural complications. I know there are different management around the world here, so I'm happy to discuss later on. And what about birdshot? So we know that birdshot, by the natural history of the disease, is a chronic disease. So you will start your steroid treatment, but of course, if you taper a stop, your steroid will come back. So you need to start also a second-line immunosuppressive treatment. You want to treat your disease when is in this phase, meaning early stage, because you want to prevent this. You want to prevent the typical birdshot lesion that represent already chronic, ongoing, untreated disease. And there's another case of very end-stage untreated birdshot. And what about PIC? The management of PIC is completely different from what we have seen so far, at least as baseline. So this patient, new PIC, active inflammatory lesion, active CMV. You start your steroid, you give anti-VEGF, but you taper to stop. And let's see what happened. We have again new inflammatory lesion with the symptomatic patient. So we decide to restart steroid, but this time to keep the patient on a low dose steroid maintenance. But again, we have new inflammatory lesion and also an active CMV. So apart from the active management here, we decided to start mycophenolate. Why? Because we have a recurrent disease with a previous relapse after stopping steroid and a disease that cannot be controlled on low-dose systemic steroid. So what are our systemic conventional immunosuppressive agents? We have antimetabolite, we have T-cells inhibitors. Remember that these medication takes several weeks to kick in, so you need to maintain your patient on steroid. Do not taper too quickly, otherwise you will have a rebound of inflammation. And these are data from the SIDE cohort study, is a retrospective cohort study on a single agent effectiveness. And you can see here antimetabolite and cyclosporine can achieve disease control by 12 months in 52-73% of the patient. And this is a randomized controls trial, very interesting, of mycophenolate versus methotrexate showing similar efficacy. So the trial showed that MMF was not more effective than MTX in treated non-infectious uveitis. But what happened when there is an inadequate response to conventional immunosuppressive treatment? So of course, make sure that your patient is on the maximum tolerated therapeutic dose before switching. And what's your next? You might want to escalate to biologic, and you might want to add anti-TNF-alpha. So anti-TNF-alpha are the first line, most common biologic used in the treatment of non-infectious uveitis. Evidence from the efficacy of adalimumab come from the visual 1 or 2 trial, but I'm not going into this because we don't have enough time. But I will say that in a typical scenario where you need a change in the therapeutic management, with your patient being on an antimetabolite, more commonly MTX or MMF, and you have active ongoing inflammation on a low dose of steroid or after stopping your steroid, you might want to continue your antimetabolite and you will add adalimumab. And this is a good example when adalimumab managed to control the inflammation. You see resolution of the ICG spot, of the vasculitis, and here you can see beautifully the reduction in the choroidal thickness. So there is no doubt that adalimumab can achieve a better control of inflammation compared to the antimetabolite drug. And these are the results from the ADVICE trial just published a few months ago, showing that adalimumab resulting in a greater proportion of patients that successfully stopped the steroid at 12 months compared to antimetabolite. But of course, antimetabolite are more cost effective. However, there are a few cases in our practice where we usually start biologic up front. Which are these cases? For example, you can see here we are going back to scenario number 4, which is ocular Behçet disease. So it's a sight-threatening vasculitis. You require prompt control of inflammation rapidly. It's a relapsing condition, completely unpredictable. So you might want to start biologic upfront. And the other condition for me, happy to discuss, is very advanced JIA. For example, these are few cases of JIA who come to our attention like this at baseline: posterior synechia, cataract, posterior spillover with optic swelling, macular edema. So in this case, in children that are so little, you might want to start biologic upfront because you might want to get the chance to have the best outcome and the best control of inflammation. But what happened when our adalimumab failed? So you might want to check adalimumab level and adalimumab antibodies. So if you have a low level of the drug with no antibodies or low antibodies level, you might want to increase to weekly before switching. However, if you have already a very good therapeutic drug or very high level of the antibodies neutralizing your drug, then you need to switch. And what do we prefer to do? We prefer to switch inside the same category of anti-TNF alpha, meaning switch to infliximab instead of changing category. But what about when all anti-TNF alpha fails? So there is no high-level evidence, of course, to guide what's next. But in my practice, I would go that my next to-go agent is interleukin-6 TOC, especially if I have a chronic anterior uveitis or if I have a retinal vasculitis or a CMO. But of course, I'm happy to discuss and also know the opinion of the other member of the panel. So just to conclude, basically, immunosuppressive treatment in uveitis. So make sure you choose the right therapy for the right patient, meaning that you have to match the treatment to disease phenotype. So you need to take into account disease severity, natural history of the disease, the entity that you have in front of you. Conventional steroid-sparing agent like MTX, MMF usually are the first line. Consider biologic when you have severe refractory or vision-threatening disease. But of course, also keep into account patient factor, for example, intolerance and comorbidities. Thank you for your attention.
Thanks, Hilaria. That was a great talk. So now we have reached almost the end of the program. So before we finish, the very interesting talk, which I'm all of us looking forward, is from Professor Amod Gupta, who will be talking on what lies ahead in uveitis, emerging frontiers in research and therapy. Over to you, sir. Multimedia, can you play the video?
And friends, the past decade has seen unprecedented.
Start from the beginning and.
Dear colleagues and friends, the past decade has seen unprecedented growth in uveitis research, driven by breakthroughs in immunology, pharmacology, molecular diagnostics, imaging, and AI. These mirror advances across rheumatology and oncology. And finally, the field of uveitis is shifting towards precision medicine. Not all uveitis is biologically identical. The same phenotypes may have different biological processes. Future therapies will largely depend upon recognition of the immune pathways. Single-cell transcriptomics and T-cell receptor analysis now allow direct characterization of immune cells within the eye, revealing disease-specific intraocular immune signatures, for example, clonally expanded T and B cells in granulomatous uveitis. In contrast, innate immune cells, particularly macrophages and violet pathways, are predominant in HLA-B27 uveitis. Unlike larger organs, ocular compartments are small, anatomically isolated, and highly enriched with disease-specific molecules. Aqueous and vitreous humor contain cytokines, chemokines, nucleic acid, proteins, and metabolomic signatures, providing a precise molecular window into ocular disease. Proteomic studies have shown that aqueous and vitreous humor can distinguish infectious from non-infectious uveitis and further from primary vitreoretinal lymphoma, and even identify disease-specific pathways such as IL-23 mediated inflammation in some cases of intermediate uveitis. In contrast, plasma profiles from the same patients often fail to show these distinctions, highlighting the value of ocular liquid biopsy over systemic sampling. One of the hottest topics these days is the autoimmune disorders caused by dysbiosis. The loose mucus layer facing the colonnectal lumen contains trillions of commensal bacteria. The green zone in this cartoon represents the denser inner mucus layer, which is usually largely bacteria-free and acts as a protective barrier over the intestinal epithelium. Breakdown of fibers by beneficial bacteria such as short-chain fatty acids helps maintain the epithelial integrity and immune homeostasis. During dysbiosis caused by disruption of the microbiome and breakdown of the mucus and epithelial barriers, which allows bacteria and bacterial products to penetrate the inner mucus layer and access subepithelial lymphoid tissues. This promotes activation of effector T cells from naive T cells against bacterial antigens, some of which may mimic self-antigens through molecular mimicry. These activated T cells can then circulate systemically and migrate across ocular barriers and initiate ocular inflammation. Experimental studies suggest that microbiome-targeted approaches, including dietary modulation, antibiotics, probiotics, and short-chain fatty acid supplementation, may reduce ocular inflammation. However, despite compelling mechanistic and preclinical evidence, human interventional studies remain limited, heterogeneous, and largely exploratory, with only few anecdotal reports currently available in uveitis literature. Subjective scoring of vitreous haze to date has been always subject to inter-observer variations. The OCT vitreous intensity signal is an improvement over the earlier vitreous intensity signals in terms of RP signals, which were affected by CME. In the FAST multicentric trial recently reported, vitreous signal intensity as observed objectively measured on OCT correlated with clinical vitreous haze score, the severity of antechamber cells, and visual acuity. In future, it will serve as a major surrogate marker for interventional outcomes. It is not affected by posterior CME, but certainly affected by posterior subcapsular cataract. While single-cell RNA transcriptomes enable liquid biopsy to study infiltrating immune cells, can OCT one day serve as a surrogate for immunophenotyping? In vivo cellular resolution retinal imaging techniques, including adaptive optics, ultra-high resolution OCT by the David Huang Group and Portland, the co-inventor of OCT technology, visible light OCT, and others are transforming ophthalmology by enabling direct visualization in vivo of the retinal cells. Unlike biologics that block one cytokine extracellularly, JAK inhibitors block intracellular signaling shared by multiple cytokines simultaneously. Broader upstream inhibition of cytokines may better address the biological heterogeneity of uveitis, although definitive clinical efficacy remains unproven. Brepocitinib, a dual inhibitor of JAK1 and type 2 for treating non-infectious uveitis, and baricitinib, a JAK1 and JAK2 inhibitor, are in the clinical trial for JIA uveitis. Infection risk, herpes zoster, thrombosis, lipid abnormalities, long-term safety issues remain major concerns. A nano formulation of high concentration of topical dexamethasone formulation has been designed to enhance solubility, corneal residence time, and also posterior segment penetration. Results are likely to be out for studies in diabetic macular edema. Extracellular vesicles are nanoscale vesicles formed within cells and are relatively non-immunogenic, making them less likely to trigger post-immune responses. As extracellular vesicles, they can be loaded to carry immunomodulatory microRNAs, messenger RNAs, proteins, and other signaling molecules that can reprogram the recipient immune cells toward an anti-inflammatory phenotype, promoting the production of anti-inflammatory cytokines such as IL-10 and TGF-beta. In one of the experiments, when mesenchymal stem cells are cultured under physical or chemical stimulation, they release exosomes which are rich in nucleotides that suppress inflammation. Mesenchymal stem cells, exosomes, are known to shift the immune system from a pro-inflammatory state to an anti-inflammatory state, the regulatory state. They carry cargoes such as TGF-beta, IDO, and specific microRNAs that promote the polarization and differentiation of uncommitted monocytes into anti-inflammatory M2 macrophages. They also promote the differentiation of naive CD4 T cells into immunospecific regulatory T cells. Extracellular vesicles can transform certain specific microRNAs, for example, a microRNA 146A and neuroprotective factors such as BDNF to recipient cells, providing neurotrophic support to photoreceptors and optic nerve. The uveitis clinic in the next 10 to 20 years would routinely carry out aqueous humor liquid biopsy, do immune endotyping, use artificial intelligence-assisted image biomarker to control, to monitor, and classify uveitis based on molecular typing and move to personalized biological selection. If the preclinical evidence holds in the trials, human trials, we may one day see using regenerative engineered extracellular vesicle or exosomal therapy in patients with uveitis. To summarize, uveitis research is transitioning from descriptive inflammatory phenotypic diseases to precision ocular immunology. And I believe that uveitis practice in future will be biomarker driven, minimally invasive, and regenerative rather than merely suppressive as is practiced today. We shall see some of these becoming available maybe in the next decade, maybe in the next 20 years, at least in some of the tertiary centers around the world. I'd like to thank you all for your time and patience. Thank you.
Thank you, sir. That was so insightful. Really enjoyed it. So now let's, I think there is a message from the organizer. We have limited time, so we'll go one by one. First, Alessandro, there is a question on how to advise imaging in a patient's with choroiditis, healed choroiditis, and look for CNVM in these patients. How frequently the patient means the clinician should advise imaging in these patients?
Thank you for the question. It's a difficult one. I think it really depends on the vision of the patient, but I will try to monitor with OCT like every 3 months, I will say, and move from that based on what I see on OCT.
Okay. So what's your view on ICG? In which are the cases you advise ICG? And I asked,
Partho, can I interrupt you for a moment? Partho,
yes, yes, sir.
I just a short interruption. I'm sorry, Sandro. This is regarding the development of CNVM in a choroiditis scar. It could be toxo, it could be TB, it could be any, or sarcoidosis versus reactivation of the lesion. I think, as Alessandro mentioned, it's a major challenge in the clinic. And I think patient should be advised and cautioned that if there is any fresh new symptoms, they must undergo this either a reactivation or a CNV. And we found that OCT angiography is a big help in discovering inflammatory CNVM, which may not be able to pick up on clinical pictures or OCT, structural OCT. So I think one would like to do an OCT angiography in some of these patients to make sure there is no recurrence or there is no development of CNVM, which is a major challenge, which could be blinding if we treated them with steroids. And these inflammatory CNVMs, they just need a couple of maybe 2 or 3 anti-VEGF injections to take care. So they'll be absolutely opposite direction that we'll be treating these patients once we know what we're dealing with. Thank you. Yeah. I'm sorry again.
The question was, in absence of any symptoms, as you know, many of our patients they can't realize the scotoma or any kind of symptoms. So we need to monitor these patients. So how often one should monitor this patient?
No, I'm sure you're monitoring for symptoms, or otherwise you're calling them every 3 to 6 months. I mean, you can't call them every month or every few weeks into your clinic. But the important point I was making was that if the patient becomes symptomatic, if they complain of any blurry vision, because if the CNVM is developing, say, somewhere close to the optic nerve head, where juxtapapillary CNVM, it may not manifest visually for a very long time. So it might get picked up. These membranes are rather slow to develop. They give you a lot of time to hang on, and they are unlike what you see in age-related macular degeneration. So characterization of inflammatory CNV is a little bit different, than the other kind of CNVMs. So I think keeping it in mind is the most important. High index suspicion that the patient may develop CNVM in future. So patient have to be told about that, not to ignore any symptoms. And as I used to tell patients that you close one eye and the other and turn, close one eye at a time and read your newspaper or watch TV or something, you'll be able to discover immediately if there is any disturbance in your vision. Yeah.
Yeah, so the take-home point is you need to explain some symptoms to your patients also, and every 3 months you should monitor all these patients and look carefully clinically, and any slightest doubt you should go for imaging. And Alexandro mentioned that OCT is a very useful marker in these conditions. So my next question to both Daniel and Dr. Smith here. So how to manage, or how often you encounter uveitis following successful treatment of syphilis with penicillin? Because many of our colleagues have reported, and we keep seeing in our clinic, the syphilis has been treated successfully with penicillin, but following that, they can see some kind of inflammation is coming, and how to treat these cases of uveitis. Dr. Smith?
Partly, to be honest, in our experience, provided the patients have been treated, we tend to treat intravenously. So we have to admit the patients and we treat them for a full 2 weeks. And depending on the clinical picture, we may or may not add oral steroids, depending on whether we think it's clinically indicated. Then we're not addressing the issue of the Yarish-Herxheimer that you can see in the eye as well. But we don't really see very much persistence of the inflammation. But of course, one of our big problems is actually being able to trace the sexual partners of these patients. And if you're unable to do that, often the patients just go and get reinfected. So that's another thing that one needs to bear in mind.
Okay. Daniel, you want to add something?
Yes. Well, that's a very interesting question. Indeed, we do have a few patients who have persistent intraocular inflammation. These are usually the ones who have more severe inflammation at presentation, have been using inadvertently systemic corticosteroids, and develop vascular occlusions. We have a few with chronic macular edema, but mostly the ones who had vascular occlusions in the acute phase of the disease. So for these more severe cases, we usually treat longer, like from 2 to 3 weeks. We start steroids and slowly taper it. And these are usually the ones who I indicate intramuscular benzathine penicillin after discharge, because they will be using systemic corticosteroids for a while. And I want to make sure that they are not reinfected and then develop recurrence of eye disease. So for me, this is an indication of supplementary benzathine penicillin in these patients, the ones that we need to keep systemic corticosteroids for a while. For these ones, how do we manage them? We may use periocular steroids, because these are patients of higher risk, so they frequently reinfect themselves regardless of treating the partner. So I usually like to treat them locally and to follow them quite closely, because I have had patients, it's not common, most are cured with adequate therapy, but this is an issue that we have in a few cases.
So my another question to both of you is, how frequently you start oral steroid in cases of syphilis, ocular syphilis I'm talking about. So
I'm sorry, Pat, you broke up. Could you just repeat the question, please?
So I'm asking you, in a case of ocular syphilis, how frequently you use oral steroid with anti-syphilis treatment? For example, if you are treating the patients when you want to add oral steroid to your regime, or you simply treat with penicillin or only antimicrobial treatment? Hope I'm clear. Miss, do you add oral steroid?
Yeah.
Yes, well, I'm sorry.
I think if I can clarify the question, Derek, it's when you are treating most of the cases of syphilis, you would be treating with a specific penicillin therapy for a couple of weeks given intravenously. In not all cases, you would give corticosteroids. So he wants to know, do you add corticosteroids at any stage in patients of syphilis uveitis? And my short answer to that would be, well, if we see immune recovery uveitis, IRU in some of these patients, you reconstitute by giving antibiotic, and they throw up a massive reaction or a macular edema or CME. So that would be my indication. But we would like to know from your vast experience managing syphilis cases.
Yeah, not immune recovery. I'm not talking about immune recovery. I'm talking about the only ocular syphilis cases. So
would
Sorry,
there
my
be any
apologies.
indication of corticosteroids?
My internet cut out. Sorry.
Okay. Daniel,
Yeah,
do you use steroid?
Yes, well, I use steroids in most patients, and the criteria here, in my view, are first, involvement of the macula, of the optic nerve head, or occlusive retinal vasculitis. So patients that don't have macular involvement, don't have involvement of the optic disc, and don't have occlusive retinal vasculitis, I don't use steroids. But most patients do have either one of these changes or a combination of all of them. So in general, mostly I use steroids for most cases. Usually I wait 24 to 48 hours to start the steroid. I just use antibiotics for the first 48 hours. Some patients do develop the Yarish-Herxheimer reaction, and which is also treated with steroids. But for most cases, I would use it, and maybe that's why we're not seeing too many cases of chronic inflammation afterwards.
Okay, so I have one very interesting case shared to me by our colleague, Dr. Navneet Mehrotra. He is treating a case of acute retinal necrosis with intravenous acyclovir and injection foscarnet. So 1 week, there is no response, and still the lesions are actually fulminantly progressing. So can you suggest how to tackle such cases? Let me repeat the treatment.
Yeah, I got it. Yeah.
Got it. Yeah.
Yeah, it was crystal clear. Well, indeed, it's depending on the case, on the virus. Some patients, they take time to start to respond, and that makes us very anxious. Sometimes you're giving intravenous antivirals, you're injecting antivirals, and still the lesions are progressing. But you have to be patient, because they will start to respond eventually. Many of these cases, they do start to respond, but some do take some time. It depends on the time to presentation. It depends also on the inadvertent use of steroids. I had a patient a couple of years ago. She received post-IV methylprednisone before suspected optic neuritis, but she had acute retinal necrosis. So by the time she came to us, it was VZV positive in the aqueous humor. We started the intravenous, we started intravitreal, and despite intravenous and intravitreal in the right eye, she developed ARN in the contralateral eye. I did not know what to do. I just waited. But then eventually she started to respond. So some patients may delay the onset or response, but I think this is the best that we could do. Intravenous systemic as well as intravitreal. So there's nothing more than that.
Yeah, I think this patient also was VZV positive. So how frequently you give intravitreal in such cases, or you recommend to give intravitreal in such cases which is progressing fulminantly?
Yes. Usually the more severe ones, the ones that are coming close to the macula, I do inject either foscarnet or ganciclovir. But the ones that I'm very, there is a problem indeed for patients very severe involvement that I'm anticipating a retinal detachment. Sometimes I do defer intravitreal therapy, but I think that it might be quite useful in the beginning to expedite the effect of antiviral therapy.
Thank you, Daniel. So just finishing, I have a question for Ilaria. So you rightly said that the anti-metabolites are more cost-effective than the TNF alpha. And that's very true for country like India, no, where most of our patients, they can't afford adalimumab or any TNF alpha. So, and you also spoke about methotrexate and mycophenolate. Both of them have same efficacy. So have you tried combining this treatment, both the methotrexate and mycophenolate mofetil? Because other subspecialties of medicine, they combine this.
Yeah, so it's something that we don't usually do, but of course, I think depending also on the setting when you are practicing. So here in London, of course, the adalimumab is NICE approved, so we have very easy access. So who fail MTX or MMF, then we just add adalimumab. We don't tend to combine two antimetabolites, but of course, I think this also depends in the practice, the setting of the practice where you are practicing. This is not our common practice. I'm happy to hear other opinion here.
So have you tried tocilizumab or any, because what if the patient is not responding to anti-TNF alpha? What's next?
So for us, next is anti-interleukin 6, TOC, especially. So TOC is really working very, very well in CMO. So if the problem is retinal vasculitis with CMO, they can respond well. I also use TOC in chronic JIA or chronic pediatric anterior uveitis that fail anti-TNF alpha. You can have a good or partial response, meaning they might still need maybe some low-dose steroid maintenance, but you can have good results. So my next to go is definitely TOC for the patient who fail anti-TNF alpha. Then, of course, depend also on the phenotype. If you have, I don't know, a scleritis or also systemic vasculitis, you might want to try rituximab. So it's depending also on the phenotype that you have. But I say as an overall statement, I would say who fail anti-TNF alpha, in my opinion, is anti-interleukin 6.
Okay, thank you. So I'll go to Amod Gupta sir. Sir, you spoke about various upcoming treatment. So if you look at the dermatology and other clinic, they have that topical applications of all the JAK inhibitors which we are using. So what do you think about this future? And we are not seeing a lot of biologicals which are being used as intravitreal agents. So what do you think about the future of this?
I think the next thing that's going to happen in immediate future is already happening is the JAK inhibitors. And they are safer JAK inhibitors. We are getting these combinations of JAK1 and type 2 and JAK1 and JAK2. So these combinations probably would be more effective than what we are tofacitinib, this JAK1 inhibitor. So the major fear is of the unknown. We still don't know. We have very limited experience, reported experience of using JAK inhibitors, very anecdotal short case series around the world. So as the experience builds, we'll gain confidence. And this was what's happening with all the immunosuppressive therapy. In the early years, people were very reluctant. They were comfortable using corticosteroids, and they became usually, more comfortable using immunosuppressive therapy like MMF or methotrexate or azathioprine. And now people are using biologicals in advanced tertiary centers, and those who can afford. I think so. Next thing to go is, of course, JAK inhibitors offer advantage over cytokine inhibitors like IL-6 or IL-2 or the adalimumab or TNF-alpha inhibitors, because they block only one inhibitor, whereas we don't know what are the array of pathways which ought to be blocked. So anything which is a broader spectrum would be, to my mind, would be more effective, and probably clinically we are going to gain experience in the next maybe 5 to 10 years. And by that time, we will have much more advanced immunoassays and pathways we'll know, and we'll have more precision in treating these patients.
I think that's all for today, friends. So that was all about the cutting edge management in uveitis. I hope you enjoyed, and thanks to all the panelists, all the coordinators, especially Dr. Sakshi and Rolika from the backend team, and thanks Alessandro, Ilaria, Daniel, Smith, and Professor Gupta for joining us. Thank you.
So
Thank
we'll
you.
one
Thank you
minute.
all.
We'll just take
Thank
one
you,
picture.
partner.
I'll request everyone to turn on their cameras and just smile for the camera.
Okay, we'll smile for you.
Thank you, ma'am.
Thank you.
Done.
Thank you.
Hi,
Thank you,
Laria. How are
Sakshi.
you?
Hi, I'm fine. You?
Good. Hello, sir. Very good.
Hello.
Hi, Dr.
Daniel,
Vishali.
Derek, Alessandro. Hi. Lot of people. Hi, Soumya, Partho,
Hi,
Padma.
Vishali.
Hello. Monsif is also here. Wow.
Good evening, ma'am.
Well,
Hi, so
Hi, long time. Hi, Daniel. Hi,
yeah,
Laria.
sorry about my internet going off.
Hi.
It was, no, sorry.
Daniel, I heard very good things about you. Guess what?
Ah,
Your
please tell me.
singing skills. You're singing.
Not really.
So you're going to sing
That
for us
that
in
was
revision because everybody spoke so high about Daniel. I said we'll get Daniel for IUSG also, not only for IOIS.
uh oh, that is a very well kept secret, you know. That's my B-side.
Both you and your wife, I guess.
Yes, yes.
Daniel, advance booking for USI. You have to sing in Madurai also. I
See?
hope you
Well,
are
my
coming.
pleasure.
So,
Hello, sir. We are live.
Oh, okay.
Thank you, everyone.
Thank you.
Bye.
Thank you.
Not yet.
So good evening, everybody. Hello, am I audible?
Yes.
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 Good evening, everybody, and welcome to the uveitis session of the USI and IUSG on an update on choroidal and retinal infections. Please allow me to share my screen.
Hi, Pratik. We are live, but the session will begin at 4:30. So we are live for now because the session remains live in continuation.
Yes,
So yes.
I'll just share the opening screen and we'll pick up from there.
Yeah. And you can start with introducing the session that time once again.
Definitely.
Yes. Vishali ma'am.
Yes.
Vishali ma'am, good evening, ma'am.
Good evening.
Yes, ma'am. Ma'am, Dr. Nishant and Dr. Pratik Nishant and Dr. Richa Pyare are here with you for anything that is required. Ma'am, please let us know.
I don't
And
have a talk, no?
no, ma'am, but you
That
will be
really
giving the opening
really
remarks
scared-
in case
Opening
anything is
remarks.
needed as a chair.
It
Please let
literally
us know.
scared me.
I think, ma'am, if somebody woke you up in the middle of the night and said, give a talk, you could
Give a
probably
talk.
like
No.
impromptu and bat it out of the field. I don't know why you would say that you're worried, but I think mainly you guys have to coordinate between the speakers, and we are there to help you call anyone if people haven't logged in on time, and we need to collect questions for you.
I think you can coordinate, Richa and Pratik. I'm fine. Go ahead.
Sure.
Only for the third speaker, you have to play the recorded ones.
Hello,
Dr.
ma'am.
Neri.
Dear Georgia,
How are you?
Yes.
Is that recording available with the support team?
Sunilji, can you confirm that, please? Dr. Daniel's talk, right?
Yes.
No,
No, not that.
Neri.
No,
Dr.
Neri.
Neri's talk.
Neri's the
Prof.
third.
Neri.
Yeah. You can confirm. If not, then I can download it here as well. Sunilji?
Process Mary's talk.
Pratik, don't worry. I will forward the talk to you. You can keep it downloaded while the other talks are going on. And it will be in backup with me as well.
I'm already copied on the mail. I'll just
Okay. Perfect. Wonderful. I'll help out with the timer from my end. So if anything else is needed, please let me know. It's 4:31. Can we start?
Good evening, everyone, and welcome
Yes,
to.
ma'am.
Someone will take a
Yes.
screenshot. Good evening, everyone, and welcome to the session on an update on choroidal and retinal infections. This is a joint USI and IUSG session. I'm Dr. Pratik Nishant, your coordinator. With me is Dr. Richa Pyare and Dr. Rolika Bansal. I'm glad to introduce our chairperson, Dr. Vishali Gupta, ma'am, moderator, Dr. Padma Malini Mahendradas, ma'am, our panelists, Dr. Rupesh Agrawal from Singapore and Dr. Ranju Kharel from Nepal. And speakers joining us are from all over the globe, Dr. Alessandro in Vernizzi from Italy, Dr. Daniel Vitor Vasconcelos Santos from Brazil, Dr. Monsef Herala from Tunisia, Dr. Pierre Giorgio Neri from UAE, and Dr. Soumya Basu from India. So welcome everybody, and it is my pleasure to hand over the session to our moderator, Dr. Padmalini Mahendradas ma'am. She will be coordinating the session. The opening remarks will be delivered by Dr. Vishali Gupta ma'am. Faculty will be introduced by Dr. Padmalini, and we will have subsequent talks on ocular toxoplasmosis, decoding TB posterior uveitis, ocular syphilis, viral herpetic posterior uveitis, and newer viral posterior uveitis. Thank you. Over to Dr. Padma Malini, ma'am.
You. The screen is visible?
Not yet.
Very good evening, everyone.
Yes, now it's visible, Padma. You can go to slideshow.
We welcome you all for the session on update on choroidal and retinal infection. It's a joint session by Uveitis Society of India and International Uveitis Study Group. It's a great honor to introduce our chairperson, Professor Vishali Gupta. She's the Chief of Vitreoretina and Uvea Services at Advanced Eye Center, PGI Chandigarh. She's the current president of International Uveitis Study Group and the president of Vitreoretinal Society of India and past president of Uveitis Society of India. She's a vitreoretina and uvea expert of international repute. She's highly sought after speaker and delivered more than 1,025 invited lectures all across the globe. She has authored 446 PubMed Index publications and edited 6 books, H-Index of 70 with 20,000 plus citations. Recipient of prestigious awards, including IUSG Gold Medal and Stephen Foster Lecture. Holds 2 US patents. She ranked among top 2% scientists worldwide across that Stanford ranking. With this, I invite Professor Vishali Gupta to deliver the opening remarks for the session.
Thank you, Dr. Padma Malini, for the very kind introduction. On behalf of IUSG and all our members, it's our privilege and honor to join USI for a joint session. And we have the best of the best. We have Monsif Karela, Daniel, Ilaria, Soumya, all of them representing us. And we do have a recorded talk from Pier Giorgio Neri. So it's like learning from the horse mouth. So let's learn from their talks, and then the house. Ranju is there. I'm sorry, Ranju, I forgot. Shapu. So we are going to have a very interactive talk, discussion after we listen to them. Thank you very much for giving us the opportunity.
Thank you. So we have a panelist, Dr. Rupesh Agarwal. He heads the research and senior consultant, NHTI Institute. NHTI Health he also co-heads Ocular Infections and Antimicrobials, Singapore Eye Research Institute. He's Associate Professor, LKC School of Medicine, Non-Technological University, Associate Professor, IACP Program, Duke NUS Medical School. He's a chief investigator for many multicentric studies like Proton, COIN, IGATES, OASIS, and CORDS. He received many awards, which include Singapore Clinician Investigator Award. The next panelist is Dr. Anju Karel. She's Associate Professor and Uveitis Specialist from Nepal. She has more than 125 cited peer-reviewed publications, and she received many awards. And her area of interest is SHARPU, that is seasonal hyperacute panuveitis. We would like to hear from her. The next, we will move on to the speakers. The first speaker is Dr. Daniel Santos. He is the current president of Brazilian Uveitis Society. He's associate professor head at UFFG Brazil. He was also the speaker of the previous session. He holds position in all major international societies. He is a member of IUSG and American Uveitis Study Group. He is a co-treasurer for International Ocular Inflammation Society, that is IOIS. He is executive board member of Global Ocular Inflammation Workshop Society. His areas of expertise include uveitis and ocular inflammation. In the ocular inflammation infections, he is specialized in toxoplasmosis and syphilis. He is also an expert in multimodal imaging in uveitis. The next speaker is Dr. Soumya Basu. He heads the Uveitis Network Services at LV Prasad Eye Institute, Bhubaneswar. His major research focus is on ocular tuberculosis, especially immune pathogenesis of ocular TB, interaction between infection and autoimmunity in ocular inflammation. He has DBT Wellcome Trust Fellowship Award. He worked on developed zebrafish model to study the ocular TB. He actively involved in framing the Indian extrapulmonary TB index TB guidelines. The next speaker is Dr. Pier Giorgio Neri. He is the Director of Uveitis Service at Cleveland Clinic, Abu Dhabi. Full Clinical Professor of Ophthalmology, Case Western Reserve University School of Medicine. He is Editor-in-Chief of International Ophthalmology, Chairman Scientific Committee, Emeritus Society of Ophthalmology. He also has MBA in Finance and Accounting from Boston University. He focuses on advancing patient-centered care, innovations in ophthalmology, and translational research in retinal and inflammatory eye diseases. The next speaker is Dr. Alessandro Invernizzi. He is Associate Professor of Ophthalmology, then Luigi Sago Hospital from Milano. He also has affiliation with biomedical and clinical sciences. He is recognized for his involving advanced retinal imaging and OCT-based analysis. He has contributed studies on retinal neovascularization, uveitis imaging, and inflammatory retinal changes. He is widely recognized as an international clinician scientist in retina on ocular inflammation. The next speaker is Dr. Mansaf Kairola. He's a professor of ophthalmology. He's from Tunisia. He has more than 270 publications. He's Society of various international groups, which includes Jules Gonian Club, International Uveitis Study Group, Vision Loss Expert Group, and Global Burden of Disease Group, and so on. He is the current president of Middle East African Uveitis Society. He is editorial board member in Ocular Immunology and Inflammation, Journal of Ophthalmic Inflammations and Infection, International Ophthalmology, and Saudi Journal of Ophthalmology. He received many awards, which includes Achievement Award from American Academy of Ophthalmology and also the Senior Achievement Award AAO. He also listed in World Top 2% Scientist in year 2023, 2024, and 2025. With this, I invite our first speaker, Dr. Daniel, to speak on ocular toxoplasmosis.
Thank you, Padma, for the so kind introduction. This is a subject that is very close to my heart. As you all know, toxoplasmosis is the main etiology of infectious posterior uveitis worldwide. It has been entertained as a neglected tropical disease, and humans get infected by either ingesting oocysts contaminating soil, water, fruits, and vegetables, or by ingesting tissue cysts infecting any warm-blooded animal. We may also be infected by congenital infection when the pregnant woman is primarily infected and allows transmission of the parasite through the placenta. This is the leading etiology of uveitis where I come from. Most cases of uveitis here in Belo Horizonte are associated with toxoplasmosis. Also in São Paulo, this is the context everywhere in Brazil. With a significant vision burden, a significant part of patients losing vision in one or in both eyes. There is a historic controversy regarding the relative importance of congenital versus acquired toxoplasmosis. Beforehand, every case of ocular disease was attributed to congenital infection. Then documentation of eye disease in adults without evidence of congenital infection impacted in the consideration that postnatally acquired disease is far more common than congenital disease. However, if we looked at the burden of eye disease in a congenitally infected fetus compared to a postnatally acquired adult, we see this striking difference. When 80% of neonates with congenital toxo display eye lesions early after birth, whereas only 2 to 3% of their respective mothers have eye disease soon after seroconversion. For eye disease, what happens is during primary infection, our retina is seeded with Toxoplasma gondii cysts, even in the absence of overt retinal or choroidal changes. So once the cysts rupture, it releases tachyzoids that are the rapidly proliferating form of the parasite. These do release cytotoxic mediators, may cause a direct lesion to the retina, or importantly, elicit an immune response, which is very deleterious to eye tissue. What is very important is that only tachyzoids are sensitive to currently antiparasitic drugs. If you look at the chronic bradyzoid containing cysts, these are refractory to every antiparasitic medication that we have currently. We have different genotypes of toxo circulating all over the globe. And what's interesting is that here in South America, we have significant higher diversity of parasite genotypes, as well as increased virulence of these bugs, so that ocular toxo is much more severe here in South America than in some other parts of the world, particularly Europe and the United States. The host immune response is important to the pathology, so that we have the immunomaturity of allergy of newborns, which predispose them to more severe disease. We have patients with immunosuppressed conditions such as HIV ones, those using immunomodulatory therapy, which are also more likely to develop more severe disease. And we have also several genetic determinants of more severe systemic and eye disease. So in these patients, the disease is more aggressive, larger lesions, bilateral lesions, and a tendency of a chronic course. This is an example of a patient that came to us with severe hemorrhagic, necrotizing retinitis. The PCR was positive for toxo, but she was HIV positive, not previously suspected. The eye disease, toxo eye disease, was the first manifestation of HIV in this patient. There's another patient undergoing chemotherapy for a thymoma that developed concomitant active lesions in the macula and the far periphery of the retina. In this case of atypical toxo, PCR is very useful to the definite diagnosis. She was treated and she nicely responded. And last but not least, patients undergoing inadvertent high-dose corticosteroids that develop reactivation of retinitis in the fulminant course. This is the case of a patient previously treated for MS that developed severe fulminant toxoplasmosis, and another one undergoing an Ozurdex implant. Diagnosis based on pattern recognition of fundus examination is mostly clinical, and once we find an active focal necrotizing lesion adjacent to a pigmented retinochoroidal scar disease, this is the typical phenotype of ocular toxoplasmosis, the so-called satellite lesion. Many times we may not find previous retinochoroidal scarring. Still, this may be toxo, a primary lesion sitting there in the retina. And in many patients, we are able to document prior retinochoroidal scarring from previous episodes of retinal choroiditis. We have other associated features, retinal periphlebitis, macular edema, optic nerve edema, vascular occlusions as well. And many times the inflammation does extend to the anterior segment of the eye. As I said, as the diagnosis is clinical, but we may use serology to support the diagnosis. The negative predictive value is very important. So patients that are IgG negative for toxo, they don't have ocular toxoplasmosis. And it's also important to rule out other etiologies of infectious retinal choroiditis. Multimodal imaging, as you all know, is very useful also to help make this diagnosis. And in atypical cases, particularly, we may opt to collect aqueous humor for PCR or for analysis of intraocular antibody synthesis. The Goldman-Whitmer coefficient does indicate a selective intraocular synthesis of specific antibodies for toxo. There is an issue in patients with very severe intraocular inflammation because disruption of blood-ocular barrier allows crossing of antibodies from the ocular to the systemic compartment. Molecular diagnosis is helpful, even though the sensitivity of aqueous humor PCR in immunocompetent individuals is limited, less than 50%, but in patients with atypical forms of presentation or the immunosuppressed one, the sensitivity is higher. Multimodal imaging is bringing a revolution to this field because we can then finally document the pattern of retinal choroiditis as focal hyperreflective thickening of the retina and underlying fusiform thickening of the choroid. So this very closely recapitulates what we see on histopathology of toxo. So there's another example where we see the active lesion, we see the changes in the vitreoretinal interface, we see the fusiform thickening of the underlying choroid, which may also be demonstrated, the choroid inflammation, by OCT angiography or even ICG angiography as well. However, we have to keep in mind that not every yellow-whitish lesion in fundus is toxoplasmic. We have to make a careful differential diagnosis of other causes of congenital infections if we have a baby with eye disease, also malformations and tumors. In older individuals with recurrent toxoplasmosis, also have to make a differential diagnosis with infection, with non-infectious conditions, as well as with neoplastic conditions. The treatment is based on a combination of antiparasitic drugs and corticosteroids. We have several factors to determine the indication of treatment, and also several different therapeutic schemes. We have the so-called classic therapy. We have the Bactrim, that is the most wide used treatment worldwide. We have to be careful with sulfur allergy in these patients as well. So there's an example of a newborn that came to us with congenital toxo before 1 month of age, had an active lesion in the macula. These are the ones that, in addition to antiparasitic drugs, we do add corticosteroids with reasonable outcomes in the long term. The toxo lesion, it usually resolves centripetally from the margins to the center, eventually leaving, as you see here in the OCT, eventually leaving a complete hypoautofluorescent scar that you see over the long term. So this is the pattern of resolution of retinal choroiditis, and this centripetal resolution is also another tip for the diagnosis of ocular toxo. We have been using intravitreal therapy as well, particularly for patients who are intolerant, have contraindications, or are not responding to sole systemic therapy, even though this is a rare situation. However, we have to consider that the half-life of clindamycin is quite short, so we may need to repeat injections. This is an example of a patient in the very beginning of gestation with a satellite lesion in the left eye. The vision was regularly preserved because of risks of systemic therapy in this phase of pregnancy. We opted for intravitreal therapy, and a single intravitreal injection of clinda and dexamethasone led to resolution of intraocular inflammation, even though we have the impression that is not as fast as what we see on systemic therapy. And finally, prophylaxis, we're using it quite increasingly, usually a combination of sulfamethoxazole and trimethoprim, double strength, either every other day or 3 times a week. For self-allergic patients, we may use azithromycin. As recurrence of toxo usually occurs in clusters during life, the risk of reactivation, it's particularly important in the first year after the last crisis. So this is usually the period that we use prophylaxis, at least for 1 year. This is when we have the risk of 15 to 20% of reactivation. We may extend it for the second year, we have a risk of 5%, and then the risk goes all down all over. So in conclusion, this is a neglectable, treated disease with significant geographic disparities, a high frequency and heavy burden of progressive ocular changes, and we have to be aware because there is a risk of subclinical involvement in negligence, particularly in small newborns with congenital toxoplasmosis. Multimodal imaging is very helpful to help us diagnose and follow these patients. And we also have to advert our colleagues that this is a significant cause of eye disease. This is a major manifestation of toxoplasmosis in human subjects. Thank you very much for your kind attention.
Thank you, Dr. Daniel, for excellent presentation. So I have a question for you. What are the indications for intravitreal clindamycin in a case of toxoplasmosis? Or in other words, where do you use?
Okay, so Padma, this is not our first choice, so I have to confess that I have been treating patients, but the first indication is intolerance to systemic medications. Some patients, they do not tolerate because of comorbidities and some other factors, so contraindications of systemic therapy. In the very beginning of pregnancy of a chronically infected woman, this is the safer treatment that we would be able to offer to them. And also patients that are not really responding, then we add intravitreal clindamycin on top of systemic therapy as well. But usually the impression that we have is that systemic therapy is way more effective than local therapy. This is contrary to, for example, viral retinitis, other entities for which we inject and we have fast response. For toxo, it does help, but it's not as effective as systemic therapy.
Patients who are on immunosuppressant develop toxoplasmosis after treating toxo. When you want to put them on prophylaxis, what will be your preferred regimen?
Yeah, so it's Bactrim, it's double strand chlotrimoxazole Bactrim. We use the medication, 1 tablet, 1 double strand rather, every other day or 3 times a week. Depending on the immunosuppressive condition, we may have to use it for a long period of time. But after we pass this 2-year time frame from the active episode, the risk substantially goes lower. So that's when we consider maybe stopping the medication if the patient is well controlled.
Thank you. Ma'am, he's leaving. If you have any comments or questions, you can ask Dr.
No, thank you. Thoroughly enjoyed your talk, Daniel. Thank you.
Thank you so much, Padma. Just now we are having the Brazilian Congress of Uveitis Congress, and I'm organizing it, so I had to quickly rush to the conference center.
Thank you so much and all the best. Thank you.
Thank you so much for the opportunity. Bye-bye. See you in Tübingen.
See you in Tübingen.
Thank you. So the next we invite Dr. Soumya Basu to speak on decoding the TB posterior uveitis. Over to Basu.
Thank you, Dr. Padma and Dr. Vishali, for getting me here. It's quite a daunting task to speak in front of so many stalwarts of tuberculosis and uveitis in general. I'll get started with the talk. It's about decoding TB posterior uveitis, and the main focus will be on interpreting the clinical signs and putting the emphasis on the clinics over the tests that we come across. So we'll talk about the current guidelines, what lies beyond the guidelines, how we pick up the clinical cues to understand beyond the guidelines, and the concept of pretest probability, where we add up the signs to get the diagnosis when the current guidelines are not helping us. In between, we'll have a lot of case examples, and towards the end, we'll also look at least one unanswered question that is that we are facing right now. So you're all familiar with this, the COTS calculator. It is doing very well for people across the world. You just pull out your phone, put in the values that are listed here, and you get to know whether you should start this patient on anti-TB therapy or not. As you can see, you have the clinical phenotype, the endemicity, and the three tests, the tuberculin skin test, the interferon gamma release assay, and the chest radiography to tell you whether you should start anti-TB therapy or not. You will get a median score, which tells an interquartile range, which tells you about the consensus amongst experts, whether this needs to be started on ATT or not. And you will either have a median score of 4 or more and an IQR of 1 or less, which is when you generally should start anti-TB therapy. Now, one point to note here is that out of the 5 criteria that we have included in making a decision, 3 of these are tests. One of them is the TB skin test, the other is the blood test, and third is the chest radiography. Now, let's see how this doesn't work in some situations. Take this patient, for example, who came to us in 2015, was diagnosed intermediate uveitis based on the features here. Of course, you see supratemporally, there's a focus of retinitis, but that was mistaken as a cotton wool spots. He underwent the TB tests, which were all positive, including a fibrotic band on the CT scan. Based on these, the COT score, if it was done at that time, would have got a median of 5 and IQR of 1, which means that the patient would be started with anti-TB therapy and steroids, which is what was given to the patient. But he kept on having recurrences till in 2021, he came to us with a mobile hypopyon. And that's when we heard about his recurrent oral ulcers and made a diagnosis of Behçet's uveitis. So with this background, I'm going to discuss how we can pick up clinical cues in front of the patient and try to implement them while working with the guidelines that we have with us. As you can see, even in the COTS validation paper, it's very clearly stated that despite its utility to make informed decisions, even in the absence of extensive diagnostic resources, the calculator should not be used in isolation. So there are 2 things that we need to worry about. One is look for evidence of granulomatous inflammation, and the Sun classification criteria, which was published in 21, will give you some hint. So all of these features which were included in the classification criteria, the granulomatous anti-uveitis, serpiginous-like choroiditis, retinal vasculitis, and multifocal choroiditis, they are examples of granulomatous inflammation. If you combine them with positive TB tests and exclude syphilis and sarcoid, you will get the diagnosis of ocular tuberculosis. Now, this is not just an imaginary thing. Even if you look at the histopathological data that we have with us, in this case, this is serpiginous-like choroiditis, or what we published for retinal vasculitis, the lesions that come with retinal vasculitis. We see that both of these have histopathological evidence of granuloma in the eye. What else apart from granulomatous inflammation? A very important thing that we tend to miss is the history of TB contact. And it's not just the family, it could also be in healthcare workers, migrant workers, which is an important issue in India, barbers, shopkeepers who are all more exposed to direct contact with a lot of people and therefore the risk of picking up tuberculosis. When you see the involvement of multiple tissues, as for example, a patient with what appears as a choroiditis complaining of pain, you suspect that the sclera also is not also involved now. Or for example, if you see on an OCT what appears as a choroiditis, you see what looks like outpouching into the retina, which is called the contact sign, you know that multiple tissues are involved. You start thinking of tuberculosis. Then in the context of TB retinal vasculitis, and this applies only to TB endemic countries like ours, we see that if we have lesions overlying the blood vessels, such as the subvascular lesions, which may be healed or active, or what we classified as the focal vascular tortuosity, a tortuous blood vessel away from the area of capillary non-perfusion, or the presence of occlusive vasculitis. All of these are elements which may be seen in other forms of uveitis as well, but in the right context will add up to what we call as the pre-test probability of having tuberculosis. Now, we use the TB test to support this pre-test probability and not the other way around. So if you have a positive test with a low pre-test, then it becomes a false positive, and a negative test with a high pre-test, then it becomes a false negative. So for example, these cases of placoid retinitis or a non-granulomatous anti-uveitis or a subretinal fibrin in a CSR patient, if you get a positive TB test, all of these have a very low pre-test probability of tuberculosis. So you will have a false positive result. On the other hand, you take this patient, for example, came to us with bilateral, what appeared as chorioretinitis lesions. The TB tests were negative. The chest CT was normal. Treated with steroids, resolved completely, and then comes back to us after a year with this large mound of lesion here. And this is when we learned that the patient was a migrant worker. This added up to the pretest probability. We started this patient on anti-TB therapy alone, and see the picture. In 2 weeks, the lesion has begun to melt, and in 5 weeks, it's gone completely with anti-TB therapy alone. So this was an example where we added up the pretest probability, even though the MON2 test and the CT scan were normal for this patient. So negative test plus high pretest gives you a false negative result. Now, negative TB tests are very common in extrapulmonary tuberculosis because of the variable memory T cell response. Almost 30% of these patients may have a negative TB test. This is particularly true for CNS tuberculosis. If you think of the eye as an extension of the CNS, then you understand that so many of our patients may be coming to us with negative tests. Even in microbiologically proven ocular tuberculosis, you see that almost 40% had a negative MON2 test and 57% had a normal chest X-ray. Now, if you have done a good diagnosis, then even with ATT alone, and this is in very select cases, in majority, of course, we combine it with steroids. But in these cases, even with ATT alone, you can have very gratifying results. For example, this patient, you see the date there, 17th of February, and by 2 weeks, 3rd of March, you see the lesion completely gone on the OCT as well as on the fundus photo. Or for this patient with this retinal vasculitis in the supranasal quadrant with the active subvascular retinitis lesion on the blood vessel, you see with ATT alone, the lesion has gone completely and you cannot see it anywhere. But instead of this, if we think that the TB tests don't mean anything and we'll treat these patients with steroids alone, you see this patient, very classic example, serpiginous-like choroiditis, a classic phenotype of ocular tuberculosis. But this patient was treated with steroids alone, and initially the results can fool you because you see that the vision is improved and the lesions, the active lesions have begun to disappear. But 6 months down the line, you see how these have extended beyond the fovea, and the vision has dropped to 20/50. And this patient was continued on corticosteroids alone, despite the progressive drop in vision and the progression of the size of the lesion. And you see at 18 months, the vision has dropped even further, and the lesions have extended even further. So if you do not recognize the correct phenotype, the correct diagnosis, and just rely on the blood test, this is what we end up with. However, TB forgives, and this is a new element I thought I should mention in this gathering. Take, for example, this patient who came to us in July 2016. You see that the macula in both eyes is relatively pristine. He had negative TB tests, and therefore, I'm sorry, it was Montu and IGRA, there's a typo there. But because of the negative TB test, he was treated with steroids and immunosuppressives for a very long time. And he kept on getting recurrences still in 2021 with further loss in vision and extension of the lesions. You can see the new lesions that have come all over. Even the fundus camera has changed by that time. And by only after 5 years, this patient was started on anti-TB therapy and steroids. It wasn't easy because this patient came back to us 2 weeks later with a paradoxical worsening. And this is a very difficult situation because your TB tests are negative and you have a paradoxical worsening after anti-TB therapy. But we continued with the treatment, and you see the picture, March 2023, 2020, both eyes, despite us missing the diagnosis for more than 5 years. The most important unanswered question that we have with us is, what do you do if there is persistent inflammation even after anti-TB therapy? And this could be anything. This could be an alternative diagnosis that we're missing, especially it could be atypical mycobacteria. It could be a drug resistance, which is not easy to pick up in ocular tuberculosis, or it could be factors beyond tuberculosis, especially when your serpiginous-like patient comes back to you with a scleritis or episcleritis or a non-granulomatous anti-uveitis. And all of these vex you as to what might be the reason why you are getting this inflammation in your patient. This patient, for example, is a serpiginous patient who resolved completely but came back to us with scleritis 9 months after anti-TB therapy. So to summarize, decoding TB posterior uveitis requires recognizing the presence of granulomatous inflammation, picking up the clinical and imaging cues, building these up into the pre-test probability of tuberculosis, being cautious about false positive and false negative tests in the absence of presence of the right clinical cues, and treating these patients timely with anti-TB therapy with or without corticosteroids. Of course, there are still unanswered questions, and I hope we'll be able to find answers to these in the due time. I thank my team, the picture you see here, and I thank my wonderful mentors who have been very, very kind to me over the years, Professor Rao, Professor Amod Gupta, and Professor John Forrester from Aberdeen. Thank you very much for your attention.
Thank you, Dr. Basu, for the illustrative and informative talk. Yes. In TB, you showed based on the phenotype, we can make the diagnosis even if the laboratory investigations does not support. So after making the diagnosis, we treat the patients with ATT and they come back with recurrence. When they come back with the recurrence, how will you approach them? Always there is a dilemma whether it is infective or is due to inflammatory phenomena.
Yeah, so that's what I put as the unanswered question. So if there is no answer, I also don't have the answer really. But the way I look at it is mainly look at the phenotype of recurrence. So if the phenotype of recurrence is suggestive of an infection, for example, if it's recurring as a serpiginous-like choroiditis again, or if it's recurring as a retinitis, then I would think of it as an infection and treat it accordingly. On the other hand, if the phenotype is a non-granulomatous anti-uveitis, and we have published this earlier, then it is, probably a non-infectious cause, and that is something we'll treat with steroids alone.
I would like to comment. Thank you, Soumya, for a very interesting talk. I think what Soumya says makes sense. You have to understand the phenotype. If you enter a Behçet's disease patient in COTS calculator as TB, it will advise you to give ATT. If your pre-test probability of Behçet's is thinking of it TB, you will end up giving anti-TB drugs based on your clinical judgment. So, I mean, you enter a fibrinous CAC, but the problem is not fibrinous CAC. The problem is you diagnosed it as choroiditis. So, whether you use your clinical judgment, whether you use your COTS calculator, or whether you use your pre-test probability, the result will be same. You will end up giving anti-TB drugs because you just fail to diagnose the proper and you fail to exclude diseases other than TB. I think these are the two bottom lines, and it does not matter what you use. One, you should know it is TB, and secondly, you should have excluded other differential diagnosis, and then you want to decide whether to treat or not. Otherwise, the errors would be same, whatever, you may keep saying here and there, but the problem would remain the same.
So, Dr. Rupesh, do you want to make any comments?
I think I always enjoy Soumya's talk. Thanks, first of all. And Soumya, thanks for illustrating with good cases and so much to learn. I was just saying, in continuation of what Dr. Vishali said, once again, is the pre-test probability is the key. And that's where we have started in our settings in Singapore. Is we work closely with the TB specialist, and chances of they denying the patient anti-TB treatment when we send to them has come down quite significantly over last 10 years. The reason is that they know that when the patient is coming after me reviewing and vetting through the cases, there is always the pre-test probability has gone in. We have thought through it, and then when we are referring to them, so they're getting more confident. And today itself, I started one of the patient on anti-TB. That too on Saturday in Singapore is a big deal, and it was just on the phone call, and we started. And the patient tomorrow is holiday, Sunday, and Monday is also public holiday, and the patient will be seen by TB specialist only on Tuesday. So you can imagine how far we have come across, and it's all based on the building up that confidence. So as I've written in the chat bot, what you have mentioned is these are the algorithms which are designed, but it should not be just like final go, and there should be some kind of a human interpretation. So it is where a human interpretation comes in, where you pick up granulomatous uveitis or occlusive retinal vasculitis with certain characteristics, and then you enter into that I'm getting a retinal vasculitis. Otherwise, every single retinal vasculitis, if you enter, you will get some answer, and then you will say, oh, this calculator is not behaving. So that's something which goes without saying. And if you start using that smartly, I'm sure you will get benefit from those kind of tools. And then we can improve those tools also.
But the same danger will happen with pre-test probability again, Soumya.
Yeah.
Because if you just think every occlusive vasculitis is TB, and you think the probability of TB is high, the test will come positive, you will end up giving treatment because you fail to recognize CMV occlusive vasculitis or something else. So probably the algorithm would be safe for everything till the time one improves the clinical skills.
Yeah, if I may add there, I think, when we say pretest probability, it can't be just one thing which is the pretest probability, because occlusive vasculitis is a very broad term, and this patient had a Behçet's disease, and that's another picture. In a young lady, you think of SLE, and so you have to put in the right context when you interpret any picture.
That's
but like you mentioned in the beginning, I think the most important part is the right clinical evaluation. Now, if you saw the picture of intermediate uveitis that I showed, it was, labeled as intermediate uveitis for 5 years without noticing that in the supratemporal quadrant, there was a retinitis lesion sitting. And vitritis with retinitis lesion, you have to start thinking what might be the reasons.
That's absolutely right.
Thank you. Next, we will invite Dr. Alessandro Invernizzi. He will be speaking to us on viral herpetic posterior uveitis. We will have Dr. Neri's recorded talk next.
Thank you, Padma, for the kind invitation. Thanks, Vishali, as well. Can you hear me well?
Yes,
Yes.
Alex. Yeah.
Okay, so I'm gonna share my slides now, and
Perfect.
okay.
Go to sleep.
So yeah, so I'm gonna talk about viral retinitis, and these are my disclosures. Well, viral posterior uveitis are mainly divided according to the immune system of the host. So we have immunocompetent hosts, which can develop acute retinal necrosis or non-necrotizing herpetic retinitis, while immunocompromised hosts are known to develop progressive outer retinal necrosis or CMV retinitis. You all know this very well. So I'm not going to spend much time in, listing all the features of these entities. I thought it was more interesting to focus on what we find, new things, new evidences from the literature regarding these entities. So we know that acute retinal necrosis affects immunocompetent patients, and usually it starts from the periphery and then goes all around 360 degrees and then progresses centripetally, and it's usually accompanied with a lot of inflammation, both in the posterior segment and the anterior segment. Now, one of the key problems here is treatment, and this both in terms of systemic treatment and the decision to perform surgery, because we know that ARN is often associated with retinal detachment. Now, in terms of treatment, the standard treatment for this condition is intravenous acyclovir. However, I wanted to mention this paper, which came up in 2018, so it's already quite old, but someone may have missed it. And basically, the authors here compared the standard treatment, which is intravenous, as I said. So it means you have to admit the patient and keep the patient in your hospital for 10 days, in comparison to oral valacyclovir, but the authors are using the valacyclovir twice the dose as it's usually recommended by the label. So they're using 2 grams 3 times per day. And this treatment, which is oral, so it allows you to avoid admitting the patient to the hospital, gave similar outcomes compared to the intravenous one. So I'm not saying you should use this new treatment or less, allowing you to keep the patient at home and just checking the patient maybe every day or every 2 days. But just keep in mind that if you don't have the opportunity to admit the patient because your hospital doesn't allow you to, you don't have room for that, you can use this as a different alternative treatment. Now, coming to the surgery, retinal detachment can occur in about 50% of these patients. And there is this nice review published on Retina in 2021. It's a meta-analysis and a systematic review putting together a lot of studies. And they come up with some interesting points. So the first thing is that when ARN is associated with VZV rather than HSV, has a higher susceptibility to retinal detachment. So meaning that if you have VZV positivity on top, you should be more concerned about the retinal detachment. The second point is that if your patient is immunocompetent, then it's more likely to develop RD, and this is because your vitreous is going to mount a much stronger response, and it can end up with traction. And obviously, the larger the area of retinitis involved, then the more likely the RD to happen. And this is quite obvious because the retina goes to melt, and obviously it can create holes. And the larger the area, more likely this is to detach. Now, regarding treatment, there's been a long debate on the usefulness of prophylactic laser, and apparently, according to this meta-analysis, the laser does not have any does not give any significant advantage if performed prophylactically. On the other hand, early postprandial vitectomy seems to have seems to decrease the incidence of RD significantly. I'm not saying to perform PPV to all these patients, but you should strongly consider it at an earlier stage. Moving on to a different aspect of the disease, I want to point out this case that happened in our clinic. This patient had ARN, and it resolved completely, so it was doing well. He did not receive surgery, and after a while, we decided to submit the patient to the vaccination, Shingrix for VZV, and after a few days after the second dose, the patient developed cystoid macular edema and a mild inflammation in the back of the eye. So we treated these with steroids, and after a while, it went back to normal. So in Italy, this vaccination is recommended to all patients who had central nervous system involvement secondary to VZV, and so the eye is considered part of the CNS, so they recommended this vaccination, and obviously it makes the immune system stronger against recurrences, but it can also trigger a sort of inflammation secondary to the vaccination, because portion of the virus can remain in the retina, and so the immune system, once triggered, can have a sort of rebound in the inflammation. Once again, it doesn't mean you don't have to vaccinate your patients, but keep in mind that this can happen. Now, moving on to immunocompromised hosts, we have to think about not just AIDS patient, but a lot, many more groups of patients. We give more and more immunosuppressive treatments to our patients. There are malignancies. Patients, very old patient may develop immunosenescence. And also patients with uncontrolled diabetes, for example, can have immunocompromisation. Now, in immunocompromised patients, you may have progressive retinal necrosis from VZV or HSV, but I would say that the most important viral retinitis for this group of patients is CMV retinitis. We know that CMV retinitis can present in protein manifestations. It can have these three typical patterns, so the pizza-like, the granular, and the frosted branch. And obviously, it can be very devastating in case you don't treat it, even if the progression is usually slower compared to the one of VZV and HSV. Now, it's normally treated with a series of different drugs, and on top of the systemic treatment, you can also perform intravitreal injections of ganciclovir or foscarnet in case the patient cannot receive the systemic treatment because of the immunocompromisation or other problems. But I want to draw your attention on a new entity, or it's not new anymore. It was described a few years ago, but it's still kind of re-emerging. And it's what happens when the patient is not immunocompetent, but is not immunocompromised as well. So what's in between an immunocompetent patient where CMV cannot affect the retina and an immunocompromised patient where CMV is able to give a necrotizing retinitis. Now, here in between, there is a new entity called chronic retinal necrosis. And in these patients, what you may see is that there is a partial immunocompromisation. So you may have a slight response of the immune system. You may have mild inflammation, mild vitreitis, and usually you're going to see a massive occlusive vasculitis and just a tiny patch of retinitis, usually at the periphery. Now, the explanation for this condition, and most importantly for the massive occlusive picture, is that there is a reaction of the immune system against the virus. The immune system is able to limit the extension of the retinitis, but the price to pay is that there is this development of this occlusive immune-mediated vasculitis. So these patients benefit from the treatment for the antiviral treatment, but you also have to deal with the massive ischemic changes. So you may want to give them laser and monitor for new vascularization. So now, related to the CMV, we have to keep in mind the standard picture we've learned on the books for immunocompromised patient, but also this new, let's say, mixed picture. One last point. Keep in mind that immunocompromised patient may have other entities that can mimic viral retinitis. So, for example, toxoplasmic retinitis can present with this atypical feature. And if you perform OCT, the involvement of the choroid can help you differentiating between these two entities. But my recommendation is when you're in doubt, don't rely just on imaging and always perform a tap. It can be a tap of the anterior chamber, so you can have aspiration of the aqueous, and this is usually enough. Or you can go for the vitreous tap and inject, antiviral or antitoxin treatment. Last but not least, I want to share with you these couple of cases that are atypical. So we had a couple of patients where we had this kind of very weird mixed picture. It had features of CMV and VZV as well. And in fact, they came positive on the top for both viruses. So this is something that it's quite unusual. And we treated them with intravitreal foscarnet to cover for both entities. And the last is this guy who came with this very weird, atypical bilateral presentation. The left eye had these kind of atrophic changes, very visible on OCT, and the right eye had these atypical sort of retinitis, but with completely absence of inflammation. And this patient ended up having measles-related retinitis. He had suffered from encephalitis in the past, but he had survived, and now the retina was the target of the virus. So to conclude, always keep in mind that herpetic etiology should be in your differential when you have unilateral involvement. The herpetic retinitis can have protein clinical picture, and always consider tap and inject when you're not sure about your diagnosis. And I thank you for your attention.
Thank you, Dr. Alexander, for the excellent illustrative talk. Thank you so much. In spite of your emergency duty, thanks for taking up and giving us the talk. Yes, since we are running late, we'll go ahead with the next speaker, Dr. Mansaf Kairala. He will be talking to us on newer viral posterior uveitis. Over to Dr. Kairala.
Thank you very much. Can you hear me, please?
We can hear you.
Yes, Mansaf, we can hear you.
Thank you.
Yeah.
So my talk is about new viral posterior uveitis, and as you know, sorry. RNA viruses often replicate more rapidly than DNA viruses and exhibit high mutation rates. And emerging RNA viruses are responsible for recent outbreaks and pandemics, including arboviruses and other viruses. they pose a global burden of morbidity and mortality with significant socioeconomic consequences. And RNA viruses may involve all ocular structures, including the retina, choroid, and optic nerve. The first important RNA emerging viruses is arboviruses. They are transmitted by the bite of arthropods, mainly mosquitoes, and these infections mostly occur in the tropics and subtropics, but they are expanding worldwide due to climate changes and globalization. Systemic disease is often asymptomatic, mild, or non-specific, but these infections may present with specific features and serious complications. Main arboviruses causing ocular disease include West Nile virus, chikungunya, dengue, Rift Valley, and Zika, and here the main epidemiological and systemic characteristics of these viruses. West Nile virus is an important cause of bilateral multifocal choroiditis. You can see here an active bilateral multifocal choroiditis with deep round chorioretinal spots with early hypofluorescence and late staining on FA. And you can also see the typical linear clustering of chorioretinal lesions. This linear clustering of chorioretinal lesions become more evident in inactive chorioretinitis. Retinal vasculitis is another important finding in West Nile virus infections, including retinal vascular sheathing and occlusive retinal vasculitis, with diabetes as the most important risk factor. Other manifestations, ocular manifestation of West Nile virus include optic disc edema, retinitis and neuroretinitis, and many other findings. The second important arbovirus is chikungunya that may cause unifocal or multifocal superficial retinitis in the posterior pole, typically associated with minimal vitritis and usually associated with retinal edema, serous retinal detachment, and retinal vasculitis. But there are many other manifestations that may occur in association with chikungunya, including anterior uveitis, optic nerve involvement, and many other ocular changes. Dengue is another important emerging infection causing ocular involvement. Dengue maculopathy is a typical finding in dengue virus infection, including cystoid macular edema, diffuse macular edema, and foveolitis. Many other ocular changes may occur, including, as you can see, retinal vasculitis, serous retinal detachment, subconjunctival hemorrhage, usually associated with severe thrombocytopenia, and anterior uveitis. But keep in mind that dengue can be associated with unifocal or multifocal retinitis, similar to the retinitis observed in chikungunya. Another important form of retinitis and dengue fever is necrotizing retinitis, and necrotizing retinitis is usually associated with a poor visual outcome. Rift Valley fever can cause blinding macular or paramacular necrotizing retinitis. Zika is an important arbovirus, and ocular involvement associated with congenital Zika include focal pigment mottling, atrophic chorioretinal lesions, and optic nerve changes. Risk factors for congenital ocular Zika mainly include severe microcephaly and the mother's symptom during the first trimester of pregnancy. Therefore, ocular screening in all infants exposed to Zika during pregnancy is recommended with regular follow-up later. Ocular manifestation of acquired Zika infection include conjunctivitis and orbital pain, and rarely hypertensive or normotensive anterior uveitis, and in some cases choroidal unilateral maculopathy, and neuroretinitis. The management of arboviral disease, no proven antiviral treatment. Treatment is mainly supportive and symptomatic. Treatment of ocular disease may rely on local or systemic corticosteroids and other modalities. Prophylaxis is the mainstay of arthropod-borne disease control, and vaccination exists against yellow fever, more recently dengue and chikungunya, but it is still in the research phase for almost all arboviruses. Another important emerging viral disease is Ebola, with outbreaks mainly in West Africa, with a very recent outbreak in the Democratic Republic of the Congo and Uganda in 2026, with imported or locally acquired cases in North America and Europe. This is a very severe viral disease. Ocular involvement may include conjunctivitis, subconjunctival hemorrhage, vision loss of unclear origin in the acute phase, and in 20 to 30% of survivors, we can have different forms of uveitis, including anterior uveitis and posterior uveitis with multifocal chorioretinal lesions. Treatment is supportive and symptomatic, and there is a recently FDA-approved Ebola vaccine for Ebola. COVID-19, as you know, this infection may cause a wide spectrum of ocular infection manifestation, including uveitis, with many reported cases of non-infectious or infectious uveitis, with development or reactivation of uveitis, and here some cases of uveitis after COVID-19 infections. COVID-19 and vaccination has been associated with ocular manifestations, including some forms of uveitis. Mumps is an re-emerging infection that mainly occurs in children and adolescents with suboptimal vaccination coverage, or in patients with waning immunity or vaccine failure. And mumps may be associated with anterior segment manifestation, optic neuropathy, retinal vasculitis, and a typical bilateral outer retinitis with a poor visual prognosis. So in conclusion, emerging viruses have the potential to cause significant morbidity and mortality of global dimension. Ophthalmologists around the world should be aware of their increased role as causes of uveitis and as causes of other ocular manifestations, and early clinical diagnosis is essential for proper management to try to prevent systemic and ocular morbidity. We should have a global perspective and always consider geographic history, epidemiological context, and specific systemic symptoms in any patient with uveitis, and prevention remains the mainstay of control for most RNA viral diseases. Thank you for your attention.
Thank you so much, Dr. Kairala, for the excellent presentations and an informative talk about newer viral infections. It's a real challenge whenever we see them clinically diagnosing, and also there is no specific treatment is available. Yes. Our panelist, Dr. Anju, is here. I would like to hear from her. And also they worked on a novel infection like SHAPU. You can tell us about it.
Thank you, Dr. Padma. Yes, I have been talking about SHAPU for a couple of years, and yes, it is definitely a novel kind of disease, uveitic disease, especially found in Nepal. And in regard to its like whether it's infectious origin or it is inflammatory in origin, we are trying to do couple of investigations regarding the inflammatory cascades and the metagenomic sequencing. So earlier we used to do the culture sampling, and there we had a couple of organisms which were detected in the cultures. Then we shift on to metagenomic sequencing in 2019 samples, where we found that there were presence of Acinetobacter varicini and Streptococcus pneumoniae, but at that time only in 2 out of 10 samples these organisms were present. But at that time we didn't have a control group with the conjunctival flora. Then we shifted with the metagenomic sequencing in 2021 outbreak, where we could find that the streptopneumoniae were present in few of the samples, in the vitreous samples, in the conjunctival sample, but we didn't have the control of the other eye. Then we shifted in next outbreak with a sample from the other eye, and the organisms were changing. One of the common organism was streptopneumoniae, but it was not that all the cases had presence of streptopneumoniae genome present in the analysis. So what we believe is like it's basically an inflammatory cascade that is caused by the toxins or the immune released from the moth setae, and this causes some breach in the ocular immune system, so that it makes the common cells or the opportunistic pathogen permeable to the intact ocular tissues and leading to the insult within the eye in such a rapid way. So we are still exploring. Now we think that just understanding the ocular samples, understanding the inflammatory cascade, understanding the metagenomic sequencing in the DNA and RNA is not enough from the ocular samples. So now we are moving the test to the moths, and we're trying to understand what actually is present in the CT of the moths. So we are running a lot of toxin related analysis, and hopefully we'll come up with newer results to share with the team in the upcoming presentations. Thank you.
Thank you, Dr. Anju. Can we have a next presentation, Professor Neri's talk?
Yes, so I'll be sharing the screen. Are we able to see presentation?
Good afternoon, everyone. I'm sorry I cannot attend in person, given some technical issues. And I'm very glad to talk about ocular syphilis, diagnostic and management, and guidelines. Looking at the syphilis history, we have to thank Dr. Girolamo Fracastoro, who was a Viennese physician who gave the name of syphilis to the disease, recalling a shepherd called Syphilus, who had been punished because he defied the sun god. Syphilis can present itself as anterior uveitis. Generally, is a solitary unilateral iritis. This is at baseline, but in 50% of the cases can become bilateral. The spectrum of severity can vary from mild to severe, often is associated with cutaneous rash, and we can see that it's very often steroid resistant. More interestingly, the posterior manifestation of syphilis in the posterior pole are more heterogeneous. We can have the superficial retinal precipitates, multifocal retinitis, retinal choroiditis that can present itself as confluent and placoid, as well as papillitis and neuroretinitis. Let's have a look to the superficial retinal precipitates. Really, one of the important aspects of differentiating these types of retinitis does lie in the OCT pattern highlighting the location of the infiltrates. Fundoscopic exam shows a subhyaloid hypopyon and superficial appearing preretinal puffballs in the picture that I'm showing here in the slide. However, macular OCT shows the hyaloid that is still attached, and there is a prominent vitreous inflammation. At this stage, we may argue whether these are precipitates or accumulations. And I can tell you that when I talked to my friend Emmett Cunningham, he said that probably those are just the white cells accumulated. Nothing has actually precipitated, and there is no involvement of the underlying retina, so probably they are better defined accumulations. Regarding the multifocal retinitis, we can see that the lesions are intraretinal, as per what we can see here at the level of the OCT. They are always reported after administration of systemic or intravitreal corticosteroids, indicating that probably there was lack of appropriate anti-thyroid polemon therapy that might have covered the spread out of the disease. We can see here that the medical literature is full of reports, and particularly there are some prominent groups, such as the one from Brazil, led by my friend Andrew Curry, that reported some interesting immune phenotypes. Moving forward to the retinal choroiditis, we can see that this involved the retina more than the choroid. There are two different kind of fashions. One is the confluent and the other one is the placoid. Technically, the confluent retinal choroiditis can have the ground glass appearance or the dense appearance. When it's ground glass appearance, this is often triangular in appearance. The retinitis is not as densely necrotic as, for example, in HSV or toxo, and frequently is associated with vasculitis and overlying accumulations. Harder it is to distinguish the ARN and toxo secondary ones compared to the ARN and toxo-like syphilis one, because you can see that they are very looking like. The ground glass appearance as superficial accumulations. The retinitis is not dense, as you can see here, and has a triangular shape, as you can see here. At fluorescein angiography, you can appreciate the vasculitis as well as the hyperfluorescence of the margin, which is very pathognomonic. When we moved forward and we want to see how the placoid form is, when you look at just a sector of the retina, sometimes it's very difficult. You need to look at the broader picture, as well as you need to pay attention to details to other imaging techniques, such as the fundus autofluorescence, so that you may appreciate, how the placoid form seems to be very apparent. When you run an OCT, while in the periphery, sometimes you can have a hard times in detecting potential peculiarities of the disease. These are more evident in very important areas, such as in the center of the macula, where you can see that the granularities are very typical of the acute syphilitic posterior placoid chororetinitis, or ASPPC, if you wish. So the multimodal imaging is very important in ASPPC, starting from the color picture, going forward to the fundus autofluorescence, as well as the fluorescein angiography, and it's important to pay attention to all the different phases, as well as the ICGA, where you can see the ischemia, which is very pathognomonic. Now, it is important also to use the OCT for monitoring the clinical course. First, it is important to see that at baseline, you may see the granularities and irregularities of the RPE level, as well as the subretinal fluid. You may see in the mid-phase that the granularities are reducing, as well as the disappearance of the subretinal fluid. And last but not least, you may see that the structure of the retina is back to normal after the entire course of the clinical treatment. Last but not least, the papillitis and neuroretinitis. When you look at pictures like this, you may see that they are very apparent. You see that subretinal fluid, the papillitis with edema, and you have also satellite hemorrhages. When you run the fluorescein angiography, you can see that this is very apparent. The Humphrey visual field here can detect very easily the visual field defect. However, this is not typical of syphilis, as it's not pathognomonic, and you have to pay attention and put an effort to try to put this into a framework where you need to run the differential diagnosis. Of course, all this potpourri of different pictures can be difficult to be interpreted. That's why the multimodal imaging in uveitis task force is working hard to create a framework that can help you to clarify on how to interpret all the images. Now, when you have ocular syphilis, you need to diagnose it very loud and clear. And sometimes one thing that is very difficult is that the suspect that is raised by imaging is not absolutely obvious. So the serology is very important, and back in the days, we used to use the traditional algorithm, using non-triple enamel test first and then triple enamel test second. In the modern approach that has been proposed by the CDC, we use the so-called reverse sequence algorithm, using triple enamel serologic tests first and then the non-triple enamel serologic tests. The interpretation, so, is a positive serology plus compatible inflammation support diagnosis that needs to be monitored by the RPR and VDRL titers. And we need also to use the triple enamel test that may remain positive for the rest of life, which are not really telling us how the disease is responding to treatment. One of the things that we are debating the most is the use of the CSF testing. When do we have to do this? Well, it is pretty obvious that we need to do this in any neurological manifestation. So cranial nerve dysfunction, meningitis, stroke, altered mental status, and sensory deficits are indicating the need to test the CSF. While when they are not present, of course, this is not compulsory. So the clinical message that is at the bottom line is to proceed with treatment when you have the evidence of the ocular syphilis and do not wait the CSF testing. Otherwise, you may waste time and the clinical outcome can be strongly impacted. What should we do when we have to treat syphilis? Number one, the recommended regimen is to use an IV penicillin G 18 to 24 million units per day, like it is in neurosyphilis. And why is like that? Because the ocular syphilis is exactly treated as a neurosyphilis. So the important part is that you have not to use the standard intramuscular benzathine penicillin regimen for uncomplicated syphilis, because it's not going to work. So in conclusion, what should we do for the follow-up and practical pathways? Well, number one, for the follow-up, monitor serial RPR and VDRL titers. So when you have the diagnosis of ocular syphilis, the clinical improvement is essential. And last but not least, repeated CSF exams are usually unnecessary. Special consideration needs to be done for HIV. You need to test all patients for HIV because you know how syphilis is contracted. And it's important to treat the patients with ceftriaxone only when penicillin cannot be used. However, desensitization remains preferred when feasible, and you should treat the patient with penicillin. I wish to give you just a sort of framework that can be useful to understand what you have to do if you are in front of a potential syphilis. Number one, remember that imaging can help you out in raising the suspect. Second step, order both serologic tests and remember the framework that has been proposed by CDC. Evaluate neurologic signs and ask for the CSF only if necessary. 4, treat with IV penicillin and remember to monitor the clinical course, studying the RPR and VDRL, plus the treatment response that can help you out in understanding whether you're doing the right thing. Last, I want to tell you why I couldn't be able to attend in person. It is true that here the connection, internet connection is horrible, but you cannot tell the same about the beautiful view from my parents' house. I invite you one day to visit my very little village where I was born more than 50 years ago. Thank you very much and enjoy the rest of the Congress.
Thank you, Professor Neri, for the nice presentation. So I would like to conclude the session. At the outset, we would like to thank Dr. Santosh Honavar and AOC team for the opportunity to have a separate session on retinal and choroidal infections. I thank our chairperson, Professor Vishali Gupta, the panelists, Dr. Anju and Dr. Rupesh Agarwal for the presence. And I thank all the speakers for the excellent presentations. Dr. Alexandro, Dr. Daniel, Professor Mansaf Kairala, Dr. Neri, and Saumavya Basu for the excellent presentations. And also I'd like to thank all coordinators, Dr. Rolika Bansal, Dr. Pratik Nishant, and Dr. Richa Pare for coordinating this session. Thank you one and all.
Thank you, ma'am. But before we sign off, can I request all the speakers to just switch on their cameras for 1 second so that we can take a commemorative picture, please?
Results for these cases are not yet out. But in parallel, Singapore
I think our session, most of the people have already left anyway. We'll just take a quick picture, Dr. Rolika, and then we'll wrap
Yeah,
it
we
up.
can take a screenshot from the previous videos as well. Don't worry.
All right. Thank you.
Thank you, everyone.
Thank you. Thank you so much.
Thank you so much.
Thank you, everyone.
Thank you, ma'am.
no cellular
Have a wonderful weekend, everyone.
Thank you. Wishing you the same. Thank you, everyone.
Thank you.
contact lens type material.
So I believe our next session team has joined.
Hi, Rolika.
Hello, sir. Hi, sir. So we are going to continue to be live. We are not going to stop the live, but your session
Sure.
begins in 5 minutes. So we have time. If anybody wants to share the screen and just do a quick check, we can do that.
Yeah, sure. Purna, you want to do that?
Hi,
Dr.
good evening,
Joy, are
everyone.
you there? Good evening.
This is a different concept.
Just wanted to confirm, is my audio is better, no? Like
Yes,
I'm
sir.
not using any microphones.
Yeah, your audio is fine, Purna.
Perfect. Thank you so
Very
much.
clear.
And we also have with us Dr. Girish Velas and Dr. Tanya, who will be helping you coordinate everything. So if you
Right.
need anything, please let us know. And we have to share the session screen. So if anybody would like to check their presentations, after that we will share the session screen so that it remains open.
Sure. Dr. Ajay, good morning. Would you like to check your screen first?
Yes, please. Thank you so much.
Thank you.
Very good evening, everyone.
Good morning, ma'am. Dr. Anita.
Hi, Sumer. Good morning.
It's early morning for you?
Yeah, it's okay. Not bad.
Not bad.
Slept early.
Morning, ma'am.
Yes, I'm gonna get this. Maybe I should just take it off my monitor.
Yeah, Dr. Joy, it's on full screen. We can see it clearly now.
Is it clear?
Okay.
Yeah.
Yes.
Okay, so are you seeing the right screen, not the present view? It's the right screen, right?
Yeah, it's the full screen view, not the present
Thank you.
view.
Thank you.
Thank you.
Lisa, what's the commonly used color? Because I can see only me using green color.
Is there a IRD color, by the way? Like
IRD.
cancer have purple, pink. Is there a IRD color?
That's a good addition.
I was trying to keep the lights off there, so I guess that won't work. I was trying to see if I could.
Hi, Dr. Omar. Welcome. Thank you so much for joining in again.
No, thanks again for the invitation.
Good evening, Dr. Omar. Good evening, Dr. Ajay.
Good evening, everyone. Thank you.
It's still dark, huh? I was trying to keep the lights off the screen, but I guess I can't help much of it.
That's
Is that
fine,
okay?
ma'am. You're clearly visible.
Okay.
There's some glare effect coming from that,
Rays
but
of
that's
light,
fine.
so
I
it's
know, I
good.
was trying to put the lights off, the ones that are, no, maybe these are the ones that are, I'm gonna do that, I think. Yeah, it's still a little dark outside.
Dr. Omar, ma'am, would you like to check your presentation once?
Yeah, may I?
Yeah, please do, ma'am. You just
Go
have
share.
1 minute to go.
Share settings? No.
Good evening, everyone.
Good evening, sir. Thank you for
Good
joining
evening.
in.
Good.
Can I share it or?
Yes, please go ahead, ma'am.
I'm trying to see share settings. Where's my share?
Usually at the bottom, there's a green arrow.
I know I can't get the green arrow. I got a black arrow.
There's a share button at the bottom, ma'am.
Yeah, for some reason it's not showing up. Let me see. The share's there, but the share's got, okay, there we go.
Yeah.
Yeah, great.
Yeah, it started, ma'am. You can go on full screen once.
No, hold on. Yeah, okay. I guess I got the first slide here. Okay, there you go. Is that okay?
Not yet.
It's not in presentation mode for us.
Yeah, it's in presentation mode. Is that okay?
No, we are not seeing the presentation.
We're just seeing the
ma'am.
slides.
We are seeing the slides with the slide deck on the left.
Maybe use the, if you go to the bottom and to the right of your screen, if you hit the presentation just before the zoom arrow, you have the minus and just before the minus sign, the icon that you see.
Yeah, I got it there. That's what for me, it's on presentation mode.
Oh, sorry.
For me, it's on presentation mode. For you guys, it's not, right?
Ma'am, you can
Yeah.
first disconnect it once. I mean, like you can unshare the screen, then go to the presentation mode, and then again
Then
share the screen. And select the one which is on the presentation mode, then it automatically will connect.
You haven't got two screens or something. Sometimes that
No,
messes it.
only have one. So I do stop share and come back.
Yeah, it stopped sharing now.
Okay. I'll make sure I put the right one. Okay. Is it okay now?
Yes,
Yes,
that's perfect.
this is good,
Okay.
ma'am. Yeah, continue to share. This is good, ma'am.
Okay, thank you.
This is good. You
All
can
right, I can-
you can
I can
escape and
unshare
stop
now.
sharing, ma'am. Yeah.
Okay, perfect. Thank you.
Dr. Omar, if you would want to do that quickly, and then we can
Okay,
maybe
sure.
start this session.
So if it's okay, if we can begin the session.
Are you seeing that okay?
Yeah, we're seeing that.
Okay, great. So I'll stop.
Yeah, it's perfect. Thank you. Yeah, so Rolika, can we start?
Yes, so we can begin the session. Dr. Girish, would you like to share out of
I
Dr.
will do
Girish or
that.
Dr. Tanya?
Hello.
Yeah, hi.
Hi, everybody. Welcome to the session for inherited retinal diseases. I now invite Dr. Deepika CP and Dr. Simar Ranjan Singh, sir, to please take over as the moderators for the session.
Thank you so much, Tanya, and thanks to AIOS and Dr. Honavar and his team for this excellent composition of the sessions for this International Ophthalmology Congress, and for giving inherited retinal diseases a chance in this meeting. So we have an elite faculty lined up for you who will be sharing their thoughts on this group of disorders. Our chairman for the session is Dr. Anita Agarwal. She's the editor of the 5th edition of the most coveted GAS Atlas of Macular Diseases, and working at West Coast Retina in San Francisco, USA. And along with, we have Dr. Omar Maharouf from the Moorfields Eye Hospital, London.
Deepika, you would want to take over?
Yeah, thank you, Dr. Simar. Thank you, everyone. I would like to begin with the next LH speakers. It's my pleasure to introduce and invite Dr. Ajoy Vincent, who is a clinician scientist and professor of ophthalmology, an IRD ocular genetics and electrophysiology expert at the Hospital for Sick Children, Toronto, Canada. We welcome you, Dr. Vincent, for the session. Thank you for being here. I would also like to welcome Dr. Subhadra Jalali. I think she'll be joining in a while. She's the Network Director, Quality, and Director of Newborn Eye Health Alliance in LV Prasad Eye Institute, Hyderabad, India.
We also
Yes, Dr. Simar.
and I welcome Dr. Vinod Agarwal, sir, who is Professor of Ophthalmology at the RP Center, All India Institute of Medical Sciences, New Delhi, and Dr. Parveen Sen, ma'am, who is an alumnus of the Shankara Nethralaya, Chennai, and now working at the Garewal Eye Institute in Chandigarh.
I would invite two more colleagues and friends, Dr. Poonat Chandra B., who is a senior vitreoretina consultant and IRD expert at Narayan Nethralaya, Bangalore, India, and my dear friend, Dr. Shrikant Padi, who is at LV Prasad Eye Institute, Bhubaneswar, India. Welcome you all. Thank you.
Thank you so much all for accepting our invite to be part of this session. And I would just ask Dr. Anita ma'am to give a brief introduction, and then we can start with Dr. Omar's talk. Ma'am, you're muted, ma'am. Dr. Anita.
Good evening to all the listeners and viewers in India, and good morning and good afternoon to anybody else outside of India. I think this is a huge honor for me to be able to be the chairperson of this session. My greatest friends, Omar, is here, and I've learned a lot from him. You know, all of us are dipping into inherited retinal diseases much more widely now than we were in the past, because we couldn't do genetic testing and really understand these diseases. As we've learned new sort of manifestations of certain diseases, we've learned a lot of unanswered questions have opened up. Whatever we phenotypically put them into different categories in the past are totally opened up, and now we really don't know exactly where to put what. Everything is usually based on genetics, the final diagnosis. Still, phenotypic recognition is very important, and I think today's talk will teach us at least how at this very early part of IRD deciphering stage of our field, we kind of have making steps towards figuring out what these diseases are. And I think the first talk will be by Dr. Maru, who'll take over, and then there'll be two of the talks following that. And they have a couple of case presentations and panel discussion, which I think is really, really important, because all of us are learning new things and none of us know all the answers, or don't know even a few answers. Thank you.
Thank you so much, ma'am. I request Dr. Omar to start his talk. Dr. Omar will be talking on diagnostic dilemmas in inherited retinal diseases.
Great. Thanks very much for the invitation. It's a huge honor, and it's an honor to be on a really esteemed panel. I'm looking forward to the other talks and the discussion. So my talk will be just a kind of short 10 minutes, whatever we can cover, some thoughts on diagnostic dilemmas we face in the field of inherited retinal disease. So you have a monogenic inherited retinal disease that we may be quite convinced it's monogenic. And even there, we don't always get the genetic cause. So sometimes we get variants of uncertain significance in our genetic reports, or no primary findings, and we don't know, does that mean it's not genetic, or are these findings relevant? Different panels have different coverages. Is it syndromic or non-syndromic? Sometimes we find a gene that's associated with syndromic disease, so we screen other organ systems. But now we're realizing there are certain genes that different variants give you syndromic or non-syndromic disease. And sometimes you find a gene that's associated with neurological disease. You worry a lot for your patient. You know, does that mean they're going to develop neurological symptoms? How should you address that? Or we now know certain variants seem to never give you neurological symptoms. So we're learning in that area as well. The inheritance, we think it's very easy. Sometimes it's not. We have a recessive disease, but one of those variants, like in Best disease, sometimes acts dominantly. So you don't know how to counsel the patient about the risk to children. And we have some families where there are more than one genetic cause going on. Then we have all of the mimickers. So the common thing we face increasingly nowadays is these patients bouncing between the IRD and the uveitis clinic. Is it uveitis? Is it inflammatory? Or is it genetic? And sometimes we're not sure. And there are these mimickers, autoimmune disease, autoimmune retinopathy, which could be paraneoplastic or non-paraneoplastic. We might get anti-retinal antibodies, but their significance is often uncertain. Are they just a bystander? Are they doing something else? To complicate things further, we have monogenic causes of autoimmune or inflammatory diseases. So the treatment is still maybe an anti-inflammatory agent, but the disease is genetic. So how do we deal with those conditions? And then there's a whole load of other differentials as well that we should also keep in mind. We've had patients with certain infections mimic IRDs, or sometimes they have an IRD and they also have an infection at the same time, and you don't know which one's causing their disease. Lymphoma, you have a vitelliform lesion, people are calling it Best, turns out to be lymphoma or something else. Various drug-related toxicities can mimic IRDs, and we're becoming increasingly familiar with them, so we need to take a good drug history. Many patients referred with a query IRD, and it's didanosine-related toxicity, and often that history isn't volunteered or necessarily in the patient's notes that they've had HIV for a long time, and they've had these various treatments. Vitamin A deficiency, very uncommon in the Western world, but we still see it now and again. For example, in patients with liver disease or bowel problems affecting absorption, and they get referred with night blindness. Is this an IRD? And sometimes maybe in the Western world, we're less likely to think of vitamin A deficiency because it's relatively less common. Or optic neuropathies, are they toxic? Are they inherited? Is it something else? And then certain, we might say in inverted commas, degenerative conditions, but they can also sometimes mimic or get misclassified as IRDs or the other way around. And so working out which of these is the cause in our patient can sometimes be tricky. We think IRDs are easy. We thought that, right? Who thought that? I don't know. But now we realize it's actually quite tricky in many cases. And some patients have more than one thing going on. We've had patients with an infection and an IRD, or some inflammatory disease going on and a genetic cause to part of their retinopathy. So sometimes patients don't just have one disease like we like them to. They have more than one thing going on, and it becomes difficult to disentangle. One thing I've become interested in recently is distinguishing from AMD. So we think IRDs present in young patients. That's not always the case. We see late onset presentations as well. And maybe we thought, actually, does it matter? It's either a macular dystrophy or it's non-exudative AMD, dry AMD. What's the big deal? You can't treat either. So if you misclassified one, well, sometimes the inheritance can be different, and you might want to know. Even if there's exudation, so you have a macular dystrophy with macular neovascularization, a CNV, or is it exudative AMD? What's the difference? You treat both with anti-VEGF, and often that helps. But now we have these newer therapies, these complement-directed therapies for non-exudative AMD, right? Which may work, may not work, approved in one place, not approved in another place. Now you probably do want to really know, is this patient actually got geographic atrophy and might be eligible or not for these therapies? Or is it a macular dystrophy masquerading as dry AMD, in which case we wouldn't want to use these therapies that have risks? Or we now have growing numbers of IRD treatments, so we want to know that this is a macular dystrophy and not AMD. Similarly, for treating macular neovascularization with anti-VEGF, you would do that in both cases, but the endpoint parameters might be different. So we're seeing lots of patients with Best disease. It's more common than we thought for them to get some neovascularization, which can be exudative and benefit from treatment, but the outcome or endpoint parameters might be different. So in Best disease, often the return of the subretinal fluid is a sign that that patient is resolving and they're doing well. Whereas in, obviously, with wet AMD, we try to treat until the macula is dry. So again, you might want to know, what are you dealing with? We published this just last month, actually. It's got a bit of a mouthful title, Non-Cancerous Monogenic Mimics of Non-Infectious Posterior Uveitis, just to look at the monogenic diseases that can look a bit like uveitis. And so you can have a look at that for a bit more information. By no means is it an exhaustive review. We published this last year where we looked at some different, a few different panels for IRDs and find that they don't all cover the same genes, and there are some that are covered by some and not by others. So again, it's something worth noting. Just because you have a negative panel test doesn't mean your patient doesn't have an IRD. Either the gene may not be discovered, or it may just not be on that panel. So you need to, it's helpful to be aware of what genes have been discovered more recently that could be important in your patient. So now, just in the last 5 minutes, some cases that illustrate. I actually have a case that illustrates every one of these points, but we haven't got enough time, obviously, to cover that. But so just a couple of cases. This was a 52-year-old who had 2 years history of subacute visual deterioration. Nothing much in his medical history otherwise. He was referred from abroad, came to Moorfields. Vision was 6/24 in both eyes. That was his pseudo color, maybe something a little bit abnormal there. The autofluorescence is more informative. That does look abnormal. Bilateral, symmetric, but not really screaming any IRD that we know very well. That's the spectralis autofluorescence. And we see outer retinal loss and intraretinal fluid on the OCT. And it turns out that when we investigated this patient, he was positive for syphilis. And there were features in his presentation that probably suggested that more than an IRD. It didn't look particularly like the IRDs we're familiar with. Genetic testing had already been initiated, but that was cancelled as we knew he had syphilis now, and he benefited from antibiotic treatment and his vision improved. So good differential to be aware of. Here's another case, a 50-year-old man who'd had about 5 to 10 years of blurring of vision in the left eye. He was diagnosed with central serous retinopathy. He even had PDT, which didn't really help. Some other things in his ocular history. This is his fundus appearance and something going on in the left macula, not much in the right macula. The autofluorescence gives it away a little bit more that he's got this hyper-autofluorescent lesion in the left macula. Even the right OCT, which was deemed normal, has something going on there. And the left OCT clearly has this elevation, vitelliform lesion, gets hyperreflective when you get into the lower scans. So we thought this is likely Best disease. We said, we think the previous diagnosis may not have been right, though it was reasonable, but we think it's Best disease. We were quite confident. We even did ERGs. EOG was subnormal, as we'd expect, but his molecular testing report came back negative. So then we had to say, we were very confident it was Best disease. Now we're kind of not so sure. But the answer is, if the phenotype really screams Best disease, if it walks like a duck, talks like a duck, has the EOG light rise of a duck, it's probably a duck. This thing looks like Best disease to us. And when we looked at this report in more detail, right at the bottom in this big list of variants of uncertain significance was this variant in Best 1 that looks like it's not in the coding region. What does that mean? Turns out in a different transcript, and now we need to be aware of gene transcripts, which we weren't really thinking about before, that same variant is a well-known missense mutation that we've got in other patients with Best disease. So he actually did have Best disease, and we were able to genetically confirm that and know that he doesn't need any more PDT. Final case, this was a 42-year-old loss of vision in one eye sequentially. The other eye goes a few weeks later, painless. LHON was diagnosed, had other causes of an optic neuropathy excluded, progressed a little bit since, counting fingers now in both eyes. LHON mutations, the 3 common mitochondrial mutations, were negative. That can happen. And then he was recruited for whole genome sequencing. We had this thing called the 100,000 Genomes Project, and that turned up 2 variants in EYS, a stop mutation and a rare missense variant. And EYS, as some of you will know, is associated with autosomal recessive RP. So he was referred to my clinic. And one thinks, did he have RP all the time? These neuro-ophthalmologists, did they not know what they were doing, calling it LHON? And it's actually RP. Actually, obviously not. They did know what they were doing. When we look at the patient, no sign of RP, pristine optos and autofluorescence, but pale discs. OCT, outer retina pristine, but he's lost his nerve fiber layer and ganglion cell layer in both eyes. So no doubt this is an optic neuropathy, and the EYS is incidental, not causing RP in this patient. Probably they could either be in cis or maybe that rare missense variant is benign, and people are forever overcalling things in EYS, which is a big gene that can have lots of rare variants in. So then what's the cause of his optic neuropathy? I consulted a friend who is an expert in inherited optic neuropathies, and she was able to look at his data, identify him in the data, the data set from his EYS variants, and he had homozygous variants in this gene DNA JC30, which we may not be familiar with, but it's the commonest autosomal cause of LHON. So weirdly, though it's autosomal, you still get a male preponderance. You get one eye going, then the other. And just around that time when we were seeing this patient, this had been described as a cause, an autosomal cause of LHON. So this is happening increasingly now. It used to be we decide on the testing. Now patients are coming with their genetic test results in their hand. And we have to work out, is it relevant or not? Still, we need to use our clinical skill and the phenotype to guide whether those genetic findings are relevant or a red herring. The advantage of having this wide whole genome sequencing or large panel testing is we don't even need to do another blood test. We just look at the data again and we look for more newly discovered genes that might fit the phenotype. And it's helpful to have friends. I do have some friends, contrary to popular belief, who can help us find the answer when we can't. So that's all I have to say, and that's my time gone. Thank you very much for listening, and looking forward to the other talks and discussion.
Thank you, Dr. Omar, for those very exciting cases and bringing into perspective all the diagnostic dilemmas that we actually face when we are looking at IRDs. So if I could get the panel in, Dr. Vinod, so how often do you find, so genetic testing is now readily available with us. So what are your thoughts on this? So when we get some results in which are actually not corresponding to what we were expecting to see, either they are negative or it's something, how do you kind of proceed with those cases when you get an unexpected genetic result than what you were almost sure of before ordering that testing?
Thank you so much, Dr. Omar. It was a wonderful talk as always. And I think Dr. Omar brought forward very important points. But as a clinician, you always get reports which are not in sync with your phenotype. And unfortunately for us, we do not have so many friends which can help us through all this. So that is a problem with us. But I think then the answer or the option which is left with us is like you said, if it talks like a duck, it looks like a duck, it has to be duck. So phenotype gets the priority. So once you have a phenotype, we go with the phenotype. I think we daily come across cases where you suspect one thing and the gene comes positive for another phenotype which is not in sync with the phenotype. So as of now, we have to say that we really don't know how to interpret this, but this looks like the gene which is not positive. And once you don't have anything which comes out positive, then I think it's even more difficult. So we just have to assume that there might be something which we may not be able to pick. So in that scenario, I think we wait and we ask the patient to be in follow-up, treat the patient as it is, and probably hope for better answers in the future.
Dr. Ajoy, any difference in your approach when you get such results? Do you yourself go into the depths of the raw data analysis of the genetics report, or do you have a team that does that, and how do you go about it?
So I think, phenotype carries a lot of weight. I think that cannot be understated. The other thing is always have an open mind as to, can the other gene where the variants are reported could actually be in some way implicated, So I think it's a combination approach. The phenotype has its weight, the genetic results has its weight, but one cannot exist without the other. And it is critical for you to be open. For us, any of the patient who has a negative panel-based genetic test, we actually then try to do whole genome sequencing in the lab when possible. And then we have a small group which actually works on it to try to identify if there are these deep intronic non-coding variants or variants in alternate transcripts, as Dr. Maru brought about. So it's a combination approach. My personal take is that in our cohort, we have a result in approximately 2/3 of patients, which is really high. Whereas in less studied cohorts like back home in India, I think the genetic yield is much lower, maybe closer to 40% or 50%. So that is a huge opportunity back home to actually discover rare variants in known genes or new genes association. So that I think you should take it as a motivation to actually find new genes. Here we are struggling to find something. Maybe there you can find something more easier. I think you should look at glass half full. Thank you.
Absolutely. And Dr. Omar, if I could take you on that. So a lot of time when we order this testing, we get a lot of VUS. It's the gene that we want, but it's a VUS, maybe a compound heterozygous or a homozygous, but it's a VUS. How do you go about that when it's the gene that you want, it's the phenotype that you have, but it's labeled as a VUS in the report? How do you go about that?
Yeah, great question. As you say, it's good to think about the gene beforehand, even before ordering it.
Your voice is breaking up, Dr. Omar.
Oh, sorry. Sometimes my microphone goes. Has it come back?
Now it's good.
Oh, yeah.
It goes. Yeah,
Okay.
yeah.
Good. So as you say, it's always good to think of the gene beforehand, what genes are likely, because then you know whether to take a VUS more seriously or not. So as you say, if it's a gene that you'd already predicted and it comes back as a variant of uncertain significance, how can you push that into being a diagnostic report? And sometimes it's not possible because it's not been reported before, but certainly if it's a gene, one of the few genes we already predicted, if the phenotype is very specific, then we would take that VUS seriously. And then you may be able to segregate in family members if there are other family members affected, if they have the same variants, that could be helpful. Looking to see how rare that variant is. Has it been reported before? All of these things are possible avenues of investigation. And then if any functional studies have been done, and sometimes people have done functional studies for certain genetic variants, and you can get an idea if that's relevant or not. Sometimes knowing whether in a dominant disease, if haploinsufficiency is a mechanism, then you could take a loss of function variant as being relevant. Sometimes it's not a mechanism of disease, so you may ignore then a VUS that would just be more likely to cause recessive disease than dominant disease. So all of these things one would think about, but sometimes we never resolve it until years later we find another patient with the same VUS. Say, okay, well that clinches it.
Right. Thank you. Any other points from
Can
the
I ask
panel? Yeah.
Omar a question? Omar, there is a site which which very frequently updates the variants, correct? Can you tell us what the site is? I know somebody just mentioned it, the Unuzirans last week, and I totally forgot about it.
Yeah, there are several sites. There's ClinVar,
Your microphone's gone again, so.
Oh, sorry. I don't know what's
good
wrong
now.
with this mic. It'll come back. Okay. So ClinVar is a site where people can upload, and that's accessed by other sites as well, but people can upload whether they have a patient, they can upload phenotypic information as well, or they just the variant. And so that can give you an idea if this has been reported in the same condition with the same phenotype. Something I think that's really helpful that actually Jose Pulido told me about is Franklin. There's a Franklin Genox site, and that's very comprehensive. You can type in the gene and the variant, and it'll give its own assessment whether it's likely pathogenic or not. But then you can also look up where it's been published before, and if that variant itself has been published before. You have to sort of click a few things, and then you can see if it's been published in previous papers, and then you can see if the phenotype fits. So these days I look at Franklin a lot. And then Nomad is this genomes aggregation database, and that's good to see how rare your variant is in the general population. And then sometimes they also give an assessment of whether it's pathogenic or not, and they also link to ClinVar, which will have all of these reports of whether it's been reported in other patients or not. So those are some helpful sites I use.
Right. Thank you so much, Dr. Omar. Dr. Vinod wants to make a point, and then we go to the next speaker, please.
Thanks, Simar. It's more of a question in continuation with your question. So we have one very set of problem where we have genetic diagnosis probably, and then we get something else gene, a VOUS. So another set of problem is when we have a phenotype, we are thinking of something, but some other gene comes positive with pathological variant and in a causative manner. So how do we go about it then?
Yeah, absolutely. We face that as well. So if it's a VUS in a gene that we think isn't relevant to the phenotype, then that's a bit easier. We say, well, lots of people have rare variants. Although I see at meetings all the time and in publications, people are trying to overcall a VUS and say, oh, it shows that that different gene can cause this phenotype. You know, we all have VUSs. It probably doesn't. But then what about if you get a pathogenic variant in another gene? Then you have to think, if it's a pathogenic variant in a recessive gene, and it's only one, then again, you can disregard that. If it's a gene that's associated with dominant disease, again, is that particular variant associated with dominant disease or recessive disease? Again, I feel that's always mixed up. PROM1, we know only certain variants cause dominant disease. The rest, it's associated with recessive, and people are often kind of mixing them up. So knowing the likely mode of inheritance helps. And then I guess keeping an open mind, if it's a really pathogenic genotype in this patient, maybe it is a new manifestation of that genotype, or a new thing that's muddied the waters even more is that we now know that IRD genotypes are probably a lot less penetrant than we thought. Eric Pierce's work, he's published a great paper recently that when you look in big population databases, you find, like, you know, in the US, is it All of Us or something, and even in the UK Biobank, you find people in the general population who've got genotypes that should be giving them an IRD, but they don't seem to have seen an eye doctor. And we think probably, you know, maybe it's undiagnosed or maybe it's not penetrant. And there's this whole area of modifiers that we don't fully understand. So sometimes you will see a pathogenic genotype, but you just might say maybe it's not penetrant in this family. Maybe this patient has modifiers. So all of these things are possible, but it's hard to resolve which one is really the case in your patient.
Thank you.
Right. Thank you, Dr. Omar. And now we move on to the next talk by Dr. Anita Agarwal, ma'am. Autosomal dominant and autosomal recessive macular dystrophies, how to differentiate and distinguish.
Is that,
yeah,
it's
clear.
Are my slides good? Okay.
Yeah.
So this, I think we're just chipping away with on a small part of IRD, and this talk is going to be, again, a very, very small part of IRD, and there's a lot of uncertainty that we still don't have answers for as we're discovering. No disclosures. And the most important thing, I'm going to speak on macular dystrophies. There are certain genes that can cause both cone dystrophy and macular dystrophy, and so the same mutated gene can cause both of them. So the thing to know about macular dystrophies is different from cone dystrophy in the sense they have loss of central vision, and the onset may be later or early onset. The key difference is cone dystrophy patients have photophobia, decreased color vision, and reduced central vision. However, the patients with macular dystrophy don't have much of photophobia. And the most important thing on autofluorescence imaging is you have the Holder-Robson ring, which tells you that the cones around the fovea are sort of diseased, and the RPE around it is overacting or overworking and get this ring. So if you have a ring, it's more likely cone dystrophy. And if you don't have the ring, it's more a macular dystrophy. And in cone dystrophy, the full field ERG shows reduced cone function and reduced combined and rod and cone function. And multifocal ERGs are abnormal in both, whereas in macular dystrophy, generally the full field ERGs are normal. So if you have these sort of entities, you can kind of put them into two different categories. We'll mention a few of the autosomal dominant macular dystrophies. The commonest, of course, is Best-Whittle dystrophy that I think many of us are familiar with. There are slightly rarer ones that are more probably not as common in India or North Carolina macular dystrophy and Malatia levantinus. Parent dystrophies are worldwide. You can see them all over, and they're caused by different mutations. Occult macular dystrophy is something that we've discovered with high-resolution OCTs now, and then there are a few other autosomal dominant macular dystrophies here. The commonest of all dystrophies, as we all know, is ABCA4 disease, also goes by the name Stargardt or fundus flavi maculatus. And the rare ones, or the less common ones, are autosomal recessive dystrophinopathy. And recently, we have these patients with RCB-TB1 dystrophies. And some cone dystrophy genes can present as cone dystrophy, or they can present as macular dystrophies. And we had a couple of patients that we presented at IUSG last month. And we had a patient with the GUSI2D who often can present as cone dystrophy, but can also present as macular dystrophy. And as Dr. Maru mentioned, if the penetrance is not deep, you can get a macular dystrophy and not get the full-blown cone dystrophy. So age at presentation is important. Best usually it's early on, but again, they can come later. North Carolina macular dystrophy is asymptomatic unless they develop CNVM or they have a staphyloma and somebody's looked into their eyes. They can present young or middle age. ABCA4 is the most variable dystrophy. It can present in less than 10 years of age. It can present for the first time in the 60s and 70s. And I have patients who have ABCA4 who are completely asymptomatic even into their 60s and 70s. So there's so much variability, and you just have to keep your eyes and ears open and look at the phenotype to see where you can fit them in. Later years, pattern dystrophy, ABCA4 again can be all over, Malatia levantinese, and Sorsby's fundus dystrophy. These two are important because they can be mistaken for AMD when they present in their 50s, and people can think that these patients have AMD till they kind of go deeper to get a family history and figure out that they were symptomatic in their 50s and not in their 60s and 70s. And let's look at the common ones. Stargardt's disease also goes by the name fundus flavimaculatus. Not everybody has the fundus flaviflex, so this patient has some flex. Hand has atrophy around the center of the fovea. The key important thing is that they have this kind of, the RPE is very diffusely thickened with abnormal lipofuscin, so they have a vermilion or orange color fundus. I think in Indian patients, it's difficult to say that because most of us have dark pigment, whereas in the Caucasian patients, you can easily tell that these patients have an orange color that is, most of the time you can see choroidal vessels in the eyes. And in patients with ABCA4, you probably miss the choroidal vessels. And that was the days that Don Gass used to look for that to see if he could see the difference between ABCA4 and PRPH2 or pattern dystrophy. He would look for choroidal vessels before he ordered a fluorescein angiogram. Here's an example where the fluorescein angiogram shows a dark choroid, and this dark choroid is dark choroid in a Caucasian, and this would look like a normal choroidal background in a patient with of Indian origin. And again, the central vision is not affected. There are focal areas where the flecks are atrophic, and you can see some loss of ellipsoid line and RP changes. Here's the fellow eye, again, the much more area of atrophy, just temporal to the fovea. These patients are either asymptomatic or very minimally symptomatic. However, some patients can present with just the central changes like this example, unlike the one that has all the flex. So ABCA4 has variable phenotypes, and you have to be sort of familiar with them to be able to make the diagnosis. Again, here's another patient with the milder phenotype of ABCA4, where only the center is affected and does not have the fundus flaviflex. Again, a dark choroid. Here's another patient who has 20/40 vision, and his central vision was spared till his late 40s and early 50s. He has extensive atrophy around the center, but the center is still good, so patients can have good vision, whereas somebody might have presented in their teenage years or in their early 20s and have 2100 or 2200 vision. Here's an OCT. Tell you that, and let's finish up all the autosomal recessive diseases because there are not that many. Autosomal dominant macular dystrophies are far more common. This is actually courtesy of Dr. Deeksha from PGI, and I think India sees a lot of these patients. These are young adults or late teenage kids presenting with elevated intraocular pressure. They have short eyes and they're hyperopic, and the classic is if you get autofluorescence imaging, you can see this ring of hyperautofluorescence around the center. And they are symptomatic in their teenage or in their 20s. And the key is that they have intraretinal pockets of loss of cells. It look like cystic spaces. And a case was presented at the IUSG, not the last month, but the month before. And as soon as somebody tells you this patient had cystic changes and they were in their 20s, you should think about autosomal recessive dystrophinopathy, or you should think of NR2E3, and what the challenge was between the two. And if you see these intraretinal cysts very early, you think about ARB, and autofluorescence is extremely useful. I think autofluorescence imaging is probably the best thing that we've got for IRD because it kind of tells you where to look for pathology based on what you see on hyperautofluorescence. Autosomal recessive bestrophinopathy is caused by mutation in the BEST gene, but these patients have a different mutation and it's autosomal recessive, so they have to have both alleles to be affected. It's a null mutation in the sense the protein is not formed, so they have a much more severe disease compared to autosomal dominant VMD2 diseases such as BEST or ADVRC or any of the other ones. Now coming to North Carolina macular dystrophy, this was a young girl who has these compact little drusen right in the center of the macula, and they're asymptomatic. The drusen are small, they're limited to the center of the fovea, approximately 1 disc area in size. Here's another example of it. But the second phenotype with North Carolina macular dystrophy is the staphyloma-like phenotype. These patients have this defect in utero. They develop eccentric fixation. They have pretty good vision. They're between 20/40 and 20/50, and it is autosomal dominance. So you have you have a family member who accompanies the patient to examine, and you can make the diagnosis. And as I said, that these patients are asymptomatic unless they develop choroidal neovascularization, which they can. Otherwise, these things remain the same all through their life. And we did find, when I saw this mother and daughter with this diagnosis, they came in as BEST disease, and I looked in their eyes and I said, you have North Carolina macular dystrophy. And I was surprised as to how the mother could see 20/40 and she was in her 40s. And I got an OCT to look to see what photoreceptors were hanging around that she could see out of her eye. And I realized she had no photoreceptors in the center, but she also had this unusual choroidal cavitation that was described previously in high myopes. And that's when we went back digging into it and to figure out that this mutation is in utero and not an acquired mutation or a mutation that comes on later on in life. They present in utero and they have eccentric fixation and hence have good vision. This is a very classic example of BEST disease. This is probably one of the most characteristic features, an egg yolk-like appearance, and the autofluorescent material is highly autofluorescent, and so you can see that on autofluorescence imaging. There's a pocket of fluid that sits there, and because the gene affects the transport of fluid across the pigment epithelium, that fluid never goes away. So people can mistake that for choroidal neovascularization and subretinal fluid and keep treating them with PDT or anti-VEGF injections. And so you have to remember that subretinal fluid remains in BEST disease. So newer conditions that are known with BEST disease or others that I won't cover here, this ADVRC, and we already talked about ARB and ADMERC, and pattern dystrophy can also be caused by the BEST gene. Doyne's honeycomb dystrophy, as is described in the UK, and Malatia levantinis, as was described in Switzerland. These are patients who develop these very lumpy, bumpy nodular drusen. It's autosomal dominant in inheritance. And if you look at this picture, you'll never forget it. They have some radial distribution in the temporal side, and they have very nodular, bumpy, lumpy drusen, and they come on their 50s, and these patients have a strong family history of AMD. That's what they go about. But if you look carefully, this is not AMD, but it is EFMP5. And these are two siblings who came in. Luckily, they came together. If I'd seen the older sister who was 20/40, I would not have made the diagnosis, but the younger sister accompanied her, and the younger sister's fundus had this phenotype that was typical for Malatia levantinis. And we made the diagnosis, and genetic testing confirmed that both of them had it. So sometimes it can be variable, even these very highly penetrant dominant disease. And the sister had a very mild phenotype, and I wouldn't have made the diagnosis. And the OCT looks exactly like what the histology looks like, where you have this nodular excrescences at the RPE basement membrane. Unlike the last example, this patient went around with a strong family history of AMD. She was in her 50s, and people had not thought about Sorsby's macular dystrophy. And when I saw her for the second eye being involved, the left eye was treated with PDT prior to anti-VEGF therapy. And then she came in, and when I asked her, there was a strong family history, and we genetically tested her, and she was positive for Sorsby. So also was this patient who actually I saw as a fellow with Don Gass, and she was in her late 40s, and she was already lost her left eye's vision. We did several PDTs and different things. And finally, about 6 or 8 years later, when I started taking care of her, I wondered why did she get such extensive AMD in her 40s and 50s, and we tested her, and she was positive for Sorsby. So you should always think about it, and somewhere down the road, you might be able to get the diagnosis. And the drusen resembles exactly like AMD. I think Dr. Maru can tell us more about it. And they do have some sub-RPE deposits. And you have to think about source B in patients where the strong family history is extremely strong and the history begins in their 40s or 50s. Vitelliform lesions, which are pattern dystrophies. These are solitary pattern dystrophies. They can be all over the place. The name pattern dystrophy was given because they can look like anything. Here's different examples of them. And the key thing is when you do a fluorescein angiogram, the central material is hypoautofluorescent and you have this halo of hypoautofluorescence around it. And there are variable types. This is fundus flavi maculatus type. This is again fundus flavi maculatus type. It looks exactly like Stargardt's disease, but they don't have the dark choroid. You can see the choroidal vessels shining through. Here's a mother and a son who have extremely the same genotype, but have extremely different phenotypes. The son has the fundus flavi type, and the mother has the extensive chorioretinal atrophy type. And so this is peripheral RDS. It can look like Stargardt's. Choroidal vessels are visible. And if you do a fluorescein angiogram, you may not have a dark choroid. This is, as I said, resembles Stargardt's disease, whereas this patient, actually the son, who was the proband, has a dark choroid. So I thought he had ABCA4 disease till his mother came, and then she had this, and it took us about 3 years to get the diagnosis at the time when genetic testing was not easily available. Finally, after 3 years, we got the diagnosis. Here's another patient with pattern dystrophy from a different mutation. This is IMPG2, again, central atrophy that looks like peripheral RDS, but has vitelliform material in one eye, lost it in the other eye. And he was positive for IMPG2. So there are rarer genetic mutations that cause pattern dystrophy, and you have to be aware of them. This was his genetic mutation. The last one I'll discuss is occult macular dystrophy. Again, these patients have onset somewhere in the 20s, 30s, and 40s. They have glare, they have difficulty discerning colors, but the fundus looks completely normal. This is her right eye. Here's a left eye. She did have some temporal dragging, but that was unrelated to her symptoms. Fluorescein is completely normal, but the OCT is very classic. In the center of the fovea, they have this very granular appearing ellipsoid line and changes in the cone outer segments. And if you go away from the center, the fluorescein actually, the OCT looks pretty good. This is a left eye again with this abnormal OCT. But if you look at the OCT above, the OCT is pretty good. It's only in the central macula that they're abnormal, and full field ERGs are normal. However, the multifocal ERG is abnormal, and you test them for genetic testing, and she was positive for RP1L1. So the important thing to remember is they have this granular appearing photoreceptor ellipsoid line. And you have to think about occult macular dystrophy. And I think for 10 minutes, I had to go really fast. I'm sorry about that. And we looked at common examples of macular dystrophies, so at least you sort of to be familiar with them. And there are several others that I couldn't cover just because of the fact that we have we only have about 10 minutes. Thank you.
Thank you very much, Dr. Agarwal. That was a comprehensive overview of all the dystrophies with predominant macular involvement. Due to the paucity of time, I'll involve in a quick question. You showed us a case of SORS-B dystrophy, which was mimicking the AMD phenotype. And there was subretinal heme in the paramacular region as well. We know that SORS-B, the bleed happens elsewhere, the CNVM bleed happens elsewhere apart from the macula. How do you go about treatment algorithm for them? Like, do we really treat with anti-VEGF? We observe the paramacular or the nasal CNVM bleeds?
I think at the moment you should treat all of them, because wherever with anti-VEGFs, you have no difficulty with treating. You know, when we did not have anti-VEGFs, was difficult because you had to do a laser to the vessels, or you had to do PDT. And I think with anti-VEGF, I think Omar probably has much more experience of SORS-Bs, but I did have those two families. And the first lady that I showed had 4 PDTs in the left eye, and she had lost vision. And when I saw her, she was about 53 or 54. She had an extrafoveal CNVM that was lasered 3 years prior. For 3 years, she had no recurrence, and then she came in with a recurrence, and that's when I kind of figured out that she may have source Bs, and we tested her, and she was on maintenance anti-VEGF therapy for, at least now, I think even AMD patients are on maintenance anti-VEGF unless they get disciform scar. So because they can pop CNVs anywhere in multiple places, not recurring. It doesn't come just from one site. So you have to, I think anti-VEGF is a good way to treat these patients.
Thank you. Dr. Maharu, do you would like to add something on that point?
No, I agree completely. I think anti-VEGF's been revolutionary for Salisbury because they used to all lose vision. And so you would treat definitely center involving. And you're right, if it's far from the center, might you watch closely or not? But I often err on the side of treating, and anything near the center one might treat as well, just because something you can treat in these patients.
Yeah. Thank you very much. I would like to invite Dr. Vincent for his talk. Please share your screen.
Is the mode right?
Yes, absolutely.
So today I'll be trying to cover why the phenotype information is so critical in analyzing big data sets like genome analysis. So as the previous speakers, you would have noted that it is a diverse group of disorders, inherited retinal diseases. There is at least 360 implicated loci. And even if you do a large panel gene testing, say of 300 or 400 genes, approximately 30 to 50% cases come back as negative or inconclusive. So to address missing heritability, some geographical places like in the UK, they use genome sequencing based platform to look at all the variants across all the genes if need be. And there are many softwares that look at these huge data sets. To give you some context, if you do exome sequencing, you'll have at least 100,000 rare variants. Whereas if you do genome sequencing, there are about 5 million variants. And trying to sort to look at the pathogenic variant is like looking for a needle in a haystack. There are many pipelines that are commercially available and research available, but there are some existing drawbacks in some of these pipelines. So one drawback is that many pipelines can only look at one class of variants, like small variants or single nucleotide variants, whereas some pipelines can look at large structural variants like deletions or duplications. So to address missing heritability, we developed what is called as REDGAP, or Retinal Degeneration Genome Analysis Pipeline. It's a semi-automated pipeline that is coded in R, and it integrates phenotyping, meaning we run it as two steps. One is we create a panel gene analysis where you look at genes that are known to cause the phenotype in greater detail. And then if it is negative, we look at whole genome analysis. The advantages of this platform is that it looks at all different variant classes. It has variant diverse scoring metric, and you can also do it for various inheritance patterns. So this is a typical workflow for a patient who comes to our clinic. The patient comes to clinic, we make a clinical diagnosis, we offer a panel-based testing. If it is positive, the case is resolved. But if it is inconclusive or negative, we recruit the proband and the additional family members and do genome sequencing. And then we run through our script, R-based script. We do a panel gene analysis. We curate the panel based on the phenotype. And then if there are candidate variants, we do the downstream analysis, functional assays, and then the case is considered resolved. But if it's negative, we then do the same exercise across the genome. This helps with managing the amount of variants that you can get on genetic testing or genome analysis. So I won't belabor through the screen. But the idea is that, say we talked about ClinVar, which is a database. So if there is a variant which is labeled as pathogenic or likely pathogenic, it carries a higher weight. Whereas if it is a stop variant or a frame shifting variant, it carries a higher weight. Whereas there is a load of bioinformatic tools that look at different parameters. Say some of these indicate possibility of a splicing error, splice AI scores. Some of these are conservative scores. If some amino acids are very conserved in mammals and vertebrates, you know that it is important for function. And some are it has aggregate scores using at amino acid polarity and other computational tools. So, and then it gives us a list, and the gene ranking is based on the cumulative score. So then you actually look at what is the most highly scored variants first. So it helps you with prioritization. So let us see how I'll show 3 examples of how we use this pipeline in an unsolved cohort. So first one is a case of early onset retinal dystrophy. This is an 11-year-old male who presented with night blindness. Best corrected vision was 2050 and 2063. If you look at the fundus, there are a few hallmarks. Again, around the vessels, you see that there is preservation of the retinal pigment epithelium. And macular, there are skytic changes, and even outside the area of the skytic changes, you see thickened retina. So typically, when you see these features, you would think that this is likely CRB1 related. When we did genetic testing through the clinic, we found one variant in CRB1. It's a stop variant. But as you all know, CRB1 causes disease in autosomal recessive fashion. So one variant cannot explain the phenotype. So we did whole genome sequencing. And then what we did was, so as you can see here, if you look at the small variant or single nucleotide variant, there is over 5 million variants in the output file. When you look at structural variant, there are about 22,000 variants. So then we created a custom panel of 27 genes that are known to cause early onset retinal dystrophy. And when you do some quality filtering and when you run through the pipeline, you're left with 13 variants, which are small single nucleotide variants, and 3 variants that are structural variants. Then we incorporate our scoring within the pipeline, and then ultimately you're left with 2 variants within 1 gene, and that happens to be CRB1. So if you look at the output from RedGap, on the top, you see the same variant that was identified in clinic, which is a stop variant. But 26 nucleotides into an intron, there is a variant which is predicted to alter splicing scores. That means that this is not a canonical splicing site, but it, despite being not within a few base pairs of the intron exon junction, this is the potential to alter splicing. So we need to do functional assay to validate such a thing. So because CRB1 is not expressed in patient-derived cell line, we took a mini gene approach, meaning this is like minimal fragments of the gene, and then this is inserted into E. coli, and then we assess the splicing assay using this mini gene system. I would just request you to look at this part of the screen. So this is a schematic. So normally, you have all the exons lined up, exon 3, 4, 5 of CRB1. When we did mini gene assay, you see that exon 4 is skipped, meaning because of this variant, it led to alternate splicing. And that in turn also led to a stop variant. So in effect, this patient has 2 variants, one that was clinically determined and one that is a intronic variant, which alters splicing, and one variant comes from each parent. So we did segregation analysis. So your phenotypic ascertainment helps with genomic analysis. Now let's look at case 2. So this is a 20-year-old female with night blindness. Central vision was 20/40, 20/50. When you look at the fundus, as you can see, there is bony spicule pigmentary changes, so diagnosis is not a problem. If you look at the OCT, there is loss of like outer segments and inner segments outside of the central fovea. But one thing that stood surprisingly is that if you look at the subfoveal external limiting membrane, that is thickened compared to what you would expect. When you have thickening of external limiting membrane, that is indicative of a storage disorder. It is classically described in mucopolysaccharidosis 1 or Hurler syndrome or Hunter syndrome. So we had that information. We did clinical testing. When we did clinical testing, there was one variant of uncertain significance in a gene called HGS-NAT. HGS-NAT interestingly caused Sanfilippo syndrome, which is also a type of mucopolysaccharidosis, and it's a storage disorder. But again, it is typically in autosomal recessive mode of inheritance. So what did we do? We did genome sequencing and ran it through our pipeline. Again, there were over 5 million variants to begin with and 15,000 structural variants. We created a panel of 121 gene lists. That means that RP can be caused by well over 100 genes at this point. And we had 460 variants, single nucleotide variants, and 6 structural variants. We did scoring, giving different weight to the different variants as per our scoring system. We were still left with 226 variants across 45 genes. Now, when you looked at, we prioritized HGS-NAT, which was in the top 10 variants. There were 4 variants in HGS-NAT, out of which 2 of the variants were interesting. One variant is the variant that was identified in clinical testing, and it had very good scores of 35 from a total cumulative score. The other variant, interestingly, is a deep intronic variant. It's about 4,500 nucleotides into the intron, and it causes some alteration to the splicing score. So similarly, so it again, the storyline looks to be that it may alter splicing. So again, we did functional assay. This time, HGS-NAT is expressed in patient lymphoblasts and fibroblasts. So we use patient lymphoblasts. So I want you to look at this schematic here to help understand easier. So normally, this is an intron 2. So normally you have exons 2 to 4. But what is happening here is, because of its deep intronic variant, there is a cryptic exon or a pseudo exon which is created. And once that is created, it can alter the product the transcript that is formed. More interestingly, the other variant, which is an exonic variant, which was identified in the clinic, when you look at exons 14 through 18, what happens is that when you have this exonic variant, it also leads to exon skipping, meaning after exon 16, you go to exon 18. So what are the effects of this? The effect of this is that because of the deep intronic variant, you get a frame shifting variant. So it leads to premature termination of the transcript. And what happens because of the exonic variant, which is actually a missense variant, the effect is the same. Because of exon skipping, you actually get a frame shift, which lead to truncated protein. So what was the advantage of the functional assay? We were able to upgrade both of the variants into ACMG class 4 and class 5, likely pathogenic and pathogenic. The last case I will highlight here is a case of Leber congenital amaurosis. So this is a 14-month-old proband who presented with nystagmus, poor vision, and non-recordable ERG, the classical triad described by Leber. Best corrected visual acuity was 2600 and 2800. And clinical testing in a clinical lab identified 2 variants in RP group 1. So one was a splicite variant, one was a duplication, but both variants came from the mother. So it is in cis. So that cannot explain the phenotype, explain the disease. So if you look at the fundus, again, you see mid-peripheral changes, and also the OCT is markedly abnormal outside of the central fovea, and the vision is markedly reduced. So we use a similar approach. We again, this one, we actually looked at an exome analysis. And if you look at, we created a 27 gene list known to cause Leber congenital amaurosis. And in the end, there were 22 variants in 9 genes. And there were 3 variants in RP-GRIP1, which is the gene of interest. So the first variant here is the splice site variant, which was already picked up on clinical testing. The second variant here is the duplication, which was picked up in clinical testing. What was interesting is the genome sequencing actually picked up a third deletion, which is upstream of the RP-GRIP1 gene, which actually, when we look at functional data available, it actually involves the promoter of RP-GRIP1. So all the genes that you have, any gene is controlled by a promoter region, which is upstream of the gene. So here in this picture, what we are trying to show is that this blue bar is the RP-GRIP1 promoter. And what is happening in this patient is this lightish blue bar, this entire region, approximately around 6,000 base pairs, is missing, so that encompasses the region of the RP-GRIP1 promoter. And when we did segregation analysis in parents, the promoter deletion comes from dad, the other 2 deletions come from mom. So it is conclusive that this is in trans. And because of these results of this functional assay, we were able to actually update the ACMG classification as likely pathogenic. So what are we trying to say? We are trying to say that, combining phenotype with genome analysis is a powerful tool to address missing heritability. Because there is genome analysis is a very powerful tool, but you have about millions of variants which you have to then shortlist. And that is where your phenotypic interpretation becomes important. This work was just recently published in Nature Genomic Medicine. This is a freely available online platform. Anyone can use this. It is in R, and you can actually, play around if you have a list of genes that you would like to look at in any of the genome, and it will work with exome as well. And I want such type of work will not happen without the help of numerous colleagues. And I want to thank my master students, my lab mates, my funding, Foundation Fighting Blindness US, and the other funding agencies. And thank you so much.
Thank you so much, Dr. Ajoy, for that very illustrative talk. And I think that kind of opens up our eyes at what is possible with the genome sequencing and what we are actually doing. So if I could get in Dr. Parveen ma'am here, so if you could stop sharing here. If I could get Dr. Parveen Sen ma'am here. Listening to what Dr. Ajoy just told us, ma'am, and what we currently practice in India, what differences do you see in the practice and how we can improve on the same? And I think we have a question in the chat also from one of the audience, that where is genome sequencing available in India, especially in Kolkata? So if you could answer that both.
Yeah, I think first of all, thanks, Dr. Joy, for a very nice talk. And I think we are far away from where Dr. Joy is at this point of time. I think at this point of time, we just need to do more and more genetic testing, get more and more familiar with the variants that we have, and discover new variants as well, and develop genotype phenotype correlations. Once we have done that, then we will start, going back and forth between, if phenotype is not matching, go to genotype. If genotype is not matching, add on to the phenotype. At this point, I think, first of all, we need to have maximum amount of data. So, going to your second question as to what most of the labs, I think, which we have all over the country, they kind of have people who collect the samples from multiple places of the country. So, I'm sure, like, for example, MedGenome, I know, would collect it from the various cities. So, they would have somebody who will collect it from your place also. So, they have centers which have collection, and then they do the DNA extraction and take care of the movement of the sample, and the result is given to you after a month. So you could probably select one of the strand genome or med genome, or even now the Unipath, which is from the Intas Pharma. These are the few companies that we work with, and they generally are able to collect samples and send them across. I hope I've answered both your questions, Simar.
Absolutely, ma'am. Thank you so much. And I think we are just short on time. We'll quickly go on to the cases. Quick case and just a short discussion on them. Purna, if you can share your slides first. So yes, we do have genetic testing now available in India extensively, but I think the kind of work that Dr. Ajoy just showed with dedicated to kind of solving these queries where you are not matching with the presentation and the result that you got, that is still a far reach and we need to work on that. Thank you, Dr. Ajoy. Purna, please go ahead.
So, good evening, Dr. Simar. Is my slide seen in full screen? Am I audible?
Yeah, absolutely. Both good.
Fine. Thank you so much, Dr. Simar, AOS, especially Dr. Santosh Vanavar, sir, for this opportunity. Wonderful talks. I'll just present one of the interesting case which I found it was little interesting. So I hope all of you will find it interesting. So this was a story of 24-year-old female who presented with diminution of vision in both eyes since childhood, early onset disease. She had nystagmus. She also had photophobia. She also gave history of intermittent divergent squint. She was a little overweight, and she also gave history of multiple episodes of eczema. And on recent systemic evaluation, she found to have a very mild renal dysfunction. So the creatinine was slightly borderline it was 1.5. Blood urea, however, it was normal. So HB was slightly less for her age. And she's under workup to understand this mild renal dysfunction. So when she came to us, this was her best corrected vision for distance was 6 by 60 with mild myopic refraction, and the near vision was N36. Intraocular pressures were normal, and she had horizontal beating nystagmus. Anterior segment examination of the eye was within normal limit. So this was the fundus picture of the right and left eye. I know it's slightly decentered, she has nystagmus, so with a lot of difficulty we were able to capture this. So if you look at this, it has typical rod cone dystrophy, LCR and RP-like phenotype. But if you closely observe the macula, there is a perifoveolar ring of atrophy, which can be better appreciated when you do the autofluorescence. Sometimes I call this as a reverse Robson holder ring. So that's perifoveal atrophy. So, same thing was seen in the OCT of the right and left eye. So wherever there was a corresponding zone of atrophy, there was a loss of RP with lower lying ellipsoid zone. So the RP was relatively healthy in the foveal region, which is barely detectable EZ. In parafoveal region, it was not that prominently seen. So this was her pedigree, born out of a consanguineous marriage. Her maternal grandparents were cousins, but she was not sure of the consanguinity history. And her paternal aunt was deaf and mute, but she did not have any vision issues as per the history. So when we got the genetic testing done, she was found to have mutation in CEP290 gene. It was in two exons, exon 51 and exon 35. So the mutation in exon 51 was a deletion leading to frame shift mutation and termination, which was reported as likely pathogenic. So other point mutation in exon 35 was of uncertain significance. So basically recessive may be a compound heterozygous maybe. We'll come to that later. So if you put everything together, early onset disease, nystagmus, RP-like phenotype, and this OCT features, and the genetic report, definitely it fits into a LCA, that's Leber's congenital amaurosis. Maybe the phenotype for an LCA is maybe mild compared to what we see in our region for the CEP290 gene. That could be because of the compound heterozygous nature of the mutation, what she has. And we commonly see these compound heterozygous usually have relatively milder phenotype, at least in our cohort. So coming to the details of the CEP290 gene for some of the post-graduation students who are attending this. So the full name is centrosomal protein 290. It's located in long arm of chromosome 12. So it encodes protein essential for ciliary function. So its key role is to, it in cilia and the photoreceptors connecting the cilium, and it helps to maintain the protein transport between the inner and the outer segment. And it is, crucial for photoreceptor integrity and survival. Whenever there is a defect, photoreceptor starts degenerating. And these are the associated disease with CEP290 LCA, which is the most common. It can have typical RP-like phenotype, Bardet-Biedl, Joubert syndrome, nephronophthisis. Basically, part of that all that ciliopathies spectrum. So inheritance is usually, typically it is autosomal recessive, and the most common mutation is this IVS26 mutation. This is important. I'll tell you why, because this is the most commonly studied mutation. They are tried targeting this through various gene therapy trials. So the gene therapy for CEP290, just like in ABCA4, it's a very large gene. So the regular vectors, what we use the for carrying the gene may not be sufficient because the cargo capacity of AAV vectors is limited, and this is a large gene. And definitely the conventional gene augmentation is difficult for CEP290. So there are some alternative methods which are there. So one such trial was done using the cepofarsen, that it is basically it's a non-classical gene therapy. It is an antisense oligonucleotide injected intravitreally. So it specifically targets the common CEP290 mutation, that IVS26 type. So the DAC corrects the abnormal RNA splicing and allows production of more normal CEP290 protein. So the early results in early phases were fantastic. There was improvement in visual function in several patients. Some patients experienced meaningful gain in visual acuity also, and also the retinal sensitivity. But however, the phase 2-3 that Illuminate trial failed to meet the primary visual acuity endpoints. So there are many reasons why the results in the early phase were good. The reason being, in early phases, usually we select ideal patients with early onset, relatively better, in whom the structures are better preserved. And the outcome measures were also not that strict, whereas in the late phases, the outcome measures in terms of BCVA and very heterogeneous group of patients, that could be the possible reason why it failed to meet the primary endpoint. So the other trial was the CRISPR gene editing. It is very interesting historically because this became the first in vivo CRISPR-Cas9 treatment administered directly inside the human body for an inherited disease. Basically, it is delivered subretinally as an injection. It removes the abnormal splice site created by the IVS26 mutation. So rather than adding a new gene, basically it edits the patient's existing defective gene. So the early phase trials demonstrated acceptable safety, and then several patients showed improvement in visual acuity, functional vision, light sensitivity, and also navigation performance. So
Now, if you can
incidentally,
conclude,
that's
please.
about the CEP290, and yeah.
If you can
Hello.
conclude, please. We are just
Yes,
running
sir.
out of time
Yeah,
here.
I'm almost concluding. So this we also found one additional genetic variant in this patient, that was G6PD in an heterozygous state, which was reported as likely pathogenic. So G6PD, these are the clinical features. I won't go into the details. See, it can cause this acute kidney injury, not like very mild variation in serum creatinine as in our patient. So to conclude, so the CEP290 associated retinal dystrophy is highly likely in this case, one likely pathogenic frameshift variant and one VUS. So overall pattern suggests likely compound heterozygous status. Coming to the phenotypic correlation, clinical picture consistent with LCA, presence of mild renal dysfunction, it definitely raises the suspicion, CEP290 related syndromic ciliopathy like Bardet, because she was obese. She did not have any polydactyly, but we know the polydactyly Bardet-Biedl without polydactyly has been reported in 25 to 30% cases, especially CEP290 cases. So the additional G6PD variant, that X-linked, could be an incidental finding, not contributing at least to the retinal phenotype. Renal, we are not sure. So the key clinical implications is autosomal recessive inheritance confirmed, which is definitely compound heterozygous. We need to screen the family members, segregation analysis, and the reports are awaited. And VUS, as usual, requires periodic re-evaluation. Thank you so much.
Thank you so much, Purna. Shrikanta, if you can share your case in the meantime. Dr. Joy will take your comments on this one, please. What you would have done differently in solving this and kind of determining the actual variant for this.
So, Purna, one quick thing maybe that, I mean, great case as always. One thing is that the ultrasound, renal ultrasound can also give some indication and try to help if it is like inconsistent with nephrocnophthisis. I think early features
No,
include
nephro.
accentuation.
Yes. Yeah, no, ultrasound was normal. Basically, there is no physical abnormality. We are looking at only the molecular biochemical level at this stage. So physically, there is no cystic changes. Usually, what we see in the mild early cases of other renal associated change. It's normal. Ultrasound is normal for her. In fact, our nephrologist has not advised anything for just observing.
And if I may complete, is that like sometimes there are no cystic changes, but there is loss of corticomedullary junction that we see in the reports, which can sometimes be useful. The other thing is that now for SEP290 there is a retrial. I think it is important for our colleagues to know that it is called, I think, Hyperion. Omar, correct me if I'm wrong. It is again gone into gene therapy, ASO therapy. Again, it is a phase 2-3 trial, which is now restarted, trying to help these patients who have the deep intronic variant that you shared. Thank you.
Right. Shrikanta, if you can have your case, please.
Yeah, thank you so much. Thanks for the wonderful discussion. So I'll quickly go through my case. So we have this 8-year-old female who presented with difficulty in bright light, and she was wearing glasses for past 3 years. There was no family history of similar illness, no history of parental consanguinity, and there was no systemic illness. If you see here, the right eye best corrected visual acuity was 21-25 with plus 11 diopter spherical equivalent, and left eye had also similar visual acuity and refractive error. On examination, she had this mild horizontal pendular nystagmus, and color vision documented on HRR plate showed mild impairment. So this is the color fundus photograph of right and left eye. So it didn't reveal much, but when you see it little bit closer, what you can see is that you can see there is absent of macular pigments, which is classically observed in normal individuals. Also, you can trace the blood vessels also up to the fovea. So this points towards foveal hypoplasia. So again, on autofluorescence, white field autofluorescence, what you can see this vessels almost tracing up to the fovea, and the typical macular, you can say hypoautofluorescence, which is not classically present in bilateral eyes. Here you can see the closer view of the macula. No surprise, on OCT, what we noted is that grade 4 hyperplasia. So we subjected the patient to handled LKC-assisted using skin electroretinogram. The scotopic response was normal, whereas the photopic response, you can see, it is mildly reduced. The patient was earlier diagnosed with a case of bone dystrophy in view of pendular nystagmus along with this bilateral symmetrical pattern of loss. So what we are dealing with? So are we dealing with NRDA associated foveal hyperplasia? However, the anterior segment looked normal. So is it a case of occlupecutaneous albinism? However, we don't have anything that is pointing towards a depigmented fundus. Or are we dealing on something else? So this PAX6 related NRDA with foveal hyperplasia or occlupecutaneous albinism related hyperplasia, this accounts almost for 90% cases of this foveal hyperplasia. So no, we are not dealing with these two conditions. So what are we dealing with? So when I subjected this patient to multi-channel pattern beeping, what I noted is that I could see a clear asymmetry between both the eyes. Here you can see the interocular latency difference is almost 60 milliseconds. And also here you can see compared to the left eye, the right eye shows gross asymmetry. So am I dealing with something which has ocular asymmetry in pattern BEP also along with that oval hypoplasia? So when we subjected this patient to genetic testing, what we noted is that we noted a genetic mutation in SLC388 and located in exon 3 with a termination mutation, which is in homozygous state. So this spectrum of disease is called as Fonda syndrome. So what is Fonda syndrome? Fonda syndrome means we have foveal hypoplasia, we have optic nerve misrouting defects, and also intersegment dysgenesis, which may have variable genesis. So to conclude, the genetic testing will help us solving dilemmas in foveal hypoplasia and multi-channel VEP can be utilized in cases where genetic testing is unavailable for confirming. Thank you very much.
Thank you, Shrikanta, for that very crisp and short case, and I think lovely finding. And I think the fundus photo shows, Dr. Vinod will agree, that fingerprint-like pattern that is very characteristic for foveal hypoplasia when you see that, so you can avoid the mist. And Optos shows it very nicely. Any comments from our panelists for this case?
Thank you.
Dr. Praveen, Dr. Omar, Dr. Anita, if you would want to comment on this. Just quick comment and then we conclude the session.
Yeah, I think that was a great case. But did somebody show a similar case at the VRSI meeting? I think it was a similar case of foveal hypoplasia with color vision issues. And yeah, I mean, the key is, of course, autofluorescence really is helpful for looking at any of these. I think if you have optos autofluorescence, even with nystagmus, you can get good images, and that helps you sort of direct your attention to certain areas when you don't have other findings that are very typical that you can catch on just a fundus exam.
I think one very important thing to do is whenever I come across such patients, I always look at the fundus of the mother or the sister if it is accompanying. So you can exclude X-linked ocular albinism by just looking at the fundus of mother if it's available. I have two cases incidentally of SLC 38, you know, and so it's a newly recognized entity, but I think quite striking appearance.
I think probably we don't see it because we don't suspect it. What we have been saying so long as an isolated foveal hypoplasia or idiopathic hypoplasia probably was always into this category. And it's not very easy to catch the misrouting, I think, because it may be variable. So until unless there is a distinct difference between the right and left, we may not still be able to pick it up. But I think having now increasing knowledge of this, we would probably, think more often of this syndrome whenever we think of foveal hypoplasia.
Absolutely. And with that, thank you so much to all the presenters and the panelists for your great talks and insights. I think I learned a lot in this, and from all the three talks from Dr. Anita, Dr. Omar, and Dr. Joy. And I think we have a great long way to go in refining our genetic testing and reaching a conclusive diagnosis for most of our patients, and then hopefully in treating them also. Thank you so much, everybody. And I hand over the session to the AIOS team now. Thank you.
Thank you.
Thank you all.
Thank you.
Thank you, everyone. It was wonderful.
Thank you very much.
Good evening,
morning,
everybody.
sir. Good morning,
Good
Professor
evening. Good
Subramanian.
evening.
Good
It's good
evening.
afternoon to Dr.
Yeah.
Adnan and
Hi,
Dr.
everyone.
Shobha.
Hi.
Hi there.
Hello, madam.
Hi, Anand.
Hi, ma'am.
Hi.
Hi,
Hello, Dr. Muna. Welcome, Dr. Vishali.
Good evening, everyone.
Good evening,
Good
everyone.
3
evening.
p.m. for the UK folks. I never knew that there was
Doctor, we are
the
continuously live,
time
please.
saving. I never knew there was a time saving. Good Lord. I almost missed it. Right. Thank you for joining, Dr. Sandy. So are you in
Hi.
Singapore? Are you in
Yes,
Singapore or elsewhere?
I'm actually in Vietnam. Yeah, there's
Oh, okay. So it's a different
yeah,
time zone?
yeah, different time. So slightly better than Singapore. Now it's 9
Okay.
p.m. Yeah.
Okay, good, 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 good.
Nice meeting everybody. Yeah.
Yes, thank you for
Yeah.
joining in. So Mudit, you're on?
Yeah, I'm there.
Mudit is here. Yeah, Mudit is Jay is here.
Yeah.
I think Anirudh will be joining. He's at an airport, so he's flying. We got his thing, but he'll be on soon. So,
Dr. Anand, we are continuously live.
oh, okay. I thought you were muted. Okay.
No, the
All right.
sessions are in continuous movement, so we are still live. And
Oh,
if
okay.
anybody would like to check their sessions,
Yeah,
they're most
please.
welcome.
Dr. Adnan, would you like to go and check your slides on first?
Yeah.
Pranav, you have Dr.
Yeah,
Anirudh's,
yeah.
right? In case.
Yes,
Yeah.
sir. Yes, sir. I'll
Yes.
just
Okay.
share.
Yeah.
And this is. Can you see
Okay.
the video, sir?
Yes, yes, yes. Can you just play it so that we hear him also in case? Are you?
Can you hear it, sir?
No, I'm not hearing it.
No, no voice.
No worries.
Can you hear
I think you
me?
need to
Okay.
turn up the volume on your.
Yes, Adnan, we can hear you very well.
Okay, perfect.
Yeah.
Let me just make sure I can share my slides. Hold on. I've got too many
Okay,
things
Pranav, just
open
hold
up.
on. Let's check Dr. Adnan's
Yeah,
talk
yes,
first.
sir. Yes, sir. Sure, sir.
Hmm.
Good evening, Dr. Hemant.
Hey, good evening.
Good
Good
evening.
evening, everyone.
Good evening. Good evening.
Is that visible now?
It's beginning. Yes, it's in. Yeah. Could you please full
Okay.
screen it?
Yeah. Is that okay?
Yeah, it's not full screen, but yeah, now it is.
Yeah, it's working.
Okay,
Yeah. Could you
great.
just run
Great.
a few slides just to see if it's moving?
Yeah. Yeah,
Yeah,
perfect.
perfect. Perfect. Thank you. Dr.
Okay, great.
Thank you, Dr. Agnan. Dr. Shobha, would you like to check?
Yeah, okay. Um,
Yeah, that's the last part. Yeah.
Yeah.
Yeah, I think you're good.
Yeah.
Okay. Yeah. Jay, Dr. Sandy, would you like to check yours?
Yes. Let
Yeah.
me just share my screen. Sorry. Can you see my screen? My slides?
Yes, we can. Yeah,
Okay.
yeah.
Yeah, I think it's all right. Yeah.
Yeah, it's good. Good.
Okay. Thank you.
I think we are 7:30, right? So
Yep.
the team, Dr. Rolika, I
Yes, sir.
think.
A very warm welcome to all of you in this thought-provoking session of biomarkers. Just a second, I'll just share the slides. Biomarkers or Mirage, decoding meaning in retinal imaging. It is my privilege to introduce our program coordinator and moderator, Dr. Anand Rajendran sir, who is also a chief of vitreoretinal services at Arvind Eye Hospital, Chennai. So without further ado, I would invite Dr. Anand sir to take the session forward. Thank you. Over to you, sir.
Thank you, Dr. Neha. Good evening, everybody. We welcome all of you to what promises to be a very absorbing and engaging 75 minutes. of deep diving into retinal imaging, unraveling key OCT and OCT angiographic, biomarkers that really will highlight, macular and retinal pathology. And it's aptly called decoding, of retinal imaging. And with that short preamble, it's my pleasure to introduce somebody who really needs no introduction, the chairperson of a session, Dr. Vishali Gupta, a stalwart in the field and our eminent president of the Vitreoretinal Society, and the senior professor at PGI Chandigarh to deliver the opening remarks. Dr. Vishali.
Thank you. Thank you very much, Anand. And I love the time. So, OCT, all the biomarkers, the imaging biomarker has been a buzzword for a decade or more. And we need to know whether it's just a fashionable thing to show during the meetings, or can you get a real information out of those biomarkers when you are actually managing your patients in a busy clinic that all of us have in India. And I think this is going to solve some of those, confusions that everyone may be harboring. We have the top of the top speakers talking about, and you would realize how these markers are important in establishing the etiology, in leading you in the management, deciding about the protocols and everything. I'm honestly looking forward to hearing to all the speakers and the panel discussion.
Thank you, Dr. Vishali. So this evening we have really an illustrious array of speakers and panelists, all of whom are absolute luminaries in retinal imaging. And we have the very erudite and very charismatic speaker, Dr. Adnan Tufel, a senior consultant and professor at Moorfields, London, UK, speaking to us on decoding DME. And followed by Dr. Shobha Shivaprasad, a professor of retinal clinical studies at UCL Institute of Ophthalmology and Moorfields, London, too. And she'll be talking to us about AMD crystal ball and the biomarkers there. We have then one of our own, Dr. Jay Sheth, a very dynamic young researcher, head of retinal services at the newly minted Shantilal Shangvi Eye Institute, Mumbai. Unpacking pachychoroid biomarkers is what he's going to talk about. We also welcome Dr. Sandy Zhu, again a young mercurial consultant at the Tan Tock Sen Hospital and faculty at the Singapore Eye Research Institute, talking to us about a very fascinating research with none other than Dr. Phil Rosenfeld. She was an associate and a fellow with him in Bascom Palmer. She's going to talk to us on wide field imaging in diabetic retinopathy. And we also then follow up with very academic and Stella, one of the earlier recipients of the VRSI Young Research Award, Dr. Anirudh Agarwal, will be talking about biomarkers in uveitis. He's right now faculty at the Cleveland Clinic, Abu Dhabi. So our panelists for the day, again, all of whom absolutely need no introduction, the leading lights in the Indian retina fraternity, Dr. Muna Bende, senior consultant and head of the retina service at Shankar Nethralaya, Dr. Chennai, Dr. Hemant Murthy, co-founder and senior consultant at Retina Institute of Karnataka Eye Foundation, Bangalore, Dr. Mudit Tyagi, head of retina services at L.V. Prasad Institute, and our current convener, scientific committee, Vitreoretinal Society. Now, without further ado, let me get the show on the road by inviting Dr. Adnan Tufel to deliver the first talk of the session, deciphering DME, OCT, and OCT octa biomarkers in DME. Thank you. Dr. Adnan, all yours.
So, dear Dr. Anand, thank you for the kind invitation to share some thoughts. In fact, I'm going to summarize some papers from some of the faculty on this session. So, I'm not able to move my slides forward here for some reason. Oh, sorry, I'm just going to have to reshare that. It's not moving the slides. Apologize, they were moving a second ago when we did the check, but they decided not to now. Let me just go out of... Great. So we're talking about biomarkers in this whole session. And since I'm starting the session, I'll just remind the audience of the concept of biomarker, which is a characteristic that's objectively measured and evaluated as an indicator of normal biologic process, pathogenic processes, or response to therapy. And we've had biomarkers in diabetes for a long time. Even before the advent of OCT, we had clinically significant macular edema, but it was more sensitive as we introduced OCT as a metric of macular edema. So this is the common biomarker we've had for a long time, which defined the entry into many of our clinical trials for anti-VEGF onwards. And so OCT thickness in the central subfield, 1 millimeter thickness, is almost the standard of care and it's the simplest of biomarkers. And together with function, best corrected visual acuity has really driven our clinical trials and is still a useful metric in our busy clinics. And even these simple measures are still helpful. We know that in eyes with central retinal thickness of greater than 400 microns, in sub-analysis of the anti-VEGF trials, our anti-VEGF is much more cost-effective, and that helps dichotomize the patients we have on the NHS and who gets funded. And we know that patients who have macular edema that's center involving but have good vision, we don't necessarily need to treat them immediately, as the data on the right from the DRCR-NET sub-study on eyes with DME and good vision shows that even if you delay therapy in eyes with good vision and treat only when they have worsening function or OCT, other biomarkers, and treat them then, the outcome is the same. So in our busy clinics, we use these all the time. However, we know that despite those two key markers, there's a very heterogeneous response to therapy. And there's a poor correlation between central retinal thickness and visual function. And we need to do better. We need to have better biomarkers to subgroup our patients to choose the best therapy and enrich our clinical trial patients. The graph on your right shows that even if we take additional factors apart from central retinal thickness, in this case, whether or not the patient's retinopathy grade or whether they've had PRP, it affects the outcome of visual acuity from treating the DME. So there are clearly other factors apart from DME that maybe we can capture with additional biomarkers that would help in guiding treatment. And we know there are histopath correlates for these OCT biomarkers. Inner and outer retinal blood-retina barrier breakdown can give cysts in different layers of the retina. There's some evidence that Muller cell stress or dysfunction will give us the disruption of the inner retinal layers. Capillary dropout will give us macular non-perfusion. We can pick up on both structural and angio-OCT. And chronic inflammation may manifest as hyperreflective foci, and we can see neovascularization or ERMAs on structural and angio-OCT. There is data that suggests that the location of the cysts can be associated with visual outcomes, and outer nuclear layer and OPL cysts more strongly tied to poor visual prognosis. And in about 15 to 20%, we can get ganglion cell layer cysts that are associated with a poorer response to treatment. Very large cysts, greater than 200 microns, are associated with possible damage to the Muller cells and poorer visual function. Interestingly, subretinal fluid presence shows a better response to anti-VEGF treatment. So DRIL is probably the strongest biomarker that we have. And this is the inability to distinguish the four layers, GCL, IPL, INL, and OPL boundaries within the central 1 millimeter zone, and is really driven by the paper by Sun and co-workers in 2014. As I mentioned, it's probably associated with Muller cell impairment. And drill predicts visual function change, and that together with other biomarkers that I will mention have additional prognostic value. So these are some additional papers showing that drill or additional biomarkers EZ together can predict visual function change. It's hard to detect when you have edema, but it'll be a help in understanding prognosis and guiding the patient after the edema is resolved and you can visualize the drill better. EZ and ELM integrity that we have seen is incredibly useful in MACTEL and AMD, also has a utility in DME. Again, it's easier when the DME is resolved to totally understand this. And there are some pragmatic grading systems of ELM and EZ missing together or alone, and together with drill have additional prognostic value. Hyperreflective foci are defined as discrete dots 20 to 14 microns that can be in both the inner and outer retina. And in the outer retina, it's associated with a better response to anti-VEGF, and the inner retina may be more associated with Muller-Glier changes and a response to steroid therapy. I don't think this area has been fully worked out yet, and I think with the next generation imaging, we may be able to tease this out a bit better. In parallel with structural biomarkers, diabetic macular ischemia is a parallel system. And we know from work from our group that was led by Dawn Sim that where we tried to review how macular ischemia affects visual function, we looked at a group of eyes, of over 700 eyes, where we had consecutive angiograms and did mask reading with some novel ways of analyzing the macular ischemia. The ETRS DMI grading system was not based on a functional readout. It was somewhat an arbitrary scale as shown on the right here. But in this paper a number of years ago, we hypothesized that papillomacular bundle ischemia, where the nerves connecting the foveal photoreceptors are passed through, would independently drop function apart from a very large foveolar vascular zone. And using quantile regression, we showed this to be the case. So the areas in red here, where there is ischemia that's non-contiguous with the foveolar vascular zone, independently is associated with loss of vision. And clearly, as we've moved forward since this original study, we can do the same with angio-CT or even structural OCT in the absence of edema. So in this paper, we showed that when you have capillary dropout, either on angio-CT or fluorescein, and no edema, this is associated with inner retinal thinning. So you can actually see where the capillary dropout is, and this helps with guiding a patient's prognosis and in subdividing patients in clinical trials. We also know that from RISE and RIDE, if you have macular ischemia, you have more likely to have significant peripheral ischemia. We've seen in this work that structural OCT alone can tell us when you have separate ERMAs from new vessels. So ERMAs just are an outpouching that lift up the ILM but don't break through the ILM, which is the histopath definition of ERMAs. But in this eye, the ERMAs progress to new vessels over 14 months and break through the ILM. So this will show you where the new vessels are just on OCT alone. And as in this paper, we showed that ERMAs can leak and new vessels don't necessarily leak. So what are other utilities of OCT? So there's lots of work now on vessel density and the automated image analysis systems. In the paper on the right, we looked at early patients with no DR, and we found in histopath that even in patients with no clinically manifest DR, many of them have outer deep capillary plexus ischemia, and that there is neuronal dysfunction that does not necessarily correlate with the areas of deep capillary non-perfusion. So there's actually two readouts that both there's neuronal dysfunction and deep capillary plexus ischemia that don't necessarily correlate. So there are two different readouts. We also know that in clinical studies, We can look at vessel density, and again, that is correlates with response to therapy in terms of visual function. And as with the histopath correlates, the deep capillary plexus is affected more. So in summary, we have a variety of OCT and OCTA biomarkers beyond just central retinal thickness that is helping to subgroup the patients and help guide our patients' prognosis and help in clinical trial stratification. Thank you for your attention.
Thank you, Dr. Adnan. That was a fantastic talk. And enjoyed it very much. Just to get the discussion started, I'll just ask you something which really intrigued me. Uh, yeah, just intrigued me. You showed us beautifully the IRMA versus NVE, where this ILM gets lifted off. Now, if you have these kind of doubtful vascular lesions in the posterior pole, have you started using flow characteristics and these structural OCT biomarkers more than going towards your fluorescein angiography, traditional fluorescein angiography?
Yeah, we're very lucky that so apart from the posterior pole where it's easy to image, we've also luckily now got the next generation swept source OCTs. The difference is in a busy clinic, you really have to get raster through the whole scan, because the danger is if you just look quickly, you can miss it. Whereas in the fluorescein, you hope it lights up, but we've also shown in our paper you can miss things because they don't all light up. So I think we're going to have better segmentation software that will segment the ILM border better, and it'll just give you an en-face map, and which you can do it in some of the newer swept source softwares. Will just give you highlight where the new vessels are, and I think that's really what's going to happen.
So could I ask Dr. Mona and Dr. Vishali, if you have any, if there are biomarkers which tell you that you should go more aggressively, there are some negative biomarkers which you have, which tell you should be a little more aggressive with a stronger choice of anti-VEGF agent from the start, at a more aggressive regimen from any of these biomarkers. Maybe Dr. Mona first.
Yeah, thank you, Dr. Adnan, for a very nice talk. I think a lot of what we do in real life is dictated by the patient's choice and their financial situation and insurance. But I think probably the only biomarker that would really drive my choice of treatment would be a very thin retina and outer layer atrophy, where I would not push something too much to a patient because I know that they may not get very good vision at the end of it. If I see vitreomacular adhesion, I will tell them you may need surgery in future. So I think I would look at those biomarkers to drive my treatment, at least when I start. And otherwise, I would leave the choice to the patient in the beginning. And of course, systemic issues will drive me towards steroid, not otherwise, at least to start.
So on that note, Dr. Vishali, Dr. Adnan touched upon these hyperreflective foci, and we see a lot of that. When you see that, do you look at these hyperreflective foci as drivers towards going faster towards steroids? Because we know there are papers which have showed that if there are more of these hyperreflective foci, likely to be a little more non-responsive or less responsive to anti-VEGF. So what is your take on that?
I kind of agree with you. I think there are studies that do show, but if I see large cystic spaces with hyperreflective foci, many a times, especially if my patient is pseudophakic, the first thing to go in is steroids. I generally do not give in these select group of patients a trial of anti-VEGF and wait for them to fail before steroids, because in our setting, patients are not insured and it's expensive. So many a time steroids do work very well. And then once the thickness comes down, it can be followed up with anti-VEGF. I mean, step down rather than step up.
Thank you. I think we'll move on to the next speaker. It's my pleasure to invite Dr. Shobha Shiv Prasad to talk to us on OCT and Octa biomarkers in neovascular AMD. Dr. Shobha.
Thank you, Anand, and pleasure to be here today. So these are my disclosures, nothing related to this talk. So I will go through the OCT and OCTA biomarkers in terms of biomarker for injection frequency, biomarker for visual outcome, fibrosis and atrophy, biomarkers in PCV, and finally OCTA, I stress, is a developing field in neovascular AMD. So when you discuss neovascular subtypes, previously, of course, we used to do only fluorescent angiography. The classification have now changed with the availability of multimodal imaging. So we go by the Conan classification, usually just based on SDOCT. So in type 1, where the membrane is external to the RPE, these usually suggest that they are indolent disease that really needs a lot of injections. They may ooze subretinal fluid, but may remain there for many years. So if you see an occult or type 1 MNB, I would tell the patient that he or she would need a lot of injections. That's the average, what we have learned about. If it is a type 2 MNB, where most or predominant amount of the lesion is above or internal to the RPE, these are very aggressive lesions, whether it's fully classic or predominantly classic. I would tell the patient that the lesion is very aggressive, likely to develop atrophy, fibrosis, and give them a poor visual prognosis right from the start. Type 3 MNB is quite variable. If you see a patient at stage 1 with intraretinal cyst and a small RAP lesion, they would need very few injections and try and stop the injections as soon as possible because the risk of atrophy is really high in these cases. But if they have already progressed to having a component of sub-RPE lesion, these are very chronic, high risk of atrophy and fibrosis, and require a lot of injections and really a poor responder to treatment. I said the type 1 occult also have PCV as one of the features, but they do have different OCT biomarkers to suggest that they are PCV lesions. But I should stress that there are no difference in PCV seen in Asians versus Europeans. They all seem to have the same clinical signs on OCT with a double layer sign, peaked PED, double peaked or multilobular PED, and the classic sub-RPE ring-like lesion. Usually manifest with subretinal fluid. For these patients, we recommend that they would need a lot of injections, may not respond well, and finally may need PDT as well. That's all about lesions. Now, going to prognostic markers in neovascular AMD, as Adnan previously mentioned, for diabetic macular edema as well, clinical trials have always gone for central subfield thickness, quantitative assessment to make the clinic decision uniform across many sites. But of course, in real life, we do see lots of prognostic markers that we take on board when we decide treatment. So we did a review of biomarkers in neovascular AMD. We found 10 that needed further investigation. That's intraretinal fluid, subretinal fluid, pigment epithelial detachment with sub-RPE fluid, SHRM or hyperrefractive material that leads on to fibrosis, atrophy, subretinal drusenoid deposits, outer retinal tubulation, hyperrefractive foci, and fluctuating retinal thickness. Out of this, we found 6 of them definite association with disease progression. That's IRF, SHRM, subretinal drusenoid deposits, outer retinal tubulation, hyperrefractive foci, and atrophy. So I'll cover them. For IRF versus SRF, usually we see a mixed picture of IRF versus SRF, and IRF always trumps SRF. If we see a patient with IRF, we definitely need to intensify and be very aggressive with the treatment for such patients. Because they are poor prognostic indicator, it suggests structural damage to the retina, including the photoreceptors, high risk of fibrosis, worse visual acuity outcome, very prone to recurrence, and require very aggressive treatment. and the aim is to abort any intraretinal fluid. On the contrary, for subretinal fluid, the usual associations based on reports is that it's much more benign in that it's got comparable vision to those who have dry macula, and that is probably because the photoreceptors are protected from the damaging fibrotic RPE and CNV below that. And it may also indicate a healthier type 1 neovascularization, but it's always with a caveat that we say something is protective in AMD. So it becomes very concerning if SRF is actually increasing compared to previous visits. It's large in volume and subretinal fluid associated with hemorrhage or intraretinal fluid. And if the patients are symptomatic, that means the lesion is active despite the presence of subretinal fluid. And if it's linked to an active type 2 CNV. And of course, persistent subretinal fluid. So if you just do a cross-sectional study and look at the outcomes of intraretinal fluid versus subretinal fluid, we often get the answer that subretinal fluid has a better visual outcome. But if you look at persistent subretinal fluid over a year or two, you'll find that these patients, even SRF in isolation, results in poorer visual acuity outcomes. Should bear that in mind. SHRM versus fibrosis. Now, hyperreflective material is a very difficult one to grade. Often we say hyperreflective material, which is ill-defined, fluffy in appearance, is SHRM, while those that are well-defined are fibrosis. But once you start grading these images, we know it's extremely difficult to distinguish them, and most of them is a combination of SHRM and fibrosis. Whatever it is, SHRM is a poor prognostic indicator, high risk of fibrosis, and the SHRM may be of any content. It may be fibrovascular tissue, fibrin, blood, inflammatory materials, or fibrosis itself, maybe an organized neovascular membrane. And the problem with us looking at SHRM as a biomarker is that its composition can change over time and with treatment. So it may regress, reappear, and when it reappears, it may reappear as fibrosis. So really, it has got a poor prognostic indicator, whatever way we look at it. And especially if it's foveal involvement or there is greater thickness and larger horizontal extent with high reflectivity suggesting onset of fibrosis with disruption of EZ, ELM, and persistent over multiple scans and serial scans. The next one is hyperreflective foci. It was mentioned in diabetes already. In AMD, it may not be due to exudates, so it's likely due to inflammatory or dead RPE cells. Again, persistent hyperreflective foci or extensive one suggest that it's severe disease biology with worse visual prognosis with high risk of fibrosis and atrophy. To be frank, I don't look at this hyperreflective foci when I manage neovascular AMD. I think there are more important features that are important for us to judge retreatment criteria. The other worst, and we have a lot of idea about outer retinal tubulation. Clinically, we should differentiate that from intraretinal fluid because outer retinal tubulation is, of course, a bad prognostic indicator with photoreceptor rearrangement with the boundary like that. It has poor visual recovery, and do not try to drain this outer retinal tubulation away because they don't go away. So it's important to differentiate between outer retinal tubulation and intraretinal fluid. Other conditions like CNV associated PXE, etc., can also result in outer retinal tubulation. Here, I recommend a review article with Pandya, who has got all this pictorial representation of these biomarkers, which are quite useful. Next is multi-layered pigment epithelial detachment. You do see this type of lamellar band, making it a fusiform PED. These are, without fluid, these are suggestive of stable neovascular AMD, very less likely to rip, and it suggests that this eye is going into fibrosis. However, if they are associated with a pre-choroidal cleft, as you see here, they have poor visual prognosis because they are likely to tear, RPE tear, and subretinal hemorrhage, quite common because of the contraction of the fibrous tissue. Choroidal cleft itself can regress with treatment, but the fibrosis would not. Another sign is the onion sign that we see with the PEDs. Mukamala was the first to describe it. They are like onions in the fibrovascular PED, which suggest of cholesterol crystals, but it's very rare. This only seen in about 5% to 7%, but it is a sign of disease activity. So when you come to PED in the presence of PCV, there are many things you look at for diagnosis. I've already described that: peaked PED, multilobular PED, etc. But what is the metrics that is associated with prognosis in PCV? It's actually a larger PED with extension of more than 1,000 microns or a height of more than 400 microns are high risk because these are suggestive of the need for recurrent reactivation, a lot of treatment, and poor visual outcomes. Otherwise, in all neovascular AMD, the risk of RP is high in patients with large PED, height more than 400 microns, large PED surface area with wrinkled RPE, irregular PED notching, presence of fibrovascular PED, and of course, if you see the stretch lines or folds on the OCT suggestive of tension on the RPE, and a small ratio of the choroidal neovascular membrane to the size of the PED is also a risk factor for RPE tear. Also mentioned prechoroidal cleft as a risk for RPE tear. The next is OCT predictors of macular atrophy. Here, I've given you a whole lot of predictors. So if it's a RAP lesion, fibrovascular PED, intraretinal fluid, large MNVs, SHRM, baseline subretinal drusenoid deposits or drusenoid PED, and thin choroids. I mean, these are all a phenotype that we know will go into atrophy. And fibrosis, I mentioned SHRM already, but SHRM, these type of lesions are more seen in type 2 MNV or large MNV with chronic exudation and a sign of delayed or inadequate treatment, and also end up with worse. They start off with worse baseline visual acuity, end up with poor visual prognosis as well. The big question is, okay, we can know all this, but what is the relationship with visual acuity? So if you see a patient presenting to us with poor baseline visual acuity, they are invariably associated with intraretinal fluid, subfoveal ellipsoid zone loss, SHRM, fibrosis or atrophy, and most importantly, subfoveal hemorrhage. So they know that these patients do have poor visual acuity prognosis. There are other entities that are published like subretinal transient hyporeflective small oil-like globules. These are very rare. About 4% of patients will have it. They respond very well to anti-VEGF therapy. They seem to be just a small bubble of fluid. Bacillary layer detachment, ballard, can also occur in AMD. Again, it is due to splitting of the photoreceptor layers. The ballard itself may respond very well to anti-VEGF treatment, but the prognosis depends on its duration and the associated fibrosis, hemorrhage, and loss of ellipsoid zone. Very rare in AMD. PCV, I already described, we do need multimodal imaging, but that's where OCTA comes in. We know more about OCTA in AMD through PCV. Previously, we used to call it branching vascular network. Now the APOIs renamed it as branching neovascular network. It's a lesion area with low flow density. They have come up with this stick type BNN, which suggests that they have thick choroidal thickness and thick subretinal fluid with a high risk of recurrence, but good visual acuity. When we look at clinical utility of our biomarkers for PCV, of course, we go straight to the choroid. So they usually, those with low CVI or choroidal vascular index, or large choroidal vascular diameter or choroidal thickness of more than 300 microns, high PED volume, and flow voids are all suggestive of risk of recurrent fluid and requiring a lot of injections, probably PDT as well. Coming to OCTA biomarkers, from all the reports we know of in this field, The prognostic indicators depend on the MNV size, branching complexity, vessel density, the maturity of the trunk vessel, choriocapillary flow deficits, and perilesional halo. I should say we don't use this at all for our assessment, except at diagnosis. We look at whether there is a presence or absence of OCTA, evidence of macular neovascularization. We don't go any further than that at present, although there are quite a lot of reports suggesting that perilesional dark halo is a suggestion of activity and extension of MNV over time. OCTA biomarkers of poor prognosis. Again, this is from reports. We don't usually use it. A large MNV area with high branching complexity, with flow deficits and choriocapillary impairment. And of course, some dead reappearance suggests that the lesion is very mature. So in conclusion, we do have a lot of baseline OCT biomarkers that predicts visual outcome, but a recent meta-analysis done by Varun Chowdhury's group suggests that most of this, if done using systematic review, they have low certainty of evidence, and the best ones that could be taken forward are intact ELM and EZ, suggest good prognosis, presence of IRF, and especially if it's in the foveal center point and SHRM, are the poor prognostic indicators. The conclusion of that paper is improved standardization of biomarker classifications required because several confounding variables are present. Thank you very much.
Thank you, Dr. Shobha. Again, a very comprehensive and fabulous talk. Amazing review. Since this is called Biomarkers or Mirage, out of all that you presented, which one would you say are like, sometimes things come into literature, as Dr. Vishali alluded to. So I just picked out a couple. The subretinal, transient hyporeflectivity. Could they just not be another word for, IRF cysts popping up and then going back? Would you say something like that?
They are extremely rare. That's why I said it's about 4% of patients. They respond very well to anti-VEGF. It's just a description coming up with people.
Yeah, exactly.
People like to
I think
describe
that's
put
something
on
we
the-
want to debunk also. And now, the big question always is, and it always comes to this, is how about, tolerating subretinal fluid? And you mentioned that compared to IRF, of course, it's a better thing to have. But then, what is your take on this? Would persistent subretinal fluid for some period of time with, say, vision reasonably okay, would you consider switching to a stronger anti-VEGF agent, or would that determine you moving to that? And I'd like Dr. Hemant Murthy's take on that also. Yeah.
So for subretinal fluid, usually if it is present and it's not going away, I make sure that we do 3-monthly dosing of any anti-VEGF, especially aflibercept 2 milligram, to see whether it will disappear or not. Only then we move on to aflibercept 8 milligram or faricimab. We have very little evidence that that's going to dry the macula. Of course, with all the clinical trials, it does show that the longer durable agents have better, faster, longer drying effect, but not necessarily the case in clinics, right? So my stepwise treatment would be to make sure they have monthly treatment first and then progress to the next line of treatment.
Dr. Hemant, if you see some persistent subretinal fluid, a lot of us look at it, bounce off that fluid trial. Many people do not agree with that. What is your take, Dr. Hemant?
No, I've had patients who have, continue to maintain good vision. Now, let's say I've treated them initially, and that's the maximum that it reaches after, let's say, 3-4 injections. Then the patient, is asymptomatic and feels that there is no change in vision. I do observe them for some time because it doesn't seem to affect the vision much. And if I find that there is, like what Dr. Shobha did mention, that increasing SRF or there are other clinical signs or vision change, then I would again.
No, what I meant is, given that we have newer anti-VEGF, stronger, more potent ones, suppose a patient has that, 100 micron of subretinal fluid staying there, he's decent, he's happy, 618, 624, but he's been there like that. Would you think of trying out a newer, strong
So
anti-VEGF to
this
get
would
him
be
to
this
612?
would be with
Just wipe
like
it
what
out?
she did mention. This would be with aflibercept or some equivalent drug, because it's not that I would look at this in a let's say ranibizumab or bevacizumab, I would first do that, and if I find that the response is as much as that is there, then I think I would observe. So it would be with a better anti-VEGF or a stronger anti-VEGF. But then in India, because of cost constraints, we always are restricted in our practice to, not offer a much higher like faricimab or anything, because then the patient is always worried about the cost that comes into play. So rather than this, suppose there is SHREM, then I would really be a lot more aggressive in my treatment. And
Absolutely.
I would ask Dr. Shobha if that, let's say, presence of SHREM, does it make you go for, let's say, faricimab or aflibercept 8 milligram to begin
I
with?
mean,
Because
to initiate treatment, we always use aflibercept 2 milligram because we use 2 milligram biosimilars here. We of course start with that, and we know that 50% will resolve, but the other 50% persistent. So I would not wait beyond the loading phase. If the loading phase, after the loading phase, the SHRM is still there, then yes, switch over to either faricimab or 8 milligram. Yes.
So, but
Yeah.
can I ask a question, Anand?
Please.
Are you using brolucizumab in your practice? Because there are reports from India as a first line, no side effects in Indian population and all. So, Shobha, are you still using it in your practice, either in recalcitrant? And I think treatment now is already out, as you mentioned.
We don't use it at all, Vaishali. We don't use it even for recurrent cases. We have enough of drugs to use. We do not want to use one with such a adverse event profile. So, yeah, we don't use it at all.
Thank you.
Yes, Dr. Mona, you want to ask a question?
I basically wanted to ask, when we have persistent subretinal fluid and we are using that as the biomarker, how many would choose to image further, like look at the octa picture, is the membrane growing, or do a fluorescein, or because sometimes, especially when we have the subtype of pachychoroid neovasculopathy, and then you do an FFA, you find there's a CSR leak coming there. So I think if we are looking at, do we switch or do we do something, I think we may need to image a little further to see if the disease is still active or growing before we change.
That's a pretty
That's
good
right.
idea. Frankly speaking, we don't do any of that, but it's a good practice to take away. Yeah.
And also, just an aside there, all of us are doing a lot of OCT angiography. If you find a lesion which is otherwise stable and clinically the fluid is not moving, there is some amount of fluid, but you notice on the octa that the vascularity is increasing. There is a little more of the twigs coming up. Would you then, and the patient is absolutely proactive, he wants to improve, but you feel the patient has been stable. Would you again push for a stronger anti-VEGF or a more proactive treatment regimen if you see activity on the octa, but not so much on the structural OCT?
Yeah. Again, we don't use OCT regularly in the clinic. We use it only for diagnosis. But I would say if you see the small blebs coming, small bubbles of new vessels coming on the side, it is definitely a sign of reactivation. So I would definitely want to be very aggressive with that patient. Not necessarily change, but make sure we do monthly treatment for those patients to ensure they disappear. But that's based on my knowledge of reading papers. In clinic, of course, we don't do OCTAs on all our patients. Yeah.
And I'd just like to bring Dr. Adnan also in this, if you're there, Dr. Adnan.
Yeah.
If you see intermediate AMD, the patient is quiescent, and then there's a little bit of subretinal fluid coming up, you do not see any change on the octa. Otherwise, would you then be a little more proactive towards, a more aggressive regimen? You don't see any neovascular network on the octa. This patient has drusense, has little now SRF coming up. This is again a bone of contention area. How would you approach these?
So you're treating the patient. So first of all, octa has a limit of detection. So the question is it exudative non-neovascular AMD, or is it neovascular AMD, but you're not detecting it on your octa? The problem is these are usually RPE elevation. So if you did a fluorescein or an ICG, unless you see a frank net, it'll probably be speckled hyperfluorescence, and it often doesn't separate the two. So it comes down to symptoms, what happened to the other eye. If they're relatively asymptomatic and it's not changing much, I would observe, tell the patient they have a much higher risk of converting to CNV, and monitor it, and I may repeat different angio-CTs. If they're symptomatic and getting worse and I can't detect anything and they've had CNV in the other eye, I sometimes do a therapeutic trial. And if it doesn't, saying that there may be a limited detection, and if they don't respond to that, then I pause treatment, but warn them, even though it's not responding now, it may respond in the future, and obviously exclude other mimicking conditions like CSR or polypoidal. Yeah.
Thank you.
You're muted, Anand.
Oh, sorry. So I now invite Dr. Jay Sheth to give his talk on unpacking pachychoroid, telltale biomarkers of relevance. Jay, take it away.
Hi, so good evening, everyone. So it's a pleasure to be here today and speaking on this very important topic of pachychoroid. So let us just begin with the basic concept. Pachychoroid is basically fundamentally a structural abnormality of the choroid, and the hallmark is, of course, the presence of these dilated choroidal vessels, what we see on the EDI, OCT in all of these patients. And along with that, there is choriocapillaris compressions and even compression of the hairless layer, and this compression actually leads to a localized ischemia in all of these eyes, along with development of RP stress, which can actually manifest as either the pigment epithelial detachments or the double layer sign, and subsequently even the development of neovascularization. So important point here is that pachychoroid is not defined only by the choroidal thickness, but also by the morphology of the choroid. So once we actually start recognizing this thing, we begin to see the entire spectrum, right? From the pachychoroid pigment epitheliopathy to the development of CSER once the fluid starts developing. And onto the other extreme, of course, there's those neovascular conditions like the pachychoroid neovasculopathies and the PCVs. And in between, of course, we see those CSER changes in the peripapillary areas, that is more known as the peripapillary pachychoroid syndrome, and the focal choroidal excavations. So multimodal imaging is key for the diagnosis in this, and the essential diagnostic actually includes a good color fundus photography for documentation, a good enhanced depth imaging OCTs and fundus autofluorescence, and the ideal complete examination also additionally includes the OCT angiography, a fundus fluorescein angiography, and an ICG angiography. So we'll go through all these modalities one by one. OCT, of course, is the gold standard in this entire spectrum of disease, where, as we spoke earlier, we can see these large hyporeflective lumen dilated hairless vessels with compression of the inner choroidal layers and also the choriocapillaris. And also along with that, there is super added RP changes that develop in the areas just above it. Next, coming to fundus autofluorescence, it's more useful in patients with CSC, where in acute CSC, we can see this presence of central hyporeflectivity surrounded by a ring of hyper, whereas in patients who have chronic CSC, we can see this variegated RP changes and also the classic track marks that is there in all of these eyes. FFA, of course, very useful in patients with non-dissolving CSE, where we can actually see this focal expansile dot leakages or even the presence of the smokestack pattern. Now, one very important factor which Dr. Munna also spoke about, patients who have a non-dissolving SRF, and if we are treating the patient with anti-VEGF injections, always very important to do a fluorescein angiography in these patients because it's an entire spectrum. So you may have a patient of pachychoroid neovasculopathy and who may develop active CSCR leaks also. So identifying these leaks and just doing a focal laser could be a very good thing for all of these eyes. Now, ICG also remains a gold standard for the choroidal assessment, and here we can see key features like these dilated vortex veins, The dilated vessels can be there at the posterior pole and in and around the peripapillary areas. One classic feature is the presence of mid-choroidal hyperfluorescence, and that actually corresponds to the areas where those Pachy vessels are present, and usually the focal leaks of CSR or even these polypoidal lesions for which the ICG still remains gold standard are usually detected in these areas of mid-phase hyperfluorescence. And of course, when you are planning PDT, ICG is mandatory. OCT angiography very useful for early detection of these networks that is over there. Sometimes you may have a patient with a shallow double layer sign, absence of any fluid, but if we do an OCT angiography, we can actually detect a macular neovascularization in this area. So, with this, we had published a very important paper. I think Dr. Shobha was a part of it, where, we looked whether OCT angiography is required for all of these patients. So it's very critical to see the reflectivity at the DLS. So if we see a hyperreflectivity in between the DLS, it is highly suspicious of a macular neovascularization in this eyes. Whereas if it is hyporeflective, it could be just a presence of CSR in this eye. So looking at this reflectivity is very, very critical. Now we'll just go through multimodal imaging in each of these disease entity. So pachychoroid pigment epithelopathy, it actually represents more of a form fruste part of the pachychoroid spectrum, where all the classic features of pachychoroid would be there on the OCT, and along with that, the OCT Bs can also show presence of these RP irregularities. FFA will usually show a mix of window defects that corresponds to these RP lesions, whereas the ICGA features remain the same throughout the spectrum of mid-phase hyperfluorescence and along with dilated choroidal vessels. Next, of course, comes the CSR, and once this development of subretinal fluid starts happening in this patient with acute CSE, and in chronic CSE, we can see those telltale OCT biomarkers of intraretinal fluid also. On an autofluorescence, we see these classic track marks, and on fluorescein angiography, there would be corresponding window defects in that area of those track marks. And this area, if I look at this mid-phase hyperfluorescence over here, it classically shows those presence of mid-phase hyperfluorescence in these areas of these dilated choroidal vessels. Next, of course, when we see these similar changes developing in and around the peripapillary area, like there is the patient had an SRF in peripapillary location with an underlying Pachy vessel, and even an ICG beautifully illustrates the presence of these Pachy vessels. So this is a classic PPS. Whereas a patient with a focal choroidal excavation, it's more of a development of an inverse pigment epithelial detachments that we see over here. And usually we see corresponding Pachy vessels also in and around that location. Now, one very critical factor, we have to look at multiple B scans to recognize this entity, and also very critical to do an OCT angiography because many of these eyes may harbor a macular neovascularization that corresponds to this location. Now, of course, next is the pachychoroid neovasculopathy. And the here very important thing is, as the pachychoroid progresses, the entire spectrum progresses, the choroid may keep on thinning, but at the same time, the presence of Pachy vessels is never going to go away. And for all these patients and a hyperreflective DLS, if I am seeing, I do the OCT angiography and it beautifully shows the network. And of course, the last part of the spectrum is the development of the polypoidal choroidal lesions, for which the OCT, of course, remains the gold, the ICG remains the gold standard. And I can see these polypoidal lesions within the first 6 minutes of an ICG angiography. OCTA may be less sensitive for detecting that. No, Dr. Shobha definitely touched upon this a little bit. So how do you differentiate between them, PCV and NAMD? So presence of these sub-RPE ring-like lesions, what we see in all of these eyes on an OCT is one of the classic major criteria for detection of an PCV. The second, of course, we look at the on-fast OCT complex where we see these hyporeflective areas corresponding to the PEDs. And this hyperreflectivity is the DLS that actually goes and connects the pigment epithelial detachments. The third is, of course, the presence of the sharp PEDs over here that is there, and that actually corresponds to classically the presence of those polypoidal lesions over here. And this angulation is usually more than 70 degrees. The minor criteria, of course, includes the presence of this shallow irregular PED or the double layered sign, the presence of increased choroidal thickness, and as well as in the last is this complex or multilobar pigment epithelial detachments in these eyes. So this is how we actually differentiate between PCV and NAMD on an OCT. So next, of course, do we do OCT angiography for all the patients? Yes, it is required, and especially for detection of BNN, where it is much more sensitive as compared to an ICG angiography. Whereas when we actually look at polypoidal lesion, this is on the left side, we see this beautiful polyp over here with those tentacle-like networks. But when I actually do an OCT angiography, I can see the network, but the polypoidal lesion is not seen because the detection rate is usually very low. So, this is my imaging algorithm that I follow for all of my patients with pachychoroid spectrum. The first very critical thing is to do an EDI OCT and assess the entire choroidal morphology, look for those pachy vessels. Very important to look at all the B scans to identify the presence of the flat irregular PEDs at different sections. It can be away from the fovea also, and look for the focal choroidal excavations. If I see a DLS, it's very important to do an OCT angiography to actually recognize the presence or absence of macular neovascularizations. And once that is done, if a patient just has a suspected networks or if there's a suspected CSE, very important to do a combination of both fluorescein as well as ICG angiography to look for further evaluation. And based on what we find, we can beautifully get the entire diagnostic outputs for all of these patients. So just to summarize, I think pachychoroid should be thought more of a structural as well as a vascular choroidal pathology and not simply a thickening of the choroid. And the entire different NTCs that we discussed, right, starting from PPE to CSE to even neovascularizations are different manifestations of the same disease process. And second key message is, of course, multimodal imaging is very, very important in all of these eyes. OCT gives beautifully the structure. OCT angiography shows us about the neovascularizations, and ICG shows the classical choroidal hyperpermeability and also the presence of PCVs. So, and finally, recognizing all these important biomarkers like pachyvessel on an OCT, DLS on an OCT, and even a type 1 macular neovascularizations on an OCT angiography helps us to identify the progression in a very early stage and make more informed treatment decisions. So here are my references, and thank you very much for your patient listening.
Thank you, Jay. That was a great talk, very comprehensive, covered a large area, large spectrum. I'd just like to bring in Dr. Shobha and Dr. Adnan. You have access to, swept source and higher end imaging. Would you say now your practice is moving away from conventional, ICG based practice? Because this is one area, pachychoroid, where, traditional angiography, in terms of basically ICG and even fluorescein angiography has a little more of a role. But with your access to higher end imaging, swept source specifically, and the plexelite systems also, are you doing more of that and delineating these polyps and BNNs better?
I can go first.
Yeah,
I mean,
please.
we still are highly dependent on ICG. So we still do multimodal inclusive of ICG to determine treatment for CSR, polyps, everything. So we are still new to OCTA. And as Jay just mentioned, the detection rate of PCV is very low in OCTA. So yes, we may see the BVN, but that doesn't give us any clue about how to treat the patient.
All right. And Dr. Adnan, again, bouncing off something we spoke about in your talk earlier, Jay mentioned that for where you have these FIPEDs or these little RP elevations, how much do you really rely on flow signals to determine neovascular activity under that area of RP vis-a-vis, he mentioned hyporeflective space for CSCR. So where does that biomarker, this flow signal kind of biomarkers have a role now?
Yeah, so I think it's very difficult because ultimately, when you want to say how good OCTA is, you need a gold standard. And I would almost argue the gold standard now is OCTA, and I think it's probably more sensitive than other forms of angiography. There are structural suggestions of if there's flow in there. So obviously, double layer sign, multi-layered PEDs will suggest you've probably got polypoidal in there. If it's irregular reflectivity of medium reflectivity that's irregular, often it suggests the type 1. So that increases your index of suspicion to do further investigations. But I really think OCTA is now really the default for detection. As Shobha said, that ICG we still use it to guide where we do photodynamic therapy, but I think structural plus angio-CT swept source pretty much tells you what's going on. I don't think it's that great for telling us at this point about hyperpermeability, but I think we're developing data sets that may eventually replace ICG, but I think that may be a couple of years away.
Okay. Yeah, Jay, go ahead.
Yeah, so just one very important. So one point which I actually didn't touch upon is all those polypoidal lesions with and without choroidal hyperpermeability. So you may have a leptochoroid along with a polypoidal lesion, and so they will usually not have hyperfluorescence on an ICG. So those are not good candidates for a photodynamic therapy. Whereas if you are doing an ICG showing a choroidal hyperpermeability,
Yes.
usually they will have a thickened choroid. So those are ideal candidates for doing a PDT, and they may respond much better as compared to just an anti-VEGF therapy.
Yeah, and also just very quickly, since you touched upon that very important point, Dr. Muna and Dr. Adnan, uh, pachychoroid, it's more about the vascular component. So I think the CVI, which Dr. Shobha had touched upon, isn't that, would you say that is a more critical indicator of, activity need to treat rather than just pure choroidal thickness? So what would you say, Dr. Adnan? Do you look at
Yeah,
that also? Yeah.
Yeah, so I completely agree. I think we still don't have great metrics of normal choroidal thickness, and you have patients with remarkably thick choroids that don't have dilated vessels, that don't seem to be prone to getting, pachydraes or complications of associated with pachy vessels, and it's the dilation and that seems to be the driver. What would be great going forward, and now that we've got these great swept source imaging systems, that hopefully we'll get some automated quantification that will really help with that and better normative data sets. And I think hopefully we all pool our data, we'll get there. But agree with you, it's the dilated vessels, not the absolute thickness.
Dr. Muna, any comments there?
Yeah, I think sometimes, as everyone said, we get a surprise. You look clinically and you see those dilated choroidal vessels, and you do your OCT, and the thickness is much less than what you expected. But probably I would lean towards looking at the hyperpermeability on ICG as something which tells me in which direction I'm going in case I'm in doubt.
Based DR grading system. And I thank you for your attention, and I welcome your questions. Thank you.
Yeah. Thank you, Dr. Sani. That was such a fabulous thing. I think there aren't many questions. Most of us are gobsmacked with all the futuristic stuff that you've shown us. I'd just like quickly to get Adnan in. I know you're one of the high priests of AI and a big fan of big data. What are your takes and comments on this fabulous data that research
Yeah,
that Dr. Sandy has, shown us?
So Sani, wonderful work. I think many people feel that OCTA is the way to go, and as you really nicely highlighted, the problem is longitudinal data. The longitudinal data, and the problem is OCTA is evolving.
Yep.
And so, there is a wonderful study led by my colleague Ramin Tadioni, sadly passed away, which I'm on the steering committee of, which it has swept source OCT with several years follow-up with all the other markers. I think that'll be the first really good longitudinal study that is reading out at the moment, and that has AI already in. So I think that really is going to help us all in how we understand this. Little comment on your original study where you compared wide field OCTA sensitivity to color. Now, I'm without a doubt, I'm sure OCTA is much more sensitive. One of the issues with your comparator is that I think the color wide field that you used from a study in southern India is not as sensitive as other color imaging. So you're comparing it to a very insensitive wide field color image that we already know is not great at dermis and new vessels and picks up low level of disease. And I think the other thing going forward that I'm really interested in is from the NHS is what is the most cost-effective solution. I have absolutely no doubt that ultra-wide field angio-CT is absolutely the answer. The problem is it's not cheap enough, and how we can utilize this cost effectively. But wonderful work. I really enjoyed listening to it. Thank you.
Yeah.
Thank you
And
so much. Comments. Yeah.
terrific work, Sandy. I think you've not left me too much to ask for. Just that little alarming piece of message that 10% of NPDR was actually PDR. That is that's something to really think about. And yeah, we'll take a little more questions then. We just in the interest of time, let's move on. Let's have Dr. Anirudh's talk. Pranav, can you share that?
Yes, sir. Yes, sir. Sure.
On OCD biomarkers in uveitis. Yeah.
Hello, my name is Anirudh Agarwal, and
Can
at
you
the
hear
outset,
it,
I
sir?
would like to thank the leadership of
Yes, yes, we
AIOS
can hear.
and the program director for this session of International Ophthalmic Conclave, Dr. Anand Rajendran, and the chairperson, Dr. Vishali Gupta, for this kind opportunity. It is my pleasure to present to you OCT biomarkers in uveitis. Over the next few minutes, I will be going over certain biomarkers in inflammatory disorders, including cystoid macular edema, biomarkers in the vitreous, inner retina, outer retina, and the choroid and the choriocapillaries. We all use OCT very commonly for the management of cystoid macular edema. We know that cystoid macular edema is a marker of active inflammation and can be present when the patient initially presents to you, be it anterior uveitis, intermediate uveitis, or posterior uveitis, and of course panuveitis. CME also suggests ongoing inflammation and can be associated with subclinical inflammation or recurrence of the disease. Sometimes intraretinal fluid can occur without CME in presence of inflammatory lesions. Let's look at some of the cases. This is a classic case of an acute presentation of Behçet's disease uveitis, where you have significant inflammation on the fundus picture, and the fluorescein angiography also shows you significant leakage as well as posterior pole periphlebitis. You also have partial thickness inner retinal infiltrates, and these are very easily seen on the OCT as inner retinal hyperreflectivity. And you also have retinal thickening, intraretinal fluid, and subretinal fluid. This is a classic inflammatory presentation with macular thickening in Behçet's disease. You may also have the classic cystoid macular edema along with intermediate uveitis. For example, in this patient where you have a classic pattern of CME along with optic nerve head pallor, and this is the usual CME that we look at in patients with uveitis, and we treat them with local and systemic therapies. The other important aspect of OCT determination of inflammation is vitreous inflammation. An assessment of vitreous for hyperreflective dots, which represent cells, is important in the evaluation of posterior segment inflammation. And nowadays, using third-party softwares, we can quantify for objective measurements from the vitreous inflammation. These are few examples of how the vitreous may be involved in viral disease. These are patients of cytomegalovirus, where you have different patterns of presentation. You have nebulous vitritis, you may have volcanic eruptions which are settling on the retinal surface, and you may also have a retinoschisis like picture where you have a clear premacular bursa and significant inflammation in the layer above in the middle of the vitreous cavity. Besides the vitreous inflammation that we see in viral disease, you may also have these pre-retinal precipitates, and they may form stalagmite-like deposits or such irregular clumpy deposits, especially inferiorly, and these are well known in patients of toxoplasmosis and Behçet's disease. You may also have this volcanic eruption sort of a pattern along with inner retinal hyperreflectivity, and this is again commonly seen in patients with toxoplasma. We have published involvement of the vitreous cavity and the inner retina in a series of patients with fungal endogenous endophthalmitis, where you may have the rain cloud sign, where you have the inflammation almost bursting into the vitreous cavity. There are various retinal biomarkers, and often you may have full thickness or partial thickness involvement of the retina, due to the invasive organism. So these are examples of patients with full thickness necrotizing retinitis, which appear as hyperreflective full thickness retinal lesions along with vitreous inflammation. And these are classic in patients with viral disease. These are patients of herpetic disease presenting with necrotizing retinitis. So they are full thickness, necrotizing, and usually there is no involvement of the choroid. In these patients, you may also see these vertical lines in intraretinal, and they have been postulated to be the paths by which the virus proliferates and enters into the retina. Viruses may also involve the choroid. Again, these are to show you the various vitreous involvement in cytomegalovirus. And if you look at the neurosensory retina in cytomegalovirus or herpetic retinitis, especially in the periphery, you may be able to detect retinal breaks, peripheral retinal detachments in patients with viral disease, and OCT plays a very important role in determining whether it's a retinoschisis, a retinal detachment, or there is an impending retinal detachment. Toxoplasma can also be identified very easily by a full thickness necrotizing retinitis along with choroidal involvement. You see a very hyporeflective homogeneous choroidal involvement. On the other hand, you may also have a patient of lymphoma presenting with these diffuse dome-shaped elevation with thickening and disorganization, which is usually reversible when these patients are treated with chemotherapy. This is another patient just to show you the contrast of patient with fungal endophthalmitis where you have a rain cloud sign and macular lesions with significant backshadowing. This is a patient with toxocara retinal involvement. This is a granuloma, and you can easily see the strand which is connecting the retinal granuloma to the optic nerve head. A few slides on the outer retina, RP and choriocapillary biomarkers seen on OCT, and we often know that outer retinal involvement is very frequent, and detailed analysis of the RP and outer retina can be performed on OCT, and you can also see the resolution of these lesions by serial OCT. So these are patients of choroiditis. As you see here, when the lesions of choroiditis are active, they usually present with outer retinal hyperreflectivity along with subretinal deposits and disruption of photoreceptor layers. When these lesions tend to heal, they appear as knob-like elevations of the RPE along with persistent focal disruption of the ellipsoid zone, external limiting membrane, and there may be associated atrophy of the RPE and Bruch's complex. Often, the complete healing is accompanied by atrophy of the outer retinal layers, persistent disruption, and RPE loss. And you may also have choriocapillaries ischemia or loss. Let's look at another case of multifocal choroiditis and panuveitis. As you see, this patient presents with retinal lesions, and on OCT you have a fuzzy infiltration of the outer retina, and you have involvement or disruption of the Bruch's layer as well. If you look at the fluorescein angiography of this patient in the early and the late phase, it's not very revealing. You really don't know if there is an inflammatory damage or if there is a choroidal neovascularization. In these patients, OCT accompanied by OCT angiography is very helpful to look at the flow along with fuzziness of the outer retinal layers. This is highly suggestive of an underlying choroidal neovascular membrane. Finally, choroidal alterations are very common in patients with choroidal granulomas that occur in patients with TB, ocular sarcoidosis, and VKH disease. The involvement of the choroid is best assessed, of course, using ICG, but you can also use enhanced depth imaging OCT and swept source OCT and follow these lesions serially. This is a classic example of a very large choroidal granuloma associated with TB, and these patients usually present with subretinal fluid and infiltration of the outer retina, which distinguishes it from sarcoidosis. These are examples of sarcoid choroidal granulomas, which are more rounded, more localized, without much undulation of the RPE, and there is hardly any fluid or exudation. When we talk about the choroid, we must not forget about VKH disease, and VKH disease is characterized by deep-seated choroidal granulomas that appear on ICG. And if you look at the OCT findings in these patients, they present with compartmentalization of fluid, what is called as bacillary layer detachment, and they may also present with significant amount of subretinal fluid accumulation and choroidal granulomas in the deep choroid. With this, thank you very much for the kind invitation, and I'm happy to take any questions. Thank you.
Thank you, Anirudh. Anirudh, you're here. Can you hear us?
Yes, I'm here.
Oh, right. Okay, he's about to take off. So, Anirudh, the one very curious thing which I noted, and it's an interesting biomarker, was what you showed us about those vertical lines in acute viral infections. So, do you see them increase? Do you look upon them as prognosticators of increasing viral retinitis or non-response to your treatment? Do you use those? Because that's something very interesting.
No, so that's an interesting finding that we saw on OCT, and honestly, it's more of a pathophysiological finding rather than prognostic. It's a finding which we see in patients with early onset viral retinitis. And so we don't necessarily use it for prognosis. I haven't seen it in patients, for example, with worse disease, there are more lines.
Yeah,
I haven't seen that. It can happen even with very small lesions, which respond very well to treatment.
Okay, okay. So, Mudit, do you have any questions for Anirudh? Your comments on his talk? Excellent as
No,
usual.
I have no questions, but any as usual, a great talk and very nicely shown. In fact, OCT and OCT angiography have become so valuable in a lot of these cases. Like the question that you asked, sir, in terms of the vertical lines, it does not have a prognostic significance, but it's got a very significant diagnostic significance in terms of the fact if you have got a lesion with those vertical lines, it's a very nice clue to the fact that you are probably dealing with a viral retinitis rather than a toxoplasma. Similarly, we had
Okay.
done some work. We were trying to look at hyaloids getting adherent. So you see hyaloid getting adherent in a toxoplasma lesion, but you don't see them happening in viral retinitis. So there are multiple clues with which OCT now comes to our rescue, not only in understanding what's happening, but in arriving at specific etiological diagnosis. Syphilitic, acute syphilitic posterior placoid choroidititis again has got an absolutely characteristic OCT appearance. So you just need to probably look at it and you will be able to make a guess that you are dealing with ocular syphilis probably in a lot of cases. So the way OCT has started working or OCT angiography, like a lot of these are absolutely true biomarkers in the true sense in terms of the fact that you can use them to not only determine what's the layer that's getting involved, but even specifically arrive at etiological diagnosis in a lot of these cases.
Yeah. What is your comment on, using, see, uveitis is not a place where, intuitively people think of OCT because, media is very hazy and very often in these cases. So again, in certain pathologies, it may be even more relevant and both of you also mentioned. What about white dot syndromes? Where do you use OCT? Because that's relatively clear media. How often do you look at the chorea capillaris, differentiating nudes from the others?
Yeah.
So generally, we now avoid using the term white dots. And what we try to do is we should really identify each disease by its original name. And what we look at in the OCT, if you pass through the lesions, generally we look at the involvement of the choriocapillaries and outer retina. For instance, if it is a Mude's lesion, then changes in the outer retina and normal choriocapillaries appearance on OCT and OCT angiography is highly suggestive of Mude's. Whereas if you have a placoid lesion, which is primarily involving the choriocapillaries, you're probably looking at an MP or infective variant, which is a pigeonous placoid lesion. And of course, you depend on the labs as well. And multifocal lesions, going by their phenotype, looking at the focality, looking at the number of lesions, size of lesions. And, generally they have this punched out appearance and punched in appearance on OCT as they heal. So that itself, is very characteristic. The findings on the OCT are highly suggestive of the disease.
Yeah.
Dr. Hemant and Dr. Muna, any questions for Anirudh? Comments on his talk?
No, great talk. I think I know that nowadays I don't do my primarily much of uveitis, but do know my colleague increasingly is using OCT and OCTA and in the diagnosis. So I do understand that there is now a way to say that this is the probably the diagnosis. So I think it's helping us in more in the etiological diagnosis or separating the two confusing spectrum. That's it.
Okay. Okay. So, any questions in the chat box that we need to take, Pranav? And
No, sir.
no, not
No,
really.
no, no,
Oh,
no.
okay, then I think we're over time. I think we've had a fabulous session. I'd like to thank all the speakers, especially Dr. Adnan, Dr. Shobha, Dr. Sandy for staying late, and Anirudh who's about to step into his flight,
Thank you.
and Jay. Yeah, thank you, Anirudh. I can see you're in a nice airport around. So good luck there, and thank you, everybody. We've had a fabulous session. I've learned a lot. I hope you've enjoyed this as much as I have moderating this. Thank you, everybody. I think our coordinators need us to turn all our videos
Yes, sir.
on.
Yes, sir.
Yes, is it true? Yeah, okay then. So
Turn
you
on the
need to,
camera and smile, sir, for the camera,
yeah,
for a picture
yeah,
of the session.
yeah. Make this a good image.
Sure, sir.
Yeah. Okay. Got
Okay,
it?
sir. Yeah.
Okay. Thank you, everybody. Thank you so much. And thank you to everybody who's been watching it. Thank you, Dr. Adnan.